Good morning. Want to welcome everyone, and we have an amazing course today. And Jens and I were just talking. I can't believe we've been doing this for 15 years. 14 years, sorry. And it's amazing because Jens came over in 2014, and him and I were always kind of talking about doing something like this, and it's been a great success. And this year is no different than the years past. You know, the key, I think, to this course is really the faculty. We have an outstanding group today. And obviously, we can't do any of these courses without our industry sponsors. So I really want to thank Globus, Sentinel Spine, Medtronic, Companion Spine, DePuy Synthes, Bone Foam, and also Therapeutics. And then, you know, today we're really going to focus on our 4 amazing, outstanding faculty members. And there's a reason why it's called, historically we called it the master's course, and that's why we all have green jackets. And this year we kind of put a little different spin on it, and we named it the Legends, because literally the surgeons that are here today are legends, each in their own right. And I get to work with a legend all the time, Jens Chapman. So Jens is going to go ahead and kick us off, and really excited to have everyone here.
Stay right here, Rod. So kudos to all of you for taking the time. We appreciate it. We deeply appreciate our faculty here today. And again, kudos to Rod and the wonderful SSF team to put this together. We want to celebrate the accomplishments in spine care, but we also want to learn from 4 pioneers that took the trek out here. In the past, we had a large faculty numbers here, but we decided to revamp this in this year and basically do it very, very, very simply. We basically invited 4 true pioneers, as I said, and we gave them a simple task. Talk about 2 things that you're passionate about and show us in 1 lab demo what you love doing. That was really all we did. That's all we did in terms of course planning. And I want to point out the global reach of this. I was at the Global Spine Congress in Turkey just recently, and one of the young AO Youth Club people showed this on mentorship. And this is Jean Debussy lecturing here in the master's course, one of the original masters. What you give to others belongs to you forever. What you keep towards yourself is lost forever. I thought this is just fantastic and a great motto for today. So we have the Fab 4 here. The ultimate spine know-how is yours to gather today. And again, you've seen the advertisements. You've seen these absolutely 4 phenomenal people. Dr. Ruti Bertagnoli, dear friend, true pioneer of motion preservation. You hear a lot about alternatives to fusion from Dubai now. He's a dear friend from Straubing, Bayern, and in alphabetic order, left to right. Then Amir Samdani, a visionary pediatric neurological surgeon who has really redefined neurogenic scoliosis care. Dr. Chris Shaffrey from Duke, who has again been one of the defining people in our era of scoliosis surgery and deformity surgeries and so much more. And Dr. Nick Theodore, chairman in the wonderful Banner Institution from Phoenix, who literally is the godfather of robotics. So 4 eminent people. And my personal motto for today, I said it to our excellent graduating class of fellows last night, is, and that's just my personal motto, the greatest room in the world is the room to improve. That's spoken for myself, and maybe we all can learn from that. Without much further ado, shall we get started? Anthony, do you want to change the laptop? Good. So thanks to our 4 lecturers. Thank you all, local and global audience, for being here today. And the room to improve is right here in ours.
Thank you, Dr. Chapman. Okay, Dr. Shaffrey. Okay. You're all set over here.
So I think this lecture is going to show a bit of a tour of memories through the course of my training, which includes some of my time with Jens. And I'm just waiting for this to come up. Do I need to do? Oh, there we go. So basically, I'm going to show you kind of a tour through the years of how things have evolved and the evolution initially through thoracic and lumbar surgery. And what I see is the new kind of evolution that's going to be occurring for better treatment of cervical deformity. And so basically, when I was starting out as a resident years and years ago, we were sort of the tail end of the Harrington rod sublaminar wire era. There was some anterior surgery, but the amount of correction that we got was really very, very poor. And enough so that this was something that I think I wrote in my first year of practice of something that I was somewhat proud of a fairly severe scoliosis. But today, I'm somewhat embarrassed to show this is what was thought of the state of the art, and this is something that I was willing to present at that time. In addition, the surgeries were just inherently bigger because we did not have the corrective capabilities. So we did a lot of ancillary type activities, such as doing an extensive amount of anterior surgery. And many times, I know even when I went to Harborview over to see Jens, there would be something that looked like some giant shark took the bite out of the front of somebody with this huge opening, and the anterior spine flayed apart because you had to do the releases from the front because you couldn't get the correction. Because of the instrumentation wasn't rigid, the fusion rates were far lower, and it was really a totally different world. So the concept came, and it came from our European colleagues, Rudy and others, that potentially the use of thoracic and lumbar pedicle screws, particularly thoracic pedicle screws, was something that could go and have biomechanically a far greater ability to go do three-dimensional correction of the spine and do some things you just couldn't do. So this is a patient, again, of mine with segmental spinal dysgenesis, especially no posterior elements up and down the entirety of the spine. And I'll tell you what was the traditional when I was training is something you couldn't do here. And I remember I submitted this case for presentation, and it was universally, I said it to spine and I said it to 15 places and said, this is insanity that putting all those pedicle screws in is something that is completely, absolutely crazy for you to do something like that. Now, what's happening is that there were some real leaders, and some of these people in the room here were amongst these leaders who gradually said, hey, this is not only something doable, but it's something that is teachable to the general spine public. And this is a picture here. This is, you see as you're going to see consistently, the Seattle Science Foundation logo here. And this is Mike Dobbs talking about safely placing thoracic pedicle screws. And those pictures are from a lab like you guys are going to see later on, showing how to potentially do it. And something that it was so amazingly controversial that, people will put a screw in the thoracic spine, how dangerous. There are going to be millions of people that are literally going to be damaged by this. Spinal cord injuries are going to be rife, vascular injuries are going to be everywhere. But gradually over time, it's been shown that you can go and do this. And this was done in a way, and I put this up with Jens because it was my belief that if you're going to do something, you need to be able to go and investigate it and improve the potential safety or what the risks are. So this was a study of us using navigation versus freehand techniques. Jens and I remember we were down with Julie York and whatnot in the basement doing this on a weekend, doing hundreds of pedicle screws and then CT scanning the cadavers and seeing what it was to show that this was something that was theoretically possible. Now, the fact is that, there are an occasional misplaced screw, but even that screw that you see off to the side, the latter one, that probably really isn't dangerous, okay? Yes, if it was up against the aorta, you might have a question, but the reality of it is a little bit of a miss in the thoracic spine was actually reasonably well tolerated. Even a 2 millimeter miss medially is about the size of the foot of a hook, so that's probably reasonably well tolerated as well. So again, paper after paper going and looking to show the safety and efficacy of thoracic pedicle screws, and what suddenly you found was that by using these tools, you were able to get far better correction and actually truly have the concept of three-dimensional correction that you'll hear Amir and others talk about to be able to reshape the entirety of the spine. And study after study after study showed that the complication rates were really very, very low, and the number of cases which resulted in paraplegia were vanishingly small, fortunately. Not to say that something couldn't happen, but we're looking here at 35,000 pedicle screws, and I think there was one paralysis that resulted from a misplaced screw in that group. There were some other complications, but it wasn't this terror that everyone thought that it was going to be. And when we looked at the analysis, both biomechanically and clinically, comparing hooks or hybrid, where you did hooks in the thoracic and screws in the lumbar, they found that the correction was far better, far more durable, and the fusion rates were far higher with the all pedicle screw constructs. And this is a relatively recent consensus survey done by the AO, and it showed that essentially 100% of pediatric orthopedic surgeons doing most idiopathic scoliosis cases are going to use screws. So this is a transformative new concept that happened relatively early in my career, and something that I was led into by the great surgeon Jens Chapman in front. Now, what's happening when you go and you get adequate fixation into the bone and you can apply much greater forces, all of a sudden you can do some things that you wouldn't be able to do with a hook, including using things to be able to three-dimensionally reshape and realign the spine. And you can see these apical derotators, and using these to go into to derotate the spine. You can do things, and you can see the chest wall. And this is a paper from Professor Sook, showing that not only the amazing correction, but the three-dimensional correction. You can see the chest wall difference between the two is really very, very profound. So basically, using these three-dimensional derotators, and this is a case that I had shown that got published, being able to go and correct the spine. And the only problem with them is I always felt that they were always cumbersome to be able to go do. And I said, look, is there a simpler way to achieve that without all of the these big towers and derotators and whatnot? So I gradually migrated towards using more and more reduction screws, fixed screws on one side, reduction screws on the other. This is a case from about 4 months ago. And you can see, for somebody that's 39 years old, it's a real scoliosis, and you can see the result. And this is intraoperatively showing the fixed screws on one side, the reduction screws on the other side, to be able to achieve that kind of result. And in the most extreme example, you can see here that some very complex, very rigid, previously fused, using osteotomies and whatnot to recorrect it, that we can do some complex reconstruction. And so what's happening is that, again, as we've done these more aggressive corrections, you would think that the complication rates would actually increase, but in reality, the truth is the opposite. As we've been able to do a better and better job, have fewer mechanical failures, do a better realignment, that our complication rates, although still high, are gradually, slowly decreasing. And as we move away from, for example, doing anterior surgery or being able to move away from doing very complex three-column osteotomies, that also goes and reduces our complication rates. So that takes us into to sort of one of my passions, and that's cervical deformity. And what's happening is this is taking the complications and the risks and the potential, disasters to a level. And this paper showed about 4 times the rate of complications and 4 times the rate of serious complications with the use, with the correction of cervical deformity. And the reason why some of these patients, because they've had severe chin on chest, they're malnourished. There's people that have other coexisting conditions such as Parkinson's disease or myopathies or other things that make these people truly, really frail and really sick. And the fact is, our giant front back surgeries, getting back to where we started with the thoracic and lumbar spine, something that is the best thing to be doing in this. So this paper from the ISSG looked and found that basically there is a 9 times higher rate of mortality within a year with people with cervical deformity compared to correction of thoracolumbar deformity. And again, it's shown that there's different ways that we've tried to go and assess it and predict it and to ameliorate it. But one of the biggest problems is that we are doing things using essentially similar corrective techniques that we used 30 or 40 years ago. And one of the problems is that the lateral mass screw, which is the workhorse for posterior cervical fixation for most of the surgeons in North America, really biomechanically is not very strong. And it's kind of very similar to what you see when when we're trying to put a hook in. There's only so much force you can put on the hook before you rip the hook out. There's only so much force you can put on the lateral mass before you rip that out. And there's been a variety of biomechanical studies saying that this really is not an adequate tool for fixating complex spine deformity. So basically, this is something which is, at least in my institution, up until recently has been the go-to. We have our indications conference every Monday, and then probably the most common cervical operation to do is the C2 to T2 instrumentation and fusion. And the reason why is you usually can put a very big C2 screw in, and you usually can put a very big T1 and T2 screw in. What you got in the middle, was a little bit less important, but this led to the problems that was done. Now, there have been a number of discussions, and if you go and you heard this conference in Asia or some places in Europe, they say, well, you can go and do this thing where you're doing sort of a funnel technique to try to go and actually do a cervical pedicle screw. But again, for those who have tried that over the years, it's a bit of a cumbersome thing, and you're drilling down, trying to find this bleeding spot and then going through there. And I'll tell you, if nothing else, it's a bit nerve-wracking to be able to go and do that. And despite the fact that people have tried a variety of different things to consistently do cervical pedicle screws, you can see there that there are some real serious injuries that have occurred from that, including vertebral artery injuries, nerve injuries, spinal cord injuries that have occurred from it. And this is another study looking at navigated, and they say, well, navigation by itself is the key. If you navigate, you're not going to have these problems. And again, this estimated there's about a 2% risk of vertebral artery injury with these navigated screws. And part of this is because the spine is very flexible. You put somebody in a Mayfield headrest and everything's kind of moving, and as you're pushing down with the drill and whatnot, things move, and it makes it so that your registration for traditional navigation isn't quite as good. So this is a recent paper looking at the largest malpractice judgments against spine surgeons in America. The one is a cervical pedicle screw, attempted cervical pedicle screw that resulted in a Wallenberg syndrome and severe neurological deficits. And the other one, you can see, it's right through the center of the spinal canal, resulting in paraplegia. So the fact is, these what we do is potentially dangerous. And what I want to say is that, at least for me, my risk tolerance for putting a traditional pedicle screw in is not quite good enough. So for me, for me to do it, and there's others that have different risk tolerances than I do, but for me, the routine use of subaxial cervical pedicle screws was too big of a leap, and the consequences of a misstep, and that's why you don't see me, doing rock climbing or anything else, because I'm a sissy, and I'd be terrified being up there on that rock. And for me, if I had a cervical pedicle screw case, so I was going to put lots of cervical pedicle screws in a day, believe you me, I would be an anxiety-full day. But however, is there something that can be done where you can teach the old dog like me any new tricks? So this was the start of my epiphany to do it. And the true start, actually, as you're going to see in a second, came from this institution right here, where about 3 years ago, Rod and I and about 6 other surgeons we're going to do a development lab to refine an expandable T-lift device that was having some problems. And so while we were doing this lab, there was another lab going on where they were trying to develop true cervical percutaneous pedicle screws. So they said, would you mind coming over and taking a look? Is this absolute insanity or not? So we were watching them, and Rod was there, and Chris Martin and Deb Bomick and Paul Kim and a few. Mike Wang was there, Reg Haid. We were all sitting there watching all this stuff, and so as they were putting the screws in, they were assessing the insertional torque, and suddenly we saw that the insertional torque just absolutely spiked through the roof as you got into what's called the pedicle inlet, the dense bone that is at the entrance to the pedicle. And what we saw was that this bone was so dense, and the insertional torque was there, and they had stripped a couple screws, and so as they were trying to put it through this bone, and suddenly we said, well, why don't we just put the end of a screw into this super dense bone that is present. So I had done 3 or 4 labs in my mind trying to refine this, and others. Rod, Chris Martin, Martin Pham, others were all, kind of thinking about this, and these guys much smarter than me are moving things along at a greater degree, but I kept on, plodding along. So this person here was a lady who was sent to me because her rod was prominent, okay? She'd had 11 previous surgeries, and you can see she had almost no lumbar lordosis and developed pretty severe cervical kyphosis. So I saw her with the prominent rod, then I started to do things. Her bone quality wasn't very good. She had other medical issues. So I sent her off for all this optimization. And during the course of this optimization, she pops back with the rod actually through the skin. And suddenly it becomes, in my mind, an urgency, because if this whole thing gets infected, then it's an absolute disaster. So I was kind of looking back at my time of using reduction screws in the thoracic lumbar spine and said, boy, can we potentially get some correction from posterior releases and the use of reduction screws. And so initially what I did was use a combination of lateral mass screws. There's one C2 pedicle screw and one C2 laminar screw, because she had a very atypical course of her vertebral artery, and I didn't want to risk that. And I looked at that and said, hey, that's a little bit better doing that. So she goes off to rehab, and at rehab, she trips over something, falls, and all of a sudden it looks like this. And suddenly all of her lateral masses are all ripped apart, okay? The lamina of C2 is a rip through the lamina of C2, and I'm like, oh my goodness, what am I going to do? But fortunately, I had been with Rod and the group here and had done now probably 200 pedicle inlet screws. I said, something, it's time for me to put that into action. And this was from a cadaver lab that I had done to sort of refine the techniques, talking about pedicle inlet. So what pedicle inlet is at this junction. I'm going to show you how dense the bone is there. And what happens is to get into the pedicle inlet, you have a little bit of variability of where your entry spot is actually going to be. But the key for this is that the ending point is in the dense bone, represented in that red line by the pedicle inlet. And the nice thing is one of the advantages of true cervical pedicle screws is your screws line up precisely, and if you can go and have the variability to have these screws line up precisely as well. So Chris Martin basically did a biomechanical study with this with Deb Bomick and others, and showed that with this was done. And these are the people that were at that initial lab. So with this allows a screw to be placed into this ultra dense bone right into there, and allows something that is biomechanically much more stable. So all of a sudden, instead of me doing that free walk climb, I'm like this kid right here. I've got the harness and I got somebody behind me holding me, allowing me to be able to go do this. And what's happening is that there's been study after study after study showing that the pedicle inlet, which is the one in the middle, is far biomechanically stronger than the lateral mass screw, and it's almost as strong, not as strong, but almost as strong as a true pedicle screw. Now, some of the people are altering this, bending this, because some people are recommending using a 4.5 millimeter screw into the pedicle inlet, which is even a stronger screw, versus you can rarely put a 4.5 millimeter screw into the true pedicle. And so there are some ways to bend this even further. And this shows for a number of different screws being put in, the comparison of lateral mass versus pedicle inlet. And you can see that these are generally 14, 16, 18 millimeter length screws, and these are usually, I use a 4.0 screw for those. And again, what we're trying to do is that super dense bone that's right there, that's where we want this screw to end up, right in that bone here. And a nice study done by Jeff Gum is going to be presented in Sydney at the SRS meeting, but he said, Chris, you can go ahead and show this. He did a thing comparing the Hounsfield units of the pedicle inlet compared to the lateral mass. And the pedicle inlet averaged around 600 Hounsfield units versus about 100 for the lateral mass. And the thing that was so interesting about this, and this was the results from his study, was that basically as people get older, their pedicle inlet actually becomes denser. So unlike the older person with lateral mass fixation and the bone gets crappier and crappier, the pedicle inlet is at least a little bit stronger. So up into people into their 80s, the pedicle inlet continues to allow very strong purchase. And again, advantages are the allowing the screws to line up because of the variability of the starting point. You can get these to precisely line up. And with this, you can finally use these reduction screws. And this is from a case, actually this is from a cadaver lab that I did. I'm going to show you a case using the reduction screws, how this lines up, and the powerful ability to achieve correction, which is very analogous to what happened moving from hooks to pedicle screws in the thoracic spine. So again, this just shows the pedicle inlet versus the true pedicle screw and the forces that can be applied. Now, what happened was some of us, including me, who's a total worrywart, was concerned, well, what happens if the head moves? This doesn't give us absolute freedom. So a variety of different things, and you'll see this in the video today, was done. The first of all is the Mayfield head fixation device does not rigidly hold, and there's a paper going to come out showing that by doing an ancillary supplementary fixation to the Mayfield, this is called the caption device, with this, it increases in at least some of the planes a 90% reduction of motion during the course of the force application to the cervical spine. So suddenly this is a far more rigid way to be able to go and do this. And you can see here, it's 92% in medial lateral motion. It's over 50% in anterior posterior motion. The second thing we did is say this bone is so dense, we need to have a better navigated way to drill into the bone. And with this is a -rex high-speed drill. It's a 2.0 by 25 bit, and it actually drills into this bone enormously precisely. No chatter, no drills. You're not going to skive off with this. And again, this is done with a navigated drill itself. The next thing we did is, particularly for those people like me who likes big open cases, I said, why don't we, in addition, put a reference frame that locks all of the spinous processes together? It makes a unilateral block. And what I do is I put this device on and put all my screws in. I take this device off, I loosen up the Mayfield, and then after I do my osteotomies, I correct it and then put it in. And with this, the ability to be able to exceptionally precisely put it, again, this is the matchstick. And what's going to happen is, in parallel to what we're doing, another group of people are continuing to refine this percutaneous pedicle screw project to be able to go and to do this. So basically, I showed from Chris Martin, and again, with this combination of different things, with these robust screws of big sizes, with reduction screws, we're suddenly able to do some very powerful correction of the spine. So this gets up to this case here. You can see, one of my many horrible cervicothoracic deformity, camptocormia cases. And by adding this entire ecosystem of activities together, suddenly something that looks like this, okay, I'm able to gradually doing a front and back surgery, including doing a posterior correction with these pedicle inlet screws, to be able to achieve this type of correction. Here's another case I did about a month ago. This got sent into me. Somebody had an anterior fusion, the graft kicked out, the thing collapsed down. In the past, this would have been, kind of a front operation. And here I am, there's Kristen Jones helping me out. She's the wizard of the O-arm. And so she's helping me out with this. And you can see the device on the multiple spinous processes. And you can see the end result after this had been completed. So with this, we're able to do, and this is from that case, very powerful reduction to allow us to do this type of reconstruction in a way that's far easier. So basically, this is something for you all to think about. I'm not saying, everybody needs to run out to do it. And I do say, for those people who are interested in trying it, there are a number of different hands-on labs. And I'll tell you, the people that do the full day hands-on lab and put in 20 screws themselves, about 98% of them convert to say this is a new thing that they're going to use regularly in their practice. And I'll show you we'll do a little bit of a demonstration of it. But I just wanted to give you all an overview of something that may impact your practice a little bit. Thank you.
Great circumspective lecture there, Chris. Thank you so much. So 2 questions from our audience. I'll just summarize them into one. Part A, do we need to have navigation for these screws, or would you feel comfortable doing that with anatomic pre-planning and C-arm? And part B, is there even a reason anymore to do subaxial, so C3 through C6 pedicle screws at all? So
Chris Ames and I are debating this at the SRS, that question. To me, so I will tell you, if I have something in my navigation and I have a 5 millimeter pedicle, and you'll see this like at C7, sometimes at C6, where you have an enormous pedicle, and I feel comfortable with my navigation as Reggio, I will continue along. But I am regularly, particularly for C3, C4, C5, C3 in particular, a lot of times those pedicles are really small, and I just don't see that the risk-benefit ratio. As you see, there's a 2 to 5% risk of vertebral artery injury. And for those that I know that I have, and I know that probably all of us here have put something into the vertebral artery, it is a life-changing and maybe pants-changing experience as that blood is dripping off the ceiling for doing it. And so for me, I'm not going to regularly take the risk unless there is a really strong reason. Back to the navigation. Since we've initiated this, there's a couple of our European colleagues who say that they have figured out a way anatomically to do these screws, okay? And in fact, just like Jens and I did, I showed you there, they are doing, as Rod knows, they're doing a study right now, a big anatomic study, comparing the accuracy to the best freehand/fluoro technique to navigation. And that study is ongoing right at the moment. My belief is that, and I do a lot of freehand stuff, I'm still nervous about this enough. You know, and when I've had 100 cases under my belt, I may come back to you and say, look, I've converted to doing this in freehand, but there are a number of people that are attempting it. I'm just going to tell you, I think it's riskier, okay? Now, if you decide, hey, I blew out a pedicle and I'm in the middle of the night and suddenly I don't have a place for some fixation, you know, I think we all have our different risk-benefit profile. But I'm going to tell you, if you do each of the steps the way that they are, with the head holder, with the better Midas, with the navigated stuff, with the 3D imaging, I think it's just safer. You may be able to get away with it. You know, we have the guru of navigation and robotics. What are your thoughts, Nick?
Here, I'll give you the bigger microphone.
No, I mean, it's amazing, and what I'm going to talk about here on your shoulders is how do you potentially, you know, use robotics for this type of paradigm? But the reality is that I agree with you 100%. It's something that you really, you know, I think are not going to deviate from using image guidance for. It has to. That's going to be part of the safety profile.
Well, good. Well, thank you all.
One more question
Yep.
from our dear friend, Professor Yang Hai from Shanghai. So percutaneous, you mentioned percutaneous screw fixation in the posterior C-spine, kind of en passant. Is this actually becoming a clinical reality? Is there a benefit for this? You talked about risk-benefit ratio.
So the reality of it is, I think it is, this is an area of discussion right now. I think that right now that people could do percutaneous, predictable pedicle inlet pillar screws now, okay? I am still, there are some really narrow pedicles, and if you're a believer that every screw has to be a true pedicle screw, I think we're still, the accuracy, and Nick may be able to, again, justice there, I think we're at a millimeter to 2 millimeters accuracy, okay? And if you have a 2 millimeter pedicle, is that enough to go do that? And I personally feel no, I wouldn't do it on my patient, okay? And so, you know, part of the thing is that, you know, what I show, and there's been some pushback even from the group that's doing the percutaneous screws, they say, Chris, you're directing people off to the side. And I said, no. The fact is, if they get comfortable doing pedicle inlet screws, the leap to then move over to doing pedicle screws is a much smaller leap than somebody who's regularly doing lateral mass screws and then making that leap, okay? So I think we're incrementally moving towards doing it, but I think there are anatomically some pedicles where you cannot put a cervical pedicle screw. Nick, do you?
I agree 100%. And that's the beauty of planning, right? Having that intraoperative CT and knowing what your tolerances are really allows you to plan the procedure. And yeah, there are going to be some patients where you can't, just like when we learned about transarticular screws, there are cases that can't be done. So I agree.
Amir?
Wait, one second. I'm going to bring the microphone to you, Amir. This is Dr. Samdani.
Thank you. First of all, a great talk, Chris, and just want to comment, particularly in the pediatric population, where in syndromic patients, it's not uncommon to get a proximal junctional issue, which we're taking up. I can tell you, those pedicles are not going to accommodate a pedicle screw. They are very tiny. Right now, we have small, wimpy lateral mass screws that we try to deal with and try to supplement anteriorly. I mean, this could have a real impact in that population as well.
Yeah, thank you. Again, this isn't something that is, I'm presenting sort of from the group. This isn't my idea. Actually, it's much Rod's and Chris Martin and Martin Tham and others, idea. But I do think that this is something that, at least if nothing else, keeping your armamentarium as a bailout. Okay, that if you suddenly say you blow, you got this rheumatoid patient, you blow out 2 lateral masses, this will give you an opportunity for a bailout technique. Thank you,
Let's
guys.
move on. So much more to talk about. Thank you, Chris.
Thank you.
1 second. I am fully responsible for having been amiss before, but it was a late night celebrating our fellows' graduation and then having an Abzocker. After that, that's a real into word from Anthony, absolutely insightful. So I was amiss in introducing Dr. Shafri before. He's obviously an eminently known person, as all of our 4 lectures are, and the only, I think, orthopedic and neurosurgical board-certified surgeon in the country, certainly in North America, and also chief of the only integrated, I had the honor of visiting them, spine service in North America at Duke. So much published, and as you saw, just a transcendental visionary in deformity surgery. And I couldn't ask for a better segue than his own statement for Dr. Nick Theodore, professor and chairman of neurosurgery at Banner, and one of the visionaries in bringing engineering to a higher level, as you'll see, for the benefit of spine care. So Nick, thank you so much for coming. And I have to say that jacket looks really good on you. Maybe we can get Chris to wear his for the second lecture.
Well, thank you very much, Chris. It's such an honor to be here, and obviously I've been following on the shoulders of giants, following Chris Shafri, and I think, my tale is a little bit different, and what I'm gonna talk about the next few minutes really is where I've spent the last 25 years of my career, which is that intersection between engineering and spine surgery. Let's see, we advancing, here we go. And I think I've stolen a lot of things from Chris today, including this slide here, but this is probably one of my favorite slides. When we talk about spine surgery and neurosurgery, when I first started, the reality is that everybody was a brain surgeon, right? And going into spine was really not something that people wanted to aspire to. And it was through Volker Sonntag that I learned that nothing could be farther from the truth. But I love this quote: spine surgery should be left to those who are either too stupid or technically inept to do anything else in neurosurgery. I think I would argue nothing could be farther from the truth. Although historically we get into this sort of chasm. This is 1973. Dick Berglund was a neurosurgeon at Harvard, and he says, really, neurosurgeons stopped evolving, and although unlikely to follow the path of the dinosaur to extinction, it's really become lifeless and uninteresting. Again, I think he missed the boat. He was, of course, playing tennis early in his career here, and really went on to do nothing of note except having this article in the New England Journal. When we look at our field of neurosurgery, though, we realize that we are absolutely technologically dependent, okay? The gentleman on the left, William Bovey, working with Harvey Cushing here, imagine doing surgery without the Bovey. So, we are, throughout the history of surgery, and in neurosurgery in particular, we really have been early adopters of technology. One of my favorites, James Greenwood here, was a neurosurgeon in Houston, Texas, also a ham radio operator, and would build his own radio equipment. So what does he do? He says, well, why can't I electrify these forceps? That became the bipolar electrocautery device. Once again, imagine doing surgery without these devices. And then there were crazy people, like this is Jose Delgado, really the father of neuromodulation. And he said, well, can I put an electrode into the bull's brain and then at that point push a button and have the bull not gore me? And he was a brilliant guy because nobody would ever thought about this. Of course, what does he do? He puts his assistant out there. He's got the button. He goes, hey, Clyde, why don't you go out there and make sure the bull doesn't get you? But, interestingly, it worked. And then the whole field of neuromodulation has come, again, at the forefront of technology. This is Aiju Watanabe, and really the father of sort of image guidance. So we go back, 40 years when we first in neurosurgery were able to understand where we were in 3 dimensions. I would argue fundamentally changed the practice. I remember being a junior resident at Bethesda Naval Hospital doing a craniotomy, looking around in somebody's head, not finding the tumor, getting a CAT scan and realizing our craniotomy was a centimeter off. I know that's probably never happened to Chris or anybody else, but the reality is that, at the time, this is what it was. And then, I was an early adopter of image-guided surgery. So this is about 15 or almost 20 years ago now, where we were able to do percutaneous things. But the fact of the matter is it required a lot of attention. And the attention, obviously, 2 things. One, you needed to trust the imaging and your registration. And secondly, you needed a steady hand, because if you're going to do something like upper thoracic pedicle screws utilizing image guidance, you can't move, right? Because you have a narrow pedicle trajectory. And I realize also that your attention is shifted, right? We're looking back and forth. When we're using navigation, we're looking at the navigation screen, looking at the patient, and we're not really focused. So why would we want to use image guidance? Obviously, we want increased accuracy and precision. Chris alluded to this a few minutes ago, but the reality is that as good as we are, we're never as good as we think we are. So this was a series of about 6,000 pedicle screws at Johns Hopkins. We look at about a 9% breach. And as Chris mentioned, and I would attest, thankfully, the majority of screws that are not perfectly placed, where there is a deviation, are not harmful to the patient. The question is, we got no sound. That's all right. Let's see if I can. Question is okay good enough? And as we spoke about, again, there's going to be some overlap here that we want to avoid this. And when we start looking at systematic reviews now of pedicle screw placement, we realize that with technology we get better. So with freehand, we have about a 12% breach in the thoracic spine, and this is a meta-analysis of 50,000 screws. And we start adding X-ray, CT navigation, and then robotics. We get better at what we do. But still, there's been a bit of a delay, a chasm, as there were, in the adoption of image guidance. And a lot of that had to do with, and still has to do with, workflow, right? If something slows us down fundamentally as a surgeon, it's not going to be adopted, right? We want to be able to do what we do on a daily basis and not get slowed down. I realize this is sort of tells the story here. All my cranial guys are using image guidance. They're doing all these things, and we're sort of stuck with the compact computer on our back, hopefully going to evolve. We've really come to an amazing point now where we have advances in imaging, advances in surgery, advances in robotics. We've got image-guided surgery now, which has been around for about 40 years. We've got surgical robotics, the Da Vinci and other platforms. And now we're in this era here where we've got image-guided surgical robotics. And when we look at, what does that look like from an automation standpoint? This is from 1980 in the Fyodorov Institute in Russia. It's just absolutely fascinating to me. Fyodorov did radiokeratotomies, and he said, why do I have to go to the next operating room to do my next eye case? Why can't I just sit down and have the patient come to me? Absolutely brilliant. Look at this now. He sits down, he does the procedure. People came from all over the world to have this done because he did thousands of these. You're not doing thousands of them if you're running from room to room, but when you have an operating room stacked up with 8 patients that are coming to you now, my mentor, Dr. Spetzler, if he had this, sure would have been a lot different world in Phoenix. But the reality is, how do we automate what we do? And, we look at automation and robotics. This is Russ Taylor, who's really arguably the godfather of robotics at Johns Hopkins. This is RoboDoc, the first commercially available robot for coring the femoral shaft. We've got the Da Vinci, which is a soft tissue robot. The whole premise of the Da Vinci, though, wasn't doing minimally invasive surgery. It was for the military to do surgery at distance. So in other words, having somebody in an austere environment, forward front, have the robot being able to operate with the surgeon being somewhere else, failed miserably. Why did it fail in that regard? Bandwidth, internet bandwidth. It wasn't fast enough. The surgeon back home would make a move and it would take 10 minutes for the robot arm to move. So what started off as that being the premise turned out to be something completely different. When we look at robotics, John Adler, with the CyberKnife, Mako surgical. And of course, if you want to go to China, you can also get a massage by a robot as well. And I'm sure Jens has these machines downstairs if you would like to participate during the break. But when we look at where we are right now in robotics, the fact is there's a hierarchy, and we're right now in what's called task autonomy. So the robot is not doing the case ourselves, but it's assisting us in what we do. The FDA has prohibitions on things happening autonomously, and we'll talk about that. But what do we want? We want to automate the accuracy of what we do. And the fact of the matter is that you would like to be like this robot, which every throw of the arm is making a perfect bullseye. And if we use the analogy of NASCAR, and we look at this is 1964, the car's pulling into the bay, the technicians are coming out, we're gonna fix this. The guy says, hey, look at the rear bumper, can you fix that? Yeah, we can fix that. Yeah, it's sort of hanging out. Yeah, we'll take care of it, there we go. And let's do that. Let's check it and then have the other guy check it too. Perfect. Looks great. Let's get back on the road again. And this is sort of where we learn to do surgery, right? Open surgery, we're palpating the pedicle. We wanted to do things safely. Our tolerance has always been low for risk. But the fact is, can we use technology to get better? So this is where we move into NASCAR 2016. And literally in about 12 seconds, all 4 tires are changed, fluids are changed, and we're in a situation where we can get back on the road, without much ado. Much faster than we are. And now I would argue that in today's era, for certain cases, certainly we'll show during the demonstration, a single level L4-5 pedicle screw case, the screws are going in about 3 minutes, and we're starting to work on the inner body. So we can really collapse the time of the procedure. So the whole concept of this, this was a video I put together for my mentor Volker Sonntag, 24 years ago. And the question was, how do we automate surgery? And Volker was very excited about this because he said, I could stay home and I don't have to do surgery. This is amazing. I said, well, we're not quite there yet, but the reality is we can get there. And why would we do this? We certainly want less invasive surgery. We want to reduce radiation exposure, but ultimately we want procedural consistency. We'd like to be able to do the same thing in a reliable fashion. Radiation is a real problem, and we're using X-ray in surgery, and thankfully that has decreased across our specialties significantly, but it's not lost upon us that there's a significant risk to us and to the patient for radiation. I threw my letter away a couple of years ago. This is dating back now 26 years. This is in Phoenix. We started looking at how do we build something that utilizes image guidance that can help us in a reliable fashion target the pedicle. And this is the old computer dynamics arm with the C-arm. We brought it into the lab in Phoenix, and we started working on this. This is Neil Crawford. How does it look? What does the end effector look like? How do you build something from the ground up that you can actually take into the operating room to allow us to do surgery? This was the first iteration of the robot called Big Blue. And the reality is we wanted it to be image guided. We wanted to work with image guidance. This is in 2012. We were in the basement over at the Barrow Neurologic Institute, and it felt like sort of Hewlett and Packard coming here together because we'd worked on this now for 10 years. And we're in the lab. This is a cadaver. We're going to put K-wires in. And everybody was just a little bit nervous. And what we realized was that, yeah, it can be done. We can actually automate this process of planning a screw and putting it in. Simple as it seems, nothing happens easily, and certainly it happens with the team. This is 2017. What do we want with robots? We want real-time image guidance. We want this feedback. There's still haptic feedback as you're putting things through the tube. We want the robot to come in and out of the field seamlessly. This is the first case done at Johns Hopkins on October 4th, 2017. I will tell you probably one of the most terrifying days of my life because here I had worked on this now for 17 years. Here we are, first case, dean of the medical school, president of the hospital, chairman of my department. There are more people in this room than you could ever imagine. And this is my fellow Karina Zigarakis. We push the button and say, okay, go to L4. The robot goes to L5. I'm sitting there, I start sweating, and Karina says, are you okay? I said, no, I'm not okay. I said, if this thing doesn't work, I said, I'm going to be in the surgeon protection program in Peru, never to be seen again. So we go back and forth, and sure enough, the robot's dead on. Our incision was off because we did it open. So again, the whole concept is trust but verify. You have to become familiar with this technology. I will tell you that utilizing, whether it's image guidance, robotics, or whatever, there's a learning curve. And if you're not using it, you need to learn. And the fact of the matter is that that learning curve, makes things safer, but you've got to put the time in. It's a different way of thinking of things. These are some cases that we did earlier with the robot. One of the things that struck me, this was a taxi driver with a T8 fracture in Baltimore, got run over by his own car. That can only happen in Baltimore. And, BMI of 50, coagulopathic, and a Jehovah's Witness. So my anesthesiologist says, "You're not going to lose any blood, are you?" Well, yeah, certainly if we did this open, I don't think it's a survivable injury, just given what would need to be done. But being able to do this percutaneously and at least get this fracture stabilized is a game changer, was the canister at the end of the case. So, this is a gentleman that fell. Interesting, the case has a thoracolumbar junction burst fracture and also a acute L5S1 disruption. And interestingly, his biggest problem was foot drop, but both these things happened from a fall from a ladder. Opportunity to do something a little bit different, to try to treat this as two different cases. So doing a percutaneous fixation and reduction, you can see a nice reduction of the fracture, and then also treating that L5S1 problem. Again, instead of doing something big and open, we're treating this as two MIS cases. This is a police officer, the known scoliosis, who was in a car accident with this mid-curve thoracic fracture, middle of the night. Being able to stabilize this, utilizing technology, again, off hours, right? Because if this technology works during the day, you want it to also work at night. Then we're doing different things. This is a case of a vertebral hemangioma. These are terrifying lesions. I remember being at the NIH and doing one of these cases with Dr. Ed Oldfield, and you take one bite of the lamina and all of a sudden these patients can bleed to death. So the question is, can we do something a little bit different? And what we did in this case was a sort of a combination, because when you embolize these cases, the bone becomes weak and you can develop a pathologic fracture. So we ended up planing and putting in pedicle screw, stabilizing, and then cannulizing the actual vertebral tumor and injecting glue at the same sitting. So in one sitting, being able to do a fixation and embolization of the tumor. And you can see the result here. That other part regresses the part, and you end up doing great. Again, a less invasive way of doing this rather than en bloc or some other paradigm. We're several years out now without any recurrence. This was a gentleman that came in also in Baltimore, just to show you about other things that you can do with enabling technologies. So he's got a hangman's fracture, and my resident calls me and says, "Yeah, he was surfing." I go, "We live in Baltimore. Where was he surfing?" He says, "Oh, he was surfing in Ocean City." So I realized that there are beaches nearby. But he also had myelopathy. He's got compression. The question is, can we spare that motion segment at C1, C2? Obviously, this is something you would never do freehand. This is something that, image guidance helps you with that tolerance. And with robotics, we're able to stabilize across that fracture segment. We're doing C1, C2 fixations now with robotics. To Chris's point, yes, things move. What I will tell you is that once the robotic arm is fixed, you're much less likely, because in freehand, you're pushing. You're putting an instrument down the spine and you're pushing. Whereas with robotics, you've got the end effector hovering above your target and you're able to very delicately to apply pressure to the spine. And also, you have that real-time feedback as you see, as you're touching the bone, from a feedback situation, whether or not your accuracy is good. So I think that this is an evolution of how we're doing, where you put the reference array. We've done transarticular screws now. And the fact is that I think that there are opportunity here, and Chris did a beautiful job, and I've taken his lead now and started to look at this pedicle inlet cases for correction of some cervical deformity. This is a partner of mine from Baltimore. We just did an odontoid screw last week utilizing the robot. So the reality is that I think that this technology is here, and the adoption is increasing. We don't have the same amount of time with our residents as we used to have, and our ability to treat these patients in a reliable fashion is going to be democratized with technology. We're using this now, the same robot, for cranial cases. So my partner in Baltimore and my partners in Phoenix as well are putting DBS electrodes, stereotactic electrodes in the brain, and it really has changed their field, being able to automate that process, which used to take a long time. We have a much different way of looking at accuracy now. And so since we know what we planned and we know what we placed, we can make a report card of how accurate we are. And of course, you publish your first series in the Chinese Medical Journal, just because I know that this is the first journal you turn to for authoritative sourcing. And the fact of the matter is that, when we first started doing this with the robot, we realized that there was a little bit of tip deflection, or what people will call skiving. And the reality is that all has to do with the drill technique, and we've sort of modified that. We now can look at things volumetrically. So it's not, is the pedicle screw in the pedicle and how does it look, but exactly what is the fit and how perfect are we in this regard. And when we look at our orthopedic colleagues, and this is with Mako Surgical, the new master knee surgeons are like, I don't need a robot to help me jig a knee. I can do this freehand very easily. And the fact is they can. But when you start looking now at 5-year data and 10-year data with robotics in orthopedic surgery, you realize that the usage of robotics with precision cutting, the outcomes are better. And they're starting to see this now. I will tell you, in spine surgery, if you can put a larger screw in to expand that pedicle, a longer screw, you have less pullout, better reduction forces, our failure rate is probably, and staying away from the adjacent facet. So when we first did this, we started looking at, this goes back to workflow, and the fact of the matter is that we are, things take time. There's a learning curve. So this is our experience in Baltimore with our first cases. What we realized was that, it's slow at the beginning. But we started shaving off about 4.5 minutes a case, and now reliably we're doing a single level MIS TLIF in about 1 hour and 10 minutes, which is not bad, but that adds an extra case in the day that you can do once the team is up and running. And when we looked at this too, and we started looking across surgeons and cases, the learning curve is very well defined. You're proficient with robotic technology at about 20 cases. All right, so people who try it once and say they don't want to do it, that's great. But if you really want to do anything, it's not. Chris Shaffrey didn't learn to put pedicle screws in one case. We all spent hundreds and hundreds and hundreds of hours of learning our craft. The same with any sort of enabling technology. So 20 cases for proficiency. At 61 cases, you become a master. So it takes time. I don't know if you get the green jacket at 61 cases. You'll have to talk to Jens about that. But it definitely takes some time. And it's very democratizing. This was actually a study that was done in Texas. It was beautiful. Right and left side, experienced surgeon on one side, res on the other side. The accuracy is the same. Again, utilizing this technology, I will tell you that's not going to be the same if you put a junior resident in a case doing pedicle screws. And we start looking now at the long-term data. We realize that image guidance definitely ups our games, and robotics makes that even better. So what's coming down the pike? I take my inspiration from the meatpacking industry, and the reality is that if you look at one of the most dangerous jobs in the world, it's butchery and cutting and carving up meat so that Dr. Shaffrey and I can have a steak at lunch today. The fact of the matter is that, now this has all been robotized, and the fact, we're now able to do this safely without, the butcher losing a finger and having that end up in your sausage. So we took this to the lab in Baltimore, and we started, doing laminectomies and osteotomies with the drill, and then programming the robot to be able to do that autonomously. Now, that's not ready for prime time, and that's not going to happen in the next few years, but I promise you it will happen. That happens with not just programming, but we can also use autonomous surgery and machine vision. This is Axel Krieger, one of my colleagues at Hopkins. If the robot can see what it's doing, it can do many more things. So we're planning with image guidance, but imagine adding visualization. So this is a case that they're doing now. This is the same technology utilized in the Da Vinci. This is a bowel resection and end-to-end anastomosis. Now, why am I showing you this? The reason I'm showing you this is because this entire procedure is done without any human touch at all. This is completely programmed robotically. The robot is operating autonomously. It's identifying the marker, cutting out a piece of disease segment. This is in a pig model, and sewing the two ends together. So for those of you who think we may be out of a job, we may be at some point. We're going to always be supervisors of these technologies. So what else? So this is what's called a synthetic CT. We've become very interested in this. It turns out it is very doable to take a regular CT scan that you see on the right and convert it into a synthetic CT, or I mean, an MRI, I should say, I apologize, and convert it into a synthetic CT. So there's a synthetic CT on the left, real CT on the right. So we took them into the lab, we took a cadaver, we got an MRI, we got a real CT, we programmed the robot and said, okay, can we register and do surgery? And it turns out, yes, we can. And it turns out there's no difference in accuracy. So for Dr. Samdani and my pediatric colleagues, imagine doing image guidance robotics with no radiation to the patient. And this is a real risk in our pediatric population. We'd prefer not to get a CT scan. And now with MRI scan, we're going to be able to reliably flip the paradigm here. Augmented reality is another thing. If robots aren't good enough for you, we can put a headset on you and have you see in real time sort of where you are and how things are going. We can do automatic pedicle screw planning. And I think the real issue is going to be taking a look at all this data that we have. If we can get reliable data, ISSG and other places that do a great job of curating data, looking at imaging. How do we predict what we need to do for a patient? How do we predict which patient is going to benefit from surgery? And that's going to be that really, I think, is going to be the ultimate game for us here. I've spent a lot of time looking at neurosurgical workflow in the operating room too. It turns out there's a lot of people, moving around. There's a lot of Brownian motion. The one thing that's constant is the anesthesiologist asleep at the head of the table. So we've looked at thousands of imaging study, thousands of operating rooms, and that's one of the things that remains constant. So we looked also at cognitive load and efficiency. So one of the things is that how do we teach the next generation of surgeons to do what they're doing? And we just published a study looking at this where we're able to look at the hands and eyes of early operators, so medical students, first-year residents. How do their hands move when they sew? How do they do things? And how does that technology, how can we use that technology to inform us? How do we get better as surgeons? How do we improve our technical craft? So this is also exciting. The last thing I'm going to talk about is just a little bit about ultrasound, and I'll talk about more in my second talk. But one of the things I became very interested in is ultrasound on the spinal cord, using it to look at perfusion and other parameters. So elastography became very interesting to me, and the elastography is the ability to measure the tension. If you think of the spinal cord as a piece of licorice, what happens in a deformity case or in a tethered cord case when you've got tension on that spinal cord? And that tension changes actually with trauma. So this is, we were in our pig model, we were able to show that we increase that tensile aspect of the spinal cord after injury. And this all goes back to Swedish neurosurgeon Alf Brigg, and this is a beautiful historical point. But if you look on the left, this is what happens with your neck inflection. When you flex your neck, when you put your head down, that spinal cord becomes stretched in the cervical spine. This is silver staining of the spinal cord. When you have your head up, look at those fibers are relaxed. And this translates to my work in the NFL, because guess what? All spinal cord injuries occur when your head's down. When the player's head is flexed and he gets into a collision, that's where things happen biomechanically, and that's where things happen with the spinal cord. Keeping your head up in a lordotic posture is really protective. So this is one of the things. But interesting, this was 60 years ago. And I got interested in this whole aspect of tethered cord, and what are we doing? This is one of my last tethered cord procedures. And not really missing that at all, because we realized that we can do something a little bit different. And this is vertebral column shortening for tethered cord. So I have about 80 cases now. In the properly selected patient, an older patient, adult patient who's having symptoms, who've had several detethering operations, continue to have neurologic deficits, can we take away that pressure of the spinal cord by shortening the vertebral column? And these patients, they have small pedicles. and, aberrant anatomy. So we're utilizing technology. You can see here the end result. And look at the spinal cord on the left, pre-tethering, it looks like a banjo string. It's tight. And on the right, you can see what happens. It becomes untense. We published our initial series about 5 years ago of 20 patients with really amazing results. Again, picking those patients carefully along the spectrum of their disease. But one of the things I saw, and this is one of my first cases at Hopkins about 10 years ago, I got an ultrasound just to look at the spinal cord. So look on this is pre-shortening at the top, and then ultimately after shortening, look at the excursion of the spinal cord. So the dimensions change and the pulsatility increases. And so I started looking at what happens with elastography in the actual surgery. So we started looking at this as, this is a paper that was published in Nature. We're looking at, in the pre-shortened case, the spinal cord stretched, and then we move into mid-shortening, and then ultimately when we close that gap down after the T12 vertebrectomy, we're able to measure this. And the fact is that we show a significant decrease in the tensile strength. So again, like a piece of licorice. And here we are again, looking at this and measuring this. We did this in a cadaver as well. We pulled on the spinal cord and we're able to show that that tension strength increases. So ultimately, I think it's about using the tools that we have in engineering and partnering with engineering. So these are not things that we do in a vacuum. These are all things that are built with teams, and I've spent my entire career, number one, working with engineers, and number two, building effective teams. And ultimately, these when you bring these technologies together, I think it's to the benefit of our patients. And technology, as I've said, really has become a critical part of what we do. This is the team. This is the home team. So first, Jens and Rod, thank you very much for this opportunity to wear the green jacket and spend the day with you all in Seattle. Thank you.
We have a couple of questions. So one question that came up is leveling the playing field. You mentioned that. That's a really cool concept, right? Where's the wisdom component in there? So I have personally in our microclimate here in the Pacific Northwest seen cases that were done by surgeons without casting any shade on them that they would have never touched before, where hardware is in possibly problematic areas, but the indication and the execution was really reflective of being kind of naive to that area. And being intentionally polite here, trying to be polite. So where is the wisdom? Where's the judgment? Is this going to be deferred to AI or some extraneous decision-making body?
Yeah, I don't think so. What I think is, that's a great question. I think, number one, nothing supplants wisdom, right? And I think when I saw your fellows last night, I was able to talk to your fellows, you realize that time you spend in the decision-making and figuring out what to do is critical. These technologies are gonna help us do what we need to do, you're right, but you still have to do the right thing. And you still have that at this point, that's still relegated to our own experience, what the literature shows us, and what we think the outcomes are going to be based on a whole series of factors. I do believe, though, going forward in the next few years, we're going to be able to take significant data, imaging data based on what bone health is, other data, depression of the patient, other labs that predict biological age, and help us get and tailor make a specific plan for that patient. We're going to have to be assisted in that because as good as you are, as good as Shaffrey, everybody, we are having done this for so many years, if we can get that aggregate data together and then help everybody make better decisions, that's where I think we're going to end up.
And let me ask a personal question again. So in spine surgery as well as in medicine, we're held to the FAA paradigm of no accidents, no problems. Learning curve is a euphemism for complications. You pointed out that we have a new era of trying to teach better in an artificial environment. Tell us, in this transition period towards a greater AI application, where do you see learning curves being ethically permissible? What is an okay learning number? I'm just going to deflect from the robotic discussion. When I am at MIS course, I'm always the dinosaur surgeon. And they talk about the learning curve of about 20 to 50 cases, right, Dr. Spinelli? that's complications. So I know there are no zero complications with open surgeries either, but where do we hit the ethics of learning curve? How can we kind of make sure that they're minimized?
So one of the interesting things that I hear all the time is that, we have to teach the residents how to do surgery, so let's do it open to teach them. I would argue that we're not doing open cholecystectomies anymore to teach residents how to do that. They're all done robotically. We have less than 0.1% of cases convert to open. So I think the fact is that there's nothing is going to change the fact that we need to know anatomy. So being in the lab, critical. Understanding the anatomy, critical. Understanding how to bail yourself out, critical. However, we have to push forward. And I think that, I don't know, it's the same thing when you ask, patients who have a chordoma, and you're in a room of chordoma surgeons, who wants to have a giant en bloc procedure versus something that might be less invasive. So as we push the envelope, I think the reality is that the training gets pushed too. And that there are other ways we can make surgeons better without necessarily having them quote unquote practice or learn that learning curve on our own patients.
Well, thank you for so much inspiration and teaching. Always great. And next, we're going to switch laptops. It's a distinct pleasure. I'm going to come up here, then I'll just unplug your laptop. Maybe Corey can help with that. So I'm going to unplug him.
Yep.
So one overlooked aspect of spine surgery, we've always had these distinctions of neurosurgery and orthopedic surgery. You see an integrative approach here. It's cool to have different backgrounds, but it's also fantastic to just be boundaryless there. An overlooked aspect has been that of pediatrics, and this is actually where spine surgery, I think Chris is correct to say that, originally came from, right? It was pediatrics who taught us how to do deformity surgery. So this is something that has been really omitted in a large way, and it's such a distinct pleasure to have Professor Amer Samdani here from Shriners in Philadelphia. And he has done so much. He's written about, again, neurologic disorders related to scoliosis. And I have a question, by the way, from Atul Goel online for you after your lecture. I'm going to hold that up. Atul is watching. Thank you, Dr. Goel. He's the godfather of lateral mass surgery. And so the big point about this lecture is very poignant for me personally. Just the other day, we had a kypho correction in the spine. It went like a textbook case, and the neuromonitoring went down. We did everything by textbook, but learning to understand the spinal cord during spine surgery, during the sometimes very complex challenges physiologically and anatomically, is such an important thing. So beyond seeing the spine in an artificial environment, learning to learn its language during a case and seeing how it feels, so to say, how it functions, is so important. Thank you for coming all the way over here, Amir. It's always a pleasure to hear and learn from you. So neuromonitoring and spine.
Excellent. Wow. No, thank you. Such an honor to be here. Let's see if we can get our slides going. Two fantastic lecturers, and truly an honor to be wearing this green jacket while I'm up here. So, I was charged with two separate talks. I thought one I would make a little more specific to pediatrics with respect to growth modulation. But neuromonitoring, let me tell you something. I mean, if you haven't already experienced it, we're all going to experience changes in neuromonitoring in our career. And I thought I could just lay out what the history of neuromonitoring has been with respect to scoliosis surgery and some tips and tricks that I've learned along the way. Let's see. Okay. Here are my disclosures, none of which are relevant to this particular talk. But before I get started, I want to give a huge thank you to the entire Seattle Science Foundation team. I mean, my goodness, what dedication and tremendous wealth of educational content. And particularly, obviously, our two course chairmen, I mean, Jens and Rod, to really dedicate that much time to make education and to make our lives easier is truly a gift for us. And I want to truly thank you guys. And I can tell you it's becoming truly the educational resource for myself, for our fellows, for our residents. But let's kick into neuromonitoring. So I'm going to take you back to 2007. So I had this child, 12 years old, very typical scoliosis. You got a curve in the thoracic spine, a curve in the lumbar spine. And we planned a T2 to L3 fusion on this child, 2007. I think you can make an argument as to what we would do today, but in 2007, we were certainly fusing lung, planned our osteotomies, and sure enough, we dropped that first rod down, and we have a loss of our signals. And at that point in 2007, if you continued with that case, and I'm telling you, I mean, I still distinctly recall different podiums and SRS case discussions where if you said, you know what, I would continue with this procedure, people would raise their hand and say, what, you're going to take a chance with paralyzing an idiopathic child? That is crazy. So clearly at that time, and it's never the wrong decision, as I'll discuss a little later, we stopped the procedure, brought the patient back, and were able to finish the procedure. Why don't we fast forward about 20 years? This is off of the Harm Study Group data set, which is a prospectively collected data set that's multi-center, national mostly, with some international sites as well. But why don't we take a closer look at that data? So if we look at the data, 3,000 patients, the incidence of having a neuromonitoring change in that cohort is 7%. So it's not trivial, right? 1 in every 12 patients or so. But if you look at the number of cases that are aborted today, it's literally 0.1%, right? About 3 patients out of a total of 3,000. So what has changed in these intervening 20 years to get us to this point where 20 years ago, 15 years ago, you had to abort? Today, we continue to go on. So we all know that what's happened is we've become much more comfortable with multimodal intraoperative neuromonitoring. Several articles have highlighted this, and the real key is transcranial motor evoked potentials. First described, there was a Nature paper that was cited earlier by Nick. I can tell you that that's where it was first described in a Nature paper in 1980, and then slowly started to gain traction. As we know, it is not continuous monitoring. We're monitoring our motor tracks, and there's a lot of variability as to how often to check, right? You have to call out to your neuromonitoring team, say, can I get a set of motors? And there's a lot of variability. Some surgeons will do it on a time frame. Others will do it after a certain number of screws or after correction. We're actually working on a Delphi process with the Columbia group currently to help us further define what those intervals should be. But right now, it's still fairly subjective. My advice, and you're going to hear me say this again and again, make sure you have your routine, whatever that routine ends up being. I can tell you what I do every 10 minutes and then 5 minutes during correction. And for my fellows in here, that has been a recent change off of the Delphi process. So why are transcranial motor evoked potentials so efficacious in spinal deformity? Because they have a very high metabolic turnover. That high metabolic turnover makes them much more sensitive to distraction and ischemia that can result from distraction, and hence they are much more sensitive and much more reliable to picking up changes. But with every plus, there's always going to be a downside. The downside is that they're very sensitive to the type of anesthetic that you're using, to volatile inhalants, and that's why you have to use total intravenous anesthesia. So transcranial motors have been really the change, but this was the paper that changed our practice. Prior to this paper, we were actually doing somatosensory evoked potentials. We also had transcranial motors, but we were doing a Stagnara test. What this paper that Schwartz et al. Did, over 1,000 patients across multiple centers, and what they found is that somatosensory evoked potentials missed 4 out of the 7 postoperative neurological deficits, whereas transcranial motors did not miss any. So now we had a tool that we felt was reliable for us to actually predict what the patient was going to do postoperatively. But that wasn't the only thing that has changed our practice of not aborting cases, because you have to be able to utilize the tool in an effective manner. So what came next, about 5 or 6 years later, is this right here, the neuromonitoring checklist, what you should do if you have a neuromonitoring change in the operating room. Mike Vitale led this effort, and we've modified it. You're going to see this version. I highly recommend that you have this in your room. I can tell you, even today, when there's a neuromonitoring change, I can feel palpitations, but they are less than when I felt, 10, 15 years ago. So really important to be able to think clearly. Basically, in it, it says, you got to check the anesthetic, reverse your last movement, raise the blood pressure, probably the number one determinant of getting those signals back. And on the bottom, what you can't see here is consider getting consultation with a colleague. And the reason why that's important is not only does that most importantly protect your patient, getting advice, it's perfectly okay. I mean, I do it today, my colleagues do it. I've had fellows who've called me from the operating room asking, hey, listen, I'm having a change. What I tell them is, we'll discuss it, and actually they put a little note in the chart as well, because it protects the patient, it protects you as a surgeon, and it protects the hospital. So just keep that in mind as well. So as we got these two tools, now we have a tool that's going to tell us when there's going to be a change, and we've got a checklist on what to do. So now, 2014-15, we're actually proceeding now with surgery. So here's a patient I had, again, a very typical 56-degree curvature. Sure enough, put that rod down, and there's a, put that screw at T4, there's a drop in the motor evoked potentials, we raise the blood pressure, the signals come back, but now we're completing the surgery. But the thought process at this point is, complete the surgery, but take less correction, right? You don't want to go ahead and stress an already spinal cord that already has some implication of injury further. So that formed the hypothesis for our paper here. What kind of correction do you get if you have a neuromonitoring change versus not having a neuromonitoring change? And the easiest way to get into JBJS or a high-ranking journal is if your results actually are contrary to what your original belief was. Because we all thought, right, in our study groups, of course you're going to take less correction. People are probably going to put titanium rods, take less correction. What our results actually showed, out of the 640 patients at that time that were in the no alert group, when we compared them to the 36 patients that were in the alert group, that actually correction coronally, sagittally, and axially was actually equivalent. So not only did surgeons go from stopping surgery after one change, now they were actually proceeding with getting a very similar correction. What about multiple results? Because that paper still had a small n. When we looked at it, and this is the next area that we're really focusing in on, how many alerts do surgeons typically are willing to tolerate? Of course, it's going to depend on multiple factors. Your experience, it's going to depend on where you are in the procedure, blood loss. For me, as a general rule, after the third one, I almost go back to a baseball analogy. I'm like, you know what? We are done for a day. And for the younger surgeons in the room, you will never be faulted. I'll tell our fellows, our more junior attendings, it is perfectly okay to stop and come back another day. But clearly, as our data is showing, surgeons do continue, and it appears there is less correction with multiple alerts, but not that significantly less for patients. So what's going to constitute a significant alert, right? Because there's a lot of variability. If you look in the literature, there's papers that say it's an all or none phenomena, right? Whether you have it or you don't have it. Others say 50%, and others will say up to 80% constitutes a significant alert. Somatosensory evoked potential is fairly straightforward. 50% drop in your amplitude, greater than 10% increase in latency, that's significant. Transcranial motors, that's where all the variability starts coming in. Some people say 50%, some people say 80%, others say it's all or none. We generally consider 50% as the threshold. I'd rather be conservative and react to something rather than get further behind and have a higher threshold. The Japanese Neurosurgical Society did actually try to standardize this, and they published a greater than 70% drop as being a benchmark, and what they found was the sensitivity for using 70% was 95% with a specificity of 91%. More recently, or a few years after their initial recommendation, they added latency, an increase in latency greater than 10%, or in combination with a drop in the motor evoked potentials of greater than 70% is going to constitute a significant change. And here, sensitivity jumps up to 100%, specificity 93%. Most importantly, the negative predictive value now is up to 100%. Doesn't matter what you use, but make sure you standardize it across your institution. Stay in touch with your neuromonitoring team so everybody has a good understanding of what that threshold is going to be. So now we've got the threshold, what are we going to do about it? And unfortunately, there still isn't a whole lot. I know Nick's doing a lot of work trying to push this forward, and we'll have more interventions on the way. But currently, the primary move to make is to increase the maps, right? Usually drive them up past 80. Typically, I tell them 85, knowing that there's probably going to be a little bit of a drop down to 80. In pediatrics, where they live at a much lower map, instead of using an absolute number, you can actually use a percent. 10% to 15% higher. Steroids are controversial, but I'm going to come back to those a little bit later. There's been some promising work with riluzole, which is neural protective, and hypothermia. You know, we had that football player several years ago. It made the news, but really just not enough data to support it right now. With respect to riluzole, it is a sodium channel blocker. It's used for ALS. It is a known neuronal protection it provides, and there's been several animal models, and this will be a common theme you're going to see with spinal cord injury. Many times in the animal models, these different interventions are working. When we try to translate them to humans, oftentimes they're not as productive as we had hoped. With riluzole, there was a double-blinded study that was led by Dr. Failings. It was actually stopped because of COVID-19, but 193 patients, cervical level injuries, placebo versus riluzole, and what they found and concluded in this paper of journal Neurotrauma is all subgroups of cervical spinal cord injury subjects treated with riluzole showed significant gains in functional recovery. I still think there's more to come on this, but perhaps we can use this even prophylactically in our myelopathic patients or patients that we think are very high risk. The mainstay for this stays raising the mean arterial pressure. And there's now several studies that support this. If you raise the blood pressure, you're going to have your best chances of getting neuromonitoring back, which is going to really be a corollary or prelude to be able to get neuronal function back. It doesn't always correlate. I actually recently had a case for the first time where the neuromonitoring signals jumped all the way back, and the patient took some significant time to recover. But what I like about this paper is, as we go through it, they had 452 patients, 7% had a neuromonitoring change, interestingly, very similar to the case series that we have. In 6 patients, just raising the blood pressure resulted in neuromonitoring signals coming back, and the other patients improved with additional maneuvers. And what I like is they actually provided a time frame, because up until now, we didn't really understand, hey, listen, do you just start ripping all your implants out? I know you have to reverse your last move, but what are you supposed to do? So they said that, listen, anywhere from 16 to 37 minutes, so you have time to really think through what your next move is going to be. And this next patient is going to highlight this. A 13-year-old child, neuromuscular scoliosis. You can see what she has got, this kyphosis, and underwent a T2 to L2 posterior spinal fusion. And sure enough, we drop our, prior to dropping our rods in, we started noticing that the neuromonitoring signals, you can see the timestamp to your right, we're dropping the rods in, 12:34, boom, everything goes out. So we go to our checklist, we start running through, we irrigate the wound, we raise the blood pressure, we check the hematocrit, we want to make sure the anesthetics are fine. None of that is helping, some time is passing now. We take out our last couple of screws and nothing really is changing. So now our options are, do we just continue to take the rest of the screws out, or we can look at some additional modalities? And at that time, we had gotten the O-arm, and sure enough, what the O-arm showed was at the T6 level, there was medial breaches bilaterally. One of these by itself likely would not have resulted in a change, but because they occurred simultaneously in a child whose spinal cord was likely not functioning at a typical level, given her neuromuscular condition, resulted in a change, and it was very instantaneous. O-arm comes out, we take the screws out, you can see the signals bump right back up, and the child makes a recovery. What about steroids? Of course, we're all familiar that the general recommendations are that the complications from steroids are likely not worth the risk of giving steroids, but understand that Bracken's New England Journal of Medicine article back in the early 1990s, and then the subsequent article in the late 1990s, was with traumatic spinal cord injury. Many times what we're dealing with is actually distraction and ischemic injury, and there is some literature in the vascular surgeons when they're doing their aortic resections to support the use of steroids. In the pediatric population, we actually do go ahead and give steroids to our patients because we feel that it's more of an ischemic injury, and for better or for worse, the complication profile may be favorable. So that is part of our routine here, but obviously still has some controversy. So when we start putting some of this stuff together, so here's a child, 16 years old. This child's actually in medical school now. Both parents are engineers. They had gone for non-operative treatment for many years. And they came with their set of x-rays, and you could see this curve go from 40 to 60, to 90, to 120, 130 degrees. So it's not just neglected patients. Sometimes it's patients who are actually have access to care everywhere, but they fear surgery so much that they let it get to this point. So we take her to the operating. Again, I'm in touch with her. She's in medical school now. Wonderful family, wonderful girl. Just got led down a certain path. They come to us. We put her in a halo, and there we are. We're working through. We're going to do a T4 to L4 spinal fusion. We're putting our screws in. Sure enough, we go to that concavity where we know those pedicles are super tight. Boom. The motor evoked potentials drop out. They slowly come back. So what I want us to recognize, yes, we can proceed at this point, right? Because we trust our motor evoked potentials, but you have to change your game plan. It's not about how many screws you're putting and how much, whether you get the curve from 130 to 20 degrees or 40 degrees, you have to change your mindset. Earlier in my career, it was all about, I would not see the forest from the trees. I would stay so honed in, no, I've got to get that high implant density. And what I want to get across here is think big picture. You want to get this patient off the table, and you want to get this patient, keep her neurologically intact. So what I typically do at this point is I go to the screws that are going to be easier to put in, which are going to be the convex screws. I know I got to get a base at the top, base at the bottom. I can tell you one thing, she's not going to miss those concave screws on the concavity. It's the convexity that I'm going to fill, and here she is. She's got some curve left. This is what she looks like before and after. I promise you, she's not missing those screws. And I did take less correction, as you can see, just to get her off the table. The story does not end. This is really important, okay? When you have a neuromonitoring change, it doesn't end right there. The idea of delayed neurological deficits, it's real. We've seen it in our practice. Got some of our fellows, I don't know if they've seen it when they were with us, but I'd say once every several years, there'll be a patient, and typically a patient that you had a very significant change intraoperatively. Josh Auerbach did this study off the SRS. It was a questionnaire published in 2016. 63% of the delayed neurological deficits occurred within 24 hours, 90% between 48 hours. So be very cognizant those first 48 hours. Typically, it's blood pressure. Patient's in pain, gets a big bolus, blood pressure drops, come in the morning, patient's not moving. So just be very, very cognizant. And then Marinus de Kluver did this larger cohort from the Netherlands, almost 3,000 patients, and 7 patients, their deterioration occurred a little bit earlier, 16 hours afterwards. And here's just an example of a kid that I had a couple of years ago, 8 years old, Vactral, had a fusion. You can see pretty severe kyphoscoliosis in this kid. We planned on a multi-level resection on him, and here he is, challenging pedicles, did a vertebrectomy, motors dropped. He had recovered post-operatively and initially did okay. And we did have them try to keep the blood pressure up, but in retrospect, it likely dropped. Pretty much after, on day 2 or 3, he's not moving his legs. We had to take him back to the OR because he had tight pedicles. We'd done a multi-level resection, likely had some collapse, so there was some laminar compression, but in combination with the blood pressure. So really make sure you understand that the story does not end at the end. And here he's about actually 8, 9 years out now, doing well. So what do we do? So first of all, the story will not end if you have a major change. Because we don't really have a step-down unit at the Shrine, we will keep the maps up greater than 80 or 85 for 48 hours. I put a central line in. I do not have a step down. I want to be very aggressive because I've seen this several times. Don't over-narcotize. We do give steroids. That's debatable. And then you can take them back if the deficit occurs and get back to that operating room to release some correction and make sure that there isn't any hematoma. But what I've also learned, so these are all several factors, right, that we've learned over the years that have made our risk of aborting cases much less. We've also learned that you can have iatrogenic compression as well from the spinal cord. Larry Lenke published this paper. So there's 3 different spinal cord types, right? You've got one where you've got CSF around the spinal cord, type 1. Type 2, it's being effaced, it's touching the pedicle. Type 3, there's actually significant distortion. And if you look at Lenke's paper, type 3 has a 28.3 odds ratio of having a neuromonitoring change. So really important to understand this. And this really came to light about 10 years ago when we had this kid came to our hospital, was transferred in, they were operating in an outside hospital. Great surgeon, had actually already operated on her sisters as well. They're doing a T2 to L3 posterior spinal fusion. They go ahead and do some distraction on the shoulders, and boom, her signals go out. They take her back, she's not moving, they take her back, remove the rods, and she comes to us, she's about 3 weeks out. For For me, it's the 4-week mark. If you look at the spinal cord injury literature, if you have a grade 1 out of 5 at 4 weeks, you have a very good chance of that muscle being a 3, 4, or a 5 at the 1-year mark. So she was about the 3-week mark. She was an Asia B, so incomplete. That's really critical. And, we were going to admit her for rehab, and they asked me to see her. We got a CT scan. I looked at it, and I'm like, wait a second, she got some really tight pedicles here. Remember, this was on a Thursday. I took her to the operating room on a Friday. She had not moved at all. Came in on a Saturday, and sure enough, she was starting to move. And all we did was we did concave pediculectomies and compression. Nick spoke about shortening the spinal cord. The spinal cord likes compression, and that's what we did with a convex rod, and eventually took her back, and she started walking. Took her several months, and got her out of the hospital. So obviously, where we're going with this is we're working, our group and others are working on automated reading of neuromonitoring signals. We all recognize that these are signals. You have a technician based on experience who's going to have to make a call on whether there's a significant change or not. That's going to get automated. That's coming. That's just going to be pattern recognition. Then we're using different machine learning models. We've got actually a paper we're submitting to JAMA right now, really based off of Larry Lenke's paper in Columbia that he did in these patients. They were adult patients. Most of them were adult patients. 1,100 patients, 205 variables, 5% loss of neuromonitoring. And what they did was they used a machine learning algorithm to come up with a preoperative score, right? To help them decide which patients are going to be at the highest risk. And the factors that you see for preoperative risk, they're not surprising. You've got a deformity angular ratio that's high. You've got a myelopathic patient. You've got a conus that's below L2. You have a upright larger thoracic Cobb angle of 75 degrees. But if you have a score that's greater than 87, then you have an 87% chance of having a neuromonitoring change. So now we're using current technology, machine learning, predictive analytics to tell us and identify which patients are high risk. So I see this as a corollary to what we had with transcranial motors, right? So again, we're getting a tool, and now we need, much like we had a checklist come through, we've come up with a Delphi process as to how to handle these patients that are high risk. This is a study that Raj Iyer led for us that was done out of Columbia, 15 surgeons, 22 determinants of what constitutes high risk. And there's the usual stuff. You want to consider preoperative flip signals. Really important, okay? Because positioning can knock out signals. You want to make sure you understand that. Temporary instrumentation, compression, but perhaps the most important one, particularly for the younger surgeons in the room, consider staging 3-column osteotomies into 2 separate stages. I think that's probably been the #1 thing that's changed in my practice over the last few years. So why don't we come to the present day? Here's a child, EB, 12 years old, progressive scoliosis. You can see fairly large curvatures here. We take her to the operating room. We do plan on a T3 to L3, posterior column osteotomies, significant drop with putting the pedicles in, significant drop with putting the rod down. But now we've learned about compression. So now we've changed our correction mechanics. Rather than dropping the rod on the concavity and distracting, we do a convex rod. We did discectomies, and today we're able to get a fairly similar result that we would have gotten with or without the changes. And I'm going to stop right there. Thank you very much.
Sorry, just a treasure trove of, I'm coming up. That's not working. So stay here.
Oh.
Just a treasure trove of information, really drinking from a fire hose. I want to hear with all clarity, because I'm very slow, as you know, in uptake. You say that one more time. So, preoperative steroids, I'm going to modulate the questions a little bit, and many shout outs to Wilmer Godoy from Bogota, Colombia, who inspired some of those questions, so he's very appreciative of your teachings also. Steroids, so you mentioned methylprednisolone. In a high-risk case, like what you've shown several, should we give it beforehand, which would be the best time, or is that an intraoperative thing? So I'll stop there with that question. There's a sequitur coming.
No, that's a great question. So certainly post-operatively in the pediatric population where it's based off of distraction and perhaps ischemia, we give it. When we started looking at it preoperatively, we found out that for tracheal swelling, our anesthesiologists were already giving it. So it's already being administered. I think it's very low risk, and I do recommend it in a much more formal pattern, especially if you've got a high-risk patient.
Yes, ma'am.
Go for it, microphone, because we have a large international online population. Dr.
May I add
Shaffrey.
in? I was part of that, several of the different riluzole-related trials.
Yeah.
And riluzole works better with pre-treatment.
Yes.
So I go and I start very high-risk patients, like the ones from Larry's criteria. I will start them 2 weeks before on riluzole and continue them for 2 weeks after. And there was a young girl, a 13-year-old, who had 4 different attempts at scoliosis surgery. Each time she lost signals. On her 3rd attempt, she became nearly paraplegic, recovered over a couple of months, and had a bad scoliosis. And I treated her for 2 weeks with riluzole, continued her through, was able to do, didn't lose signals, was able to do a very nice correction on her. So for all my high-risk cervical, the super bad, congenital kyphosis cases, I pre-treat them with the riluzole. Now, if the patient wakes up afterwards and you work something unexpected, then I put them on riluzole and treat them. And everybody at Duke now, any neurological deficit is treated with riluzole.
No, Chris, you're absolutely right, and we're hearing more and more, and I bet that will be the trend as we move forward.
Then part 2 of the question was, so vasopressors, MAPS 85, higher. What vasopressor, norepi, dopamine, and you said 48 hours. I just want to hear you elaborate a little bit more on that because it's such a critical breakthrough recognition that cord perfusion relates to mean arterial pressure.
Yeah, it's interesting because I'll relay a story that we have a great intensivist, and my partner and I had done a case, again, maybe 7 or 8 years ago, and we're in the ICU, and the kid was doing fine. We walk in the second day, and the child's not moving. I'm like, whoa, and we look, and sure enough, there was some narcotics that were getting, blood pressure had dropped, and our intensivist, which some of you may know, he's like, guys, you're always telling us to drive the pressure up, and it doesn't really make a difference, and I'm not kidding you, as the pressure went up, the kid started moving. So clearly there is going to be, he became a believer after that. What we typically utilize is, again, if we're trying to set a goal of 80, we'll usually say 5 points higher, and typically use dobutamine.
The third question is from me, an ethical one. So I was recently invited to the UK to speak about neuromonitoring because they're even more in a cost-saving mode than we are, and they want to know, is neuromonitoring really necessary, and when and how? The stereotypical answer is high-risk cases, of course, but the other realization in our country is the more you use it, the better you get. And even in routine lumbar cases sometimes, I don't know, I'm looking at Nick and Chris here, you can actually learn a lot. You become more careful or so. So utilization versus cost, of course, any paralysis is a horrendous complication and almost priceless. Right. But what is your advice to large administrative organizations in terms of cost savings versus gains by having neuromonitoring accompany spine surgery?
No, it's a great point. And in the past, when we've tried to come up with position statements, we've tried to avoid calling it a standard because that could put people at a disadvantage that may not be able to access neuromonitoring. And interestingly, our paper that's under review, they wanted us to add that specific paragraph that it may not be necessary for all patients. So clearly, it, for us, it is what we use, and it is the standard at our hospital. I think individually, I'd say in the US, for what we do with pediatrics, I would strongly suggest to administrators, because all it takes is one deficit. But I completely understand people where cost may be more of an issue, mostly outside of the United States, where it would not be a standard. So it would be a little bit of a regional difference, in my opinion, is to go ahead and utilize it in the US, just my understanding of our legal system and our administrative teams. But clearly, there's other areas where we cannot call it a standard for sure.
So this is a very insightful and very diplomatic answer. When I was tasked with this in the UK, I used the usual evidence base, but I also resorted to ChatGPT Pro.
Yeah.
I used Claude 4.2, and I used Open Evidence, my favorite new tool, or newer tool. And it was very interesting to hear their responses. I trained them all to basically give non-diplomatic answers. You give a pre-diplomatic answer. But the most funny thing on that vignette was they're all in favor of more neuromonitoring. They actually said that all. So the more you use it, the actually better you get, the more streamlined the process gets. The key point that I found was funny, Nick, to your AI point, there's a regulatory component to this. I had fortunately done my homework in the US. When I arrived there, I found that you could not access AI because it was forbidden in the UK. So I had to show them that. They had some government representatives there. I had to show them that you could not access open evidence in the UK, but it was so problematic in their eyes. So as to your point for AI and using AI, there are regulatory dimensions that we can't even fathom. We take it for granted in our country, and it's blocked. So in terms of AI, is that something that you now use as a risk modulation? You use that risk calculator, but this should be something that could be AI amenable, right? I mean, you can have a pretty simple machine learning technology to apply to patients, and for us as adults also, as adult surgeons.
Absolutely, and you know, that paper that Lenke did, that was actually off of adults. We have a separate one that we're working with Georgia Tech, actually going to try to submit it to JAMA, where we've identified using machine learning, the large data set that we have. It's relatively, I mean, for us as spine surgeons, it's large at 3,000 patients, but as we know in the world of AI and machine learning, it's actually relatively small. So we are utilizing to come up with a risk calculator. That's our next step right now. Once we get we've identified some high-risk factors, upper thoracic curvatures that get instrumented, the DAR. Actually, interestingly, one of the biggest risk factors that came out was pulmonary function, which makes sense, right? So if you have PFTs and if your lung function is low and you're unable to oxygenate, that actually ended up being one of the top predictors. But our goal after this is to turn it into a risk calculator.
Then I have a technical question to the two previous speakers and yourself.
Yep.
So we had Ricky Sasso, our good friend and frequent contributor from Indiana, speak here about fixation and dysplastic spines and the thoracolumbar spine, and he showed some horrible cases, and he did translaminar screw fixation. He said, I'm not even going to bother with a robot or doing something complicated. I'm going to do translaminar, so crisscross screws like what we do in the C2 sometimes. What are your thoughts on that? Maybe I'll go to Nick first. Is that a cool technology? Is that something sensible? Here, I'll give you the microphone.
I mean, listen, if you can get fixation and the reduction that you need, I mean, I think it's fine. We definitely have done it up in the upper cervical spine for, at C2, but I think if I know, I've not done it in the thoracic spine, but if you can get the correction and the reduction that you need and it holds, something to think about.
Chris, your thoughts. So you showed a very cool technology for the lower C-spine. Is that something that we could think of more often as we see these horrendous dysplastic pedicles like Amr showed?
Well, again, I think like everything, there are, you're looking for bailouts and options. So would that be something I would routinely be doing, putting laminar screws instead of pedicle screws? No. But if there's a difficult case, knowing how to do something is good. And I know in the cervical spine, for example, sometimes I'll put a third rod and I'll put laminar screws as a third rod connection to maintain my correction. So I think all of these different things are important to know, for us to understand, things to do as bailouts, for us to do as difficult cases. And as the technique gets solidified, how far you can take those techniques is really something important to investigate.
So Amir, last but not least, you showed some absolutely horrendous cases and being very selective about when and where you put hardware in, how much correction you do, listening to the cord through a really good, intelligent interaction with electrophysiology is great. Your thoughts on kind of using alternative fixation strategies like translaminar screws or so, if applicable?
Yeah, no, absolutely. I think you have to be very open to different technologies. Obviously, Chris just showed the pillar tech, the inlet technique. I have not utilized translaminar screws in the thoracic spine. I've typically gone to the in-out-in. So I'll just come a little bit out laterally and just aim it out towards the rib head is typically what I've used. And as a bailout after that, if I really need a screw and I can't get one on the convexity, which you usually can on the convexity, then I'll go to bands. But I'll keep that in mind on the translaminar side, but I have not utilized it. I'd be worried just about lining up the rod.
Hooks and cables, do you still use that?
We definitely use some hooks, typically at the right upper, the UIV on the right side, typically where the pedicles are small, usually a downgoing
You'll be
TPU.
happy to hear that we still have a annual hooks and cables lab, and our fellows are there, and they actually really like it. I still believe in showing these old things that Chris demonstrated at the beginning of his first lecture, and they're absolutely wonderful group. They're, by the way, going to show some cases at the end of the day. They don't know that yet, but I'm going to tell them their cases.
I think that's probably the most important lab, because that's something they may not be seeing routinely, and you have to have bailouts.
You have to have bailouts.
You have to.
So you still use those in your armamentarium also?
We do, yep, we do.
We should combine our fellowship forces and do a combined hooks and cables lab.
Let's do it.
Thank you, Anya.
You're very welcome. Thank you, guys.
Don't forget your lab. That's your lab. So in a slight change of plan, we'll ask the fourth of the Fab Four to come up here, Dr. Rudy Bertagnoli. He came in here from Dubai, but I know him from decades ago. He's a direct surgical teacher of mine. He's a fabulous surgeon, and he is going to do something totally different. We saw a lot of fusions here, and he's going to suggest to you, and I'm going to warn you, and I say it officially here, a lot of this is maybe not FDA approved, so we're not advertising something, but he's going to open your eyes and minds towards non-fusion technologies. And for me, that is the actually less invasive or the true minimally invasive surgery is not to fuse patients. We have to fuse patients. You saw 3 absolutely fabulous lectures from true leaders, but maybe not fusing a spine may be a very meritorious thing. And this is just that you know who this man is if you haven't heard the name. He's the godfather of the Protus C. He co-inspired and modified the Protus L, which are now 30-year-old technologies. And they're finally making a breakthrough in our country. And it was your pioneering work. So it's such an honor to have you here. And I know it's a huge effort to fly in from Dubai. So great to have you here. Tell us a little bit about non-fusion techniques for degenerative conditions. Thank you for being here, Rudy.
Yeah, thank you, Jens. It's also a big honor for me to be in this faculty, and that was the reason why I almost traveled half the globe to come here. We have now 11 hours difference, so for me it's a little bit late, but I'm still awake after this very comprehensive lectures. And today, as Jens already mentioned, I want to bring you in a different world from what you have seen and what you still will see a lot. I want to bring you in a world that maintains function by restoring stability. And it's another technology that can do in specific indications what we have done in the past with fusion procedures or screws, pedicle screws, rods, hooks. And I will show you in my 2 lectures what can be done, not motivating you that you should start right ahead when I show you these big cases. This is experience of 30 years, and like we have heard before, also in robotic spine surgery, you need to have patience, and you need to be patient, and you need to have experience to get to the right point. So let's talk a little bit about posterior dynamic stabilization options for treating degenerative disc disease and lumbar spinal stenosis. Because there's all the time the question, conservative care or fusion, because this has been the 2 parts that we have used in the past. And we are talking about, when we are talking about degenerative disc disease, and when we are talking about this problem, we have to understand that we have to look at the entire motion segment. Degenerative disc disease is one part. It's the disease in the frontal part of the spine, but a lot of times we'll see there is also an influence on the posterior structures that have to be addressed there as well. So it's one disease, as we can say, with many faces, and it's actually a continuum. It's not that you have a disc hernia or you have a black disc or you have a stenosis. It's an evolutionary problem that shows different pathologic changes at different time points. And we see a lot of times different discs in different stages of this degeneration process. So that means starting from a desiccation of the nucleus with a narrowing disc space, bulging of redundant annular ligaments. So we have to look at the ligaments a lot. We have going to a complete desiccation, cracking, tearing of the annulus. Now we can see the classic disc hernia, the extruded disc. And then we're seeing as a secondary phase that we call hypomobile phase. There is already an answer of the nature to address this microinstability by shortening the tension bands, by putting in calcifications to make the micro-instable spine again stable. And we are losing motion at that point, therefore we call this phase hypomobile phase of this degeneration. And the final stage is typically wise the collapse, subluxation with a degenerative spondy, and also in the end stage we see a lot of times spinal stenosis. So that's the reason why this is a long-lasting process. We see spinal stenosis more often in elderly patients and not in young patients. And we see the classic discogenic disc hernias, black disc, extruded disc in the mid-age population or in the early population. There are a lot of classifications in the meantime available. Here's the Thompson classification. Goes from grade 1 to grade 5, and this gives us a good way to classify the stages, because that's very important, because we have now many tools available that we can choose, and we need a kind of classification that we select the right indication for the right tool that's available. It should not be that if you have only a hammer, everything looks like a nail, and that's what we see in a lot of technologies. Surgeons want to use one technologies in all pathologies, and this is not possible, as we know, from a lot of problems that we see when you see second opinions, when you treat patients that have been already 3 or 4 times treated before they come to you. The question is, what is the cause of degenerative disease? Is it a mechanical failure or a cellular failure, or where is the hen, where is the egg, what is the first? There is also a hint that it could be also a genetic predisposition, so that we have proteins that are linking the cross fibers of the annulus, and it's not as strong as they should, and then we get fissures, and the discogenic pressure can start this process of the degenerative process. So we can say it's a chronic disease with many phases, as you can see here on the picture, where you have different stages in the same patient at different levels. If we are looking into that, then we have to say that the disc starts typically wise to dehydrate. So hydration is a very important thing, because this is what we also can see in the MRI scan. Do we have enough water content or not? We see it in the T2 images, if we have a healthy disc or if we have already black disc. The pressure, if the pressure is decreasing, also the whole segment becomes to be micro-instable. It's like you have an automobile tire and you lose air out of your tire, then your car will not anymore be as stable as it should, and you feel it when you go in some heavy turns. We see also a chemical change in the disc, and this is something that my dear friend Thierry Manet is researching at this point, because this is something we theoretically can measure. We see an acidic evolution and a PO2 collapse, and also a glucose collapse, leading to apoptosis of nuclear cells, and they are not able anymore, because the number is decreasing, to produce enough extracellular matrix that allows to have a good pressurized disk. There are factors, so there is a nutrition reduction. So this is very important, because a lot of times when you try to put in like stem cells or disc cells that you reproduce outside the disc, then you have to understand, is the nutrition of the space still in a good shape, or do we have already sclerotic end plates where such cells or such biomaterial cannot work anymore because it does not get enough nutrition and oxygenation to survive. So this is very important, and if you are in this kind of stage, it's useless to use a cell transfer, so here a mechanical solution is necessary. Chemical evolution, this is something that we will show you later, and cells apoptosis, so this is if all the nucleus cells are dying, so you will have a complete degeneration ongoing, and it's irreversible. The disc generation, these biomechanical disorders have to be fixed, and the shear forces, especially when you lose disc pressure, are creating what we call micro instability. So the segment moves more than it should. So we call this the hypermobile phase. And the spine is in an unbalanced situation, and we have what we call this instability. So the question is, can posterior dynamic assistance create the disc healing condition? So that means if we are in the early stage and we are stabilizing the segment without fusing it, can the disc heal? And we'll show you a couple of pictures where you see it can when you go in early enough. So this is the anatomobiology. So you have the PHD protein, you have hydroxylation, the PO2 and protoplasma. This is a very important biochemical situation that will change when the oxygenation, when you do not have enough oxygen in this chain, and then you will see this will lead to apoptosis, and when you have apoptosis, you lose the ability of your disc to rehydrate and have a good mechanical property again. So how can we measure that? There is a correlation with the MRI. This is what my dear friend Thierry Manet is working on currently. So if you look at the normal control disc, you have a pH of 6.5. You have a pressure of 2,131 millimeters, and you have an H2 water content of 87%, and the temperature was 37.3 degrees Celsius. If you look in the black disc above, then we see there is a pH of 5.4, so it's a very negative sign already. You have the pressure of only 740 millimeter Hg, so that means already a significant loss of disc pressure, and 43% water content only. Temperature was 37 degrees, so almost the same. So this is when you have this modic 1 change, and it can happen when you go, here is a 60-year female patient, again, the control disc, pH of 6.3, the pressure 1,781 millimeter, and water content 91%. temperature 36.9, and in the black disc, that's L45, we only have a pH of 5.2, so it's very acidic, and a very low pressure of 537 millimeter, and water content only 54%, temperature was almost the same. So you see, it's very important that you check that, and this could be in the future control mechanism, like you do a discogram today, you can put in an electrodic sonde and you can measurize the pH and also the pressure of the disc, of the interdiscal space. So that means here you see there's also a correlation between the normal controls and the black disc in a younger and in the older patient. And you see this could be a tool for the future to measure when you should intervene before and when you should not continue with conservative treatment, because conservative treatment, as we know, is only a symptomatic treatment and will not address the problem per se, because it's unable to do that. Let's talk a little bit, why does a patient with degenerative disc disease suddenly have low back pain and why others don't have low back pain? I think we have to understand and go back to the very simple situation, the biomechanical loads. We know that the anterior column is maintaining almost 70% of the body load in opposite to the posterior structures that are controlling only 30%. That runs over the posterior spine, mainly the facet joints and ligaments there. So that means, in other words, can we create a support to the anterior column when we do a tension band restoration hypothesis? And this is exactly, you see here, James Gordon said within the body framework, the vertebral column has employed a genial place soft elements to limit the loads that are burdened and also helps to protect from the consequences of fragility. So that's a very good observation. And you see here, if you control the posterior elements or you retension them again, then you can also support the disc and you help the disc not to progressively degenerate further on. Another theory is the stone in the shoe hypothesis. So why you have a problem, like you have a stone in your shoe, that's from Mulholland, and a degenerative disc is painful only at abnormal load transmission. That means if you move, if you stand up, you have pain. If you rest, the pain disappears. And he defines instability not as more movement. He defines instability as an abnormal load distribution. So I think that's a very good idea about that. And finally, the neutral zone hypothesis by Punjabi. He says we have three systems. We have a stabilizing system, we have a dynamic and a static system. The static system are the ligaments, the bones, and the dynamic system are the muscles, and the neural control unit. So that means if you have a problem in your static system, the neural control unit will implement an stabilization due to the dynamic stabilizer group, and you overwarm the muscles and you have low back pain because you have too much motion. And we are also looking forward, when we started to develop the dynamic DSS implants, we were looking what we call an active zone hypothesis. That means we try to modulate motion and not taking away all the motion, but we modulate the motion in a way that we bring it back to a normal motion. So you see here, this is the principle. So you have a micro instability, and this will bring signals to your brain, and your brain will come back and say, okay, muscle tension increased, and if you have an overwarm muscle, as you know, you have low back pain. And this is what we call the active zone. Active zone is the green, it's a neutral zone that you have in flexion extension, neutral position. And if you have a degenerated spine, you have an hypermobility at the beginning. So you have pain throughout an abnormal range of motion in the final stages of your movement pattern. If you flex down, if you extend back. And what we want, you have an enlargement of the so-called neutral zone. That means you have pain through muscle spasm initially. And what we want to do with the dynamic stabilization, the posterior dynamic stabilization, we want to reduce the neutral zone back to a normal. So that means we eliminate from this hypermobility approximately 30% and bring it back to 80%, where we still have motion, but we have a controlled, stable motion without overwhelming the muscles. And this is what we call the active zone. So we are calling this activity level the active zone, that the implant that you will implant in the posterior structures will help you to control. What is the therapeutic effect of motion modulation? How does motion modulation affect low back pain? I think there's also some theory and hypothesis that you have an injured degenerative segment, you have an increased neutral zone, as we know, we have an increased muscle force to recreate stability again, and you have adverse consequences. You have a higher spinal loads, you have higher stresses, strains in the spinal components, and you start to become chronic back pain. So if we are reversing that by using a dynamic stabilization device with motion modulation, we are decreasing muscle forces again, and by doing so we implement positive consequences. We have decreased spinal loads, decreased stress and strains in the spinal components, and less back pain. So this is the theory why a device like a DM device we will talking about in a few minutes can help your patients to reduce the pain and to help the disc to rehydrate and to regenerate. So right now, if you look in the degenerative disc disease, you have not many options available. You can say, okay, go for conservative treatment, and some people have already 2, 3, 4 years conservative treatment, including epidural shots, facet joints. They have a lot of things that not really addressing the problem per se, but to help them to come along with the problem. So now, if you have a disc herniation with it, you can say, okay, we can do endoscopic discectomies, we can help that, but you are not, if you do that, you are not restoring stability back. You're removing something that you never give back, or you can go to a total disc replacement, but this is a pretty large procedure, cannot be done everywhere, because expensive implant, you need to have an anterior approach, so it's not so easy to do that. So we can introduce a smaller implant like that we call it's DM, it's a spinal stabilization system. And when do we use this system? So when the back pain is larger than the leg pain, ODI is larger than 30, and there's a bulging disc or protruded disc, no disc herniation. So you have to start in the earliest stage of the degenerative process. This is the device for the earliest stage. So the first step when you want to support your segment with an implant. It's an easy, applicable implant. It's very simple, but it has a great effect to the motion segment. So what is it? It's indications. Actually, it's recently FDA approved, and it will be introduced into the spinal community right now. The indications are not many, as you see here, because this was the problem in the past. It has been overused in any indication. So, and after that, they found out that where it works, and it works when you have severe primary low back pain greater than leg pain. Leg pain should not be the dominant symptom. And you can use it only at a single level from L2 to L5, where it's approved with current episodes of refractory to a last of 6 months non-operative care. So you should not start immediately. You should bring your patient to conservative treatment. If it doesn't work out after 6 months and you still see this pathology like this black disc or this bulging disc, this is a very good implant to support. It's easy to put in. We'll show you today how you can do it. And you can measure that the degrees of disc height should not be more than 2 millimeters, so you should not use it in a completely collapsed disc, because then it cannot do any work for you. And you should also not use it when the ligamentum flavum or the annulus fibrosus is thickened, or the facet joint capsule is hypertrophic, or the facet joint has a severe degree of degeneration. So this is also a contraindication. And we have, as I already mentioning, more contraindications than indications. So this is very important, because in the past, this device has been overused. In Europe, we are using this device since almost 20 years. Then it has almost disappeared, and now it's coming back. When you have a spinal instability with an isthmic or degenerative spondylolisthesis, arteriolisthesis, disc height loss more than 67%, osteoporosis, of course, multi-level disc degeneration, prior surgeries in the same segment, extruded segment disc herniation, or severe anatomical changes. So this is not an implant for this kind of situations. And what does it do? Like I showed you before, the distribution about 7 to 30, 80 to 20. So this is the distribution of a healthy segment. So if the disc starts to degenerate, it will shift loads back to the posterior column. And the posterior column is reacting to that, because it starts to progressively degenerate as well. You have facet arthritis, you will see a ligament shrinking, you will see a lot of problems also now in the posterior structures. And that's the reason the DM will restore it back to normal, because it restrains the hypermobility and brings back the normal mobility. And this has been proved with a finite element analysis that shows that there is a 27% disc load reduction in flexion. So that's very important, and 51% disc load reduction in extension. So that's very important, because we know extension is all the time the position. That's not good. If a patient has an kind of disc hernia, you tell them don't extend. If you do something, go into the sitting position and do not load your posterior annulus too much, so that it does not rupture and create a fragment disc and an extruded disc herniation. So this is what it does. It load shares with the posterior annulus. It maintains the foraminal height, so that's also very important. And it does also load share with the facet joints. And here you see how the disc is restored in the back. And we can also create a facet alignment with that, so the facets are again in a normal position where they can act easily in flexion extension like they should. If you are not doing that, your facet joint is all the time in a sublux position and will generate further on, and you will create a problem that you cannot solve anymore with a smaller problem. The surgery technique is very simple. You make a small, less invasive approach, or we say an appropriate invasive approach. You should expose the spinous processes, both spinous processes in a good manner so that you can see what you're doing when you put in the implant. You remove the interspinous ligament. You should not remove the supraspinous ligament because this is an important tension band. It's protecting an overload in flexion for the spine. You have specific tools to squeeze the implant, and then you can apply the implant. You can deploy it, and it will open, and with the two wings, it will be fixed on the upper and the lower spinous process, and you have a tension band that you bring around the upper and the lower spinous process to have also a kind of extension reduction. You have crimpers that keep the tension in the implant. So the whole procedure, if your experience, will take you maybe 15 minutes, 20 minutes. It's very simple, very atraumatic, and it's very effective in the early stage of the degenerative process. So there, of course, there has been performed an IDE study. It was a prospective randomized controlled IDE study against conservative care. 279 patients with 182 DM patients, 97 controlled patients. That means control was conservative care alone. Failed more than 6 months conservative care, and 24 months was the primary endpoint. And there was a high-level evidence to patients receiving non-operative care, not just in the early patients, but population surgery struggle with normally. These patients are coming back frequently, and you don't know what you have to do if you not want to fuse this patient. The safety showed a high efficacy of 144 DM and 76 controlled patients. The back pain was predominant. Excluded from effectiveness was a predominant leg pain. And of course, the criteria was an ODI larger than 30 with no improvement in the conservative treatment. And it reflects more or less a real-life failure of conservative treatment if you treat this kind of patients frequently. The success or the superiority could be demonstrated clearly in a 24 months control. 144 to 76 patient population showed a high efficacy. And the patient is considered as a success when all three criteria are met. That means a meaningful improvement in the disability, larger than 15-point improvement in the ODI, no reparation at the treated level, and no serious device or procedural related adverse event. DM was 67.4%, the control was only 11.9%. And there was 55% absolute difference. So it's a very clear result that could be demonstrated. ODI responders were 77% versus 53, and back pain reduction 83 and versus 46 in the conservative group. QAL improvement as of 36 was 75 versus 40, so significant improvement as well. The reoperation rate was 6.6 versus 67, failure of conservative treatment. So it was clear beneficial to the normal conservative population. So we can say in conclusion that 92 back pain predominant patients analyzed for efficiency the mean follow-up was 11.5 years. So the ODI responders 86.4 in this group after 11 years. Composite success was 78%, and 90% of the devices are still implanted. So this is a meaningful number for such a small implant that can be easily applied, and there was no serious device-related problem. And the functional improvement, ODI improvement, was 15 points from the baseline. Secondary surgical intervention at index level, there was no removal, no reparation, no supplement fixation, and the serious device-related adverse events could not be seen, even after 11.5 years. Now coming to another problem, that's at the end stage of the scale. So we're talking about lumbar spinal stenosis. So where you have a long onset, elderly patient is the typical patient that affects that. And we will see these patients are typically wise. They have sciatica, choral. The Zurich score shows significant high numbers. We have a sensitive motoric deficit, the VAS, ODI, SF36 are not very good, and 3 months conservative care is not really helping. So these are the typical patient for the other implant that I want to introduce to you. A classic implant that where you have to do a direct decompression before you implant that. That's the Coflex. And it is also, when you look at the decision zone, at the treatment options, again, stenosis, you can do conservative care, multiple injection therapies when the ODI is smaller than 30. But if it's larger than 40, typically wise, the typical surgery that has been done so far is a fusion type of procedure. You can do only an indirect decompression, like with an interspinous implant, when you do not have leg pain, when you have more or less back pain, and when you have not a significant compression of your spinal canal and you have a nerval complex. If you have a simple decompression procedure without any restabilization, you might run into a problem that you still have low back pain because you have not addressed the facet joints. But we have now a new implant category that comes into the position, what we call the Coflex, because this can be used now in mild to moderate stenosis and also severe stenosis when you do not have a slippage, degenerative spondylo greater than grade 1. The implant is indicated and FDA approved for 1 or 2 level stenosis from L1 to L5. Also, at least 6 months of non-operative treatment should be present, and it is implanted in the midline between the adjacent lamina of 1 and 2 continuous lumbar motion segments, and is performed after decompression of the stenosis at the affected level. So this is mandatory. It's not an implant that you can put in without doing a significant decompression of the spinal canal. So you have a 2-stage procedure. Stage 1 is the classic decompression. Stage 2 is the implantation of the implant that takes, if you're an experienced hand, less than 5 minutes to put in the implant. It's well designed and with very nicely designed tools. Of course, you have a lot of contraindications. I will not go through them right now. But again, all the contraindications where you should not use posterior dynamic implants are also more or less valid for the Coflex. The Coflex is not a very new technology. It has been invented by French surgeons, Dr. Samani, first implanted in 1994. So it's really a kind of old technology that was lost, and Viscoliosi brothers found it back and brought it back into the market. And it's really a very useful implant if you use it in the right way. Like the Diam, like all these small implants, you have to look at the indications. If you choose the right indications, it's a very good tool for posterior restoration and a dynamic, motion preserving technology. In the meantime, there have been more than 217,000 usages in over 60 countries with excellent and good outcomes and a very low rate of failures. Failures mainly if the surgeons are not following the rules, if they are abusing the implant in degenerative slips over 2 degrees, if you are not doing a proper decompression, so then this implant will fail. The symptomatology, of course, radiculopathy, neurogenic claudication. This is the classic symptomatology of this group of patients, with or without back pain, and the shopping cart sign. Then the patient leans forward or sits, is improving, and if he stays straight or leans back, he has increasing problems. And these are the ideal group of patients that we have. If you look again in the decision zone right now, you have the 2 different procedures that are right now available. Procedure number 1 is the simple decompression that will be done without doing any support. But this, as we know, leads a lot of times to complication, segmental kyphosis, progressive degeneration of the segment of the disc in the front, and also leading to kyphotic and flat back syndromes in the lumbar spine. So you can now add fusion products. Right now, about 260,000 fusions will be annually done for this kind of pathology. So then, and that means a lot of times you're doing an overkill in the group of patients, because this group of patients has maybe a stenosis at 4.5, at 3.4, but the disc at L5.1 or 2.3 is also not anymore in a good condition. So you're creating a situation where you will have a higher rate of progressive adjacent level pathologies if you are completely stabilizing the spine without allowing it to move and to adjust. So you will transfer the loads to the adjacent levels, and you will overload them, and they will progressively break down quickly. So here the decision is you have moderate to severe stenosis, ODI greater 40, you have back pain greater 40, 50, you have a stable grade 1 spondy, not a grade 2 anymore, and you have an anticipated microinstability. So this is exactly the group of patients that you can use this implant. So that means a lot from the fusion group is belonging to this implant, and a lot of the 370,000 annual performed decompression alone can be used for this group of patients. So what is done? It's a spinous process, bearing laminotomy is important, stabilized motion at the posterior column. We have also stabilization of the segment, especially we maintain the height, the foraminal height. So this is very critical. Because if you lose foraminal height, you have progressively radiculopathy that can evolve. You can also have a facet arthritis, a progressive, because the facet will collapse more if you lose more disc height, if you don't keep it open. And it's definitely less invasive than fusion. It has less OR time, less blood loss, and less length of stay. It's a more outside patient procedure that you can do. So here you see the effect on the foramen that you can, when you put in this implant, it maintains the foraminal height. This is something, and it offloads the posterior disc and facet joint. So like the DiAM is doing, but in a later stage. So this is, if you're looking in a 5-year follow-up study, then we see the maintenance of the foraminal height could be demonstrated. It was around 17 millimeters even after 60 months compared to the preoperative height, it was almost the same height after 60 months. It can also, because it will be implanted, it has a serration in these longitudinal blades and in the wings, so it will also protect a little bit from sagittal translation, so therefore you can use it in spondy grade 1. Not anymore in grade 2, and it will have and offload the disc and facet joints, as you will see in a picture. So that means the mechanism of action is to preserve motion, constrained motion facets in the adjacent segment. It's compressible in extension, so it's a passive implant. It cannot actively control flexion. It will stay only in the neutral position, it will not be overbanded, so it's like a passive implant, a passive spring implant that maintains the distraction and allows full function of the segment. As you can see here, this is when the patient is bending, so forward, backward, so it will be compressed. And when the patient is flexing, it will open to the neutral position. When the patient bends further on, it will be guided to the wings. So that means the spinous process can glide on the upper spinous process, typically wise, we can glide through the wings a couple of millimeters and to maintain the mobility. Yeah, let's talk about the surgical technique quickly. So very important is the protection of the supraspinous ligament. We see a lot of times that people are resecting this completely, resect everything, and this is a very important ligament that helps you to restrain flexion. Especially the implant cannot do this, so therefore it's very important to keep it. So like if you put that, we are protecting that, we go superiorstally to the tip of the spinous process, and then we open it, we take a Casper spreader, so then you easily can see the two facet joints. It's a small incision from the upper border of the upper spinous process to the lower border of the lower spinous process, and you can you should also do a microsurgical decompression, that you should really maintain the isthmus, but you have to do a bilateral decompression. A unilateral decompression is not very sufficient, especially for this higher grade of spinal stenosis, and you should be making sure that it's decompressed on both sides to the lateral side, and it's very important that you really should check to the protect as much isthmus as you can. And finally, you do the trial application. We have different trials. We have 8, 10, 12, 40 millimeter heights with a special trial that you should apply. You should not over distract the space. That's very important. You see here it's a 10 millimeter trial. So you should not lift the vertebrae, that the vertebrae go into a kyphotic position. That's the same issue with all the posterior interspinous implants. There's all the time a mistake. For instance, you see here we are using now a 12 millimeter implant. Now the vertebrae is in a kyphotic position. So you have to go back to the definitely to the 10 millimeter implant. And finally, you drive the implant almost 1 or 2 millimeters above the dura, because the center of rotation should be in the height of the facet joint. That's very important. If you bring it too far back, you have two problems that you might address: a fracture of the spinous process, a migration of the implant, and not a very functional implant, because the center of rotation will be moved too far posterior, and it's not anymore in the axis of the spinal joints. And finally, what you do is you are reattach the supraspinous ligaments with transosseous sutures. That's very important, that you are bringing the ligament back to its original position on the top of the spinous process. Here, a couple of examples. This is a 69-year-old woman with a classic stenosis, hypertrophic facet joints. Here, the 3 months control, 12 months control, you see a good functioning implant and a good moving implant. Another patient, 65-year-old, spinal canal stenosis with hypertrophic flavum at 3-4. So we have decided to do a double level implant. So here, this implant can be used also when the disc space is higher degenerated. So because it's in a later stage of the process, and you will still have a good function. You see here, 3 months later, you see how nicely in the extension you will maintain the foraminal height and will allow flexion, and in 12 months you see the same result. So that's things, motion preservation surgeries per se are not replacing all other spinal surgical procedures, but they give us, the spine surgeons, a supplement possibility to address segmental pathologies much more precise than we could do it in the past. And we have to understand, this is a soft tissue disease. It's not a bony disease that you can treat. A fracture you can easily treat. It comes to restitutio ad integrum, but this soft tissue disease will not. That means we are treating only the mechanical consequences of the disease in a specific area. We are not treating degenerative disc disease at other levels when we're doing that. And like in odontology, where each tooth has to be evaluated and treated individually, I personally think when you do this kind of tools, you should really look into this situation, that you treat each segment very individual. That means in one stage you can use the Coflex, when you have an other level where you can use an artificial disc, or you can use a DM in a less degenerated disc. So this is something, it's not one procedure fits all. If you have a fusion, you fuse the whole lumbar spine, including the pelvis. So I think this is not the goal when we are treating degenerative disc disease. And this can be the train of motion preservation clinic in the future, if more surgeons are doing that and more people are looking at that, because my motto is life is motion, motion is life. And the purpose of learning is to become an independent thinker, not a mindless follower. That's important when you start to run a technology forward, like all these 4 speakers are doing in their field, running the technology forward. So thank you very much for your attention.
Outstanding lecture. Keep your slides on. So we'll have to rush a little bit because we're going to go to the lab and we'll do a quick tour of the exhibits and some interviews that I'll do. 3 quick questions, 2 from the forum. If you can go back to a DM slide, one of the DM slides with an MRI with it. So can you actually slow down disc disease by this dynamic on and offloading device? And how is that different from a Dynasis device, which was a dynamic rod distractor compressor?
Yeah, I double check where is the slide.
That's okay. Otherwise, you can just extemporize.
Yeah.
Or extemporate.
I don't have the slide.
That's okay.
I think a very good question. So we have demonstrated that you slow down the degeneration because you're unloading the posterior part of the disc. That means if you are shifting the loads back in the right direction, you allow the segment to be restabilized, and if you have not this micro instability, the cells can recover and they can restore more water content into the disc space. So this is what we have seen in a lot of MRI scans, that you have a kind of black disc, and after 1 year, after 1.5 years, suddenly the appearance of the disc is becoming normal according to the water content. So that's important.
So you've seen that on MRI?
Yeah.
Dynasis, yeah?
Yeah. Dynasis is not really a dynamic tool. Dynasis is, I would say, an elastic fusion device. We have seen that also when you go for motion pictures like flexion extension X-rays, you see this segment is not very much moving at all. And this was the problem also when you do it in multi-level, because it's a kind of hinge implant. It's depending, the flexibility is depending on the length of the sleeve. The shorter the sleeve, the less mobile this will become. And you have a much more aggressive way to anchor it with pedicle screws. And we have seen with all dynamic implants, pedicle screw based, the biggest issue was screw loosening, because you are not fixing the space and you have a very unfavorable load pattern to the screw. So a lot of the screw become loose and they are not really allowing a proper motion like Diam or Coflex.
Great answer. Second question, Coflex. Often asked question. So, by the way, I'm a paid consultant for the company, but I'm a believer, and I became a consultant because I became a believer. My clinic staff thinks this is the most favorable procedure of all the surgeries I do. This is the question I get asked all the time. How long do those last? How long does a Coflex last? What's your experience with that?
My experience is I'm doing it, I think, more than 25 years, and we have not explanted a single one so far because it broke or something happened. What we see sometimes, even the Coflex is covered with bone on both sides. So the bone grows over the Coflex and it allows now in both directions a control. The only thing is when you are not taking care on your spinous process, because your spinous process can tolerate a lot of loads craniocaudally, but not to the left or right side, to the lateral band. And if you put in your implant, you crimp the wings, so a lot of times you easily can destroy it, or you can create a fissure, an undetected fissure, and then this implant will fail.
So then the question I'll ask Dr. Shafri to come and join me here and take the microphone also in a second. What took so long? So Diam and Coflex, you showed us that they were around 20 to 30 years ago. What took so long? I know we're a little bit slower here in the US and we have higher regulatory burdens, but what took so long?
I think it's the mindset of us, of our group of surgeons, because surgeons are not believing in motion preservation so far. Everybody was going into fusion procedures, and even now, and nowadays, we'll discuss this in my next lecture even more aggressively, we are not talking about new concepts when we are talking about a new cage, an expandable cage, a new pedicle screw to put in. So this is not a new concept that we are using. It's a new tool that we are using that brings a better result maybe in fusion, but not in motion. And I think this is the biggest issue. And motion preservation per se needs a little bit of higher precision. And unfortunately, the reimbursement is not as good as when you fusion. So these are factors, the learning curve, a higher precision, and the less good reimbursement. These are three factors that are not leading to an exploding application of these tools.
Quick point, counterpoint, and then we want to take a break, and I'm going to do some interviews for our guests online. I have a couple of target addressees there, and then we'll switch to the lab. We have the former president of AANS, SRS, CSRS. I'm forgetting some of the organizations. There's little doubt now that somewhere between half and 3/4 of adult spinal deformity surgeries are done after L4 through S1 has been fused somewhere. Where do you, as one of those big picture people and one of the senior minds in deformity surgery in adults in this country and beyond, where do you see dynamic fixation fitting in? Is there a niche? Is this an expanding proposition? Where do you see the wisdom in this? And maybe we can have a very quick point counterpoint before we move on.
Well, I think that this is a spectrum of disease that Rudy showed so nicely. So I'm part of starting a trial right now for using multifidus stimulation for early degeneration. I think that there are certain things that build together to lead to the end stage severely degenerated disc. One of the problems in the United States, and I'll give a classic example, is cervical laminoplasty. Most people feel that that is a better, if you look at all the literature, look at everything that goes on, cervical laminoplasty is probably a better operation for multi-level cervical spondylotic myelopathy than any of the alternatives. But because it doesn't pay anything, people don't do it, or don't do it nearly to the degree that they should do it. I think some of these technologies, which is the initial step, which I may think is biological, whether that's going to be disc regeneration, whether it's going to be things like multivitous simulation, probably should be done very early in the cascade. If things move further, then I think things like these dynamic stabilization devices make total sense. Then finally, if you get to the end stage, and there's some people who degenerate who are not particularly symptomatic. We don't understand this. This thing moves forward. They have minimal symptoms. Suddenly they have an advanced degenerative condition when they have symptoms of neurogenic claudication or whatnot. But I do think that during the course of this, the appropriate treatment for the earliest stage possible should be what should be done. Now, what happens, there's always a gray area as one phase goes into the other, and whether fusion is better than dynamic stabilization or vice versa. That's the area where the debate is. But I do think that we have been, motivated towards doing a laminectomy versus doing an entire reconstruction, and all the intermediary stages have not been well developed. I don't know if there's a debate, but I do think where the debate is sort of the gray area, okay? If you have a grade 1 spondy, is dynamic stabilization or fusion the better option? And I think that there's probably a multiplicity of factors, including what the spinal alignment is and what other different things are going on and where exactly the compression is, whether it's sort of an up-down compression versus something else that's going to go and define these things. Rudy?
Yeah, I agree completely. Therefore, it's not really a counter-argument, but when it comes to motion preservation, we have something in our armamentarium that I will show you in my next lecture. So we have also tools where we can do all that realignment of the profile, restabilization, that what we call 360 motion preservation, and you will be amazed what you can do with that. And in my perspective is all the time, can I go back when I do something for the patient? For instance, this little implant like the DM implant, we can almost aggressively say if it does not help, it does not harm so much. If I do a fusion at the first step, fusion is fusion. There is no alternative. You can go back and maintain it mobile, because we know a lot of times when you are not selecting the patient, the right patients, even fusion procedures are not the holy grail for an improvement of your patient. And therefore, I think if you go what we call a step algorithm, so we should go to a smaller procedure if possible, if it fits in the right stage of the degeneration, instead of the bigger tool, because an overkill can be done quite easy. But if you go below that, you can go easy to the next step, and the ultimate step is fusion. So that means if I have a couple of more steps in between, I can treat my patients like a dentist. A dentist will not extract your tooth right away. When you have a small carious hole, it will start to do a filling. So this is something we have to teach our patients and to train. Independently what we are doing in degenerative disc disease, we cannot solve the problem of the patient. We have to follow him up and guide him through the whole phase until he's aging and getting older.
And maybe you're going to address this in your next talk. I think the biggest thing for me where the debate is disc arthroplasty in the lumbar spine and where that fits in within the spectrum of care. And part of the problem, where I think, at least for me, and I remember when Jens was doing the ProDisc in part of that trial, it's an operation that I think is so dependent upon absolutely precise placement. And it just doesn't tolerate. Cervical one can take a little bit of imprecision and placement, but I think that was the sort of the death knell of the United States. It wasn't the technology. It was that not as many people could absolutely precisely place the arthroplasty exactly where it needed to be due for it to work well. You put it 2 millimeters too far, front, back, side, whatnot, and you just didn't get a durable implant. So how does arthroplasty fit in your spectrum? Are you going to address that in the next talk?
Yeah, this will be my next talk.
I have one very quick question. We have to do one sentence answer because, well, I'm not going to do the interview. We'll not take a break. We'll switch straight to the lab. This is a quick question. Why would insurance companies, and this is difficult for you to answer, in our country, put such a roadblock on interspinous or interlaminar dynamic fixation devices and rather have patients undergo a much more expensive and much more sequelae rich fusion surgery? So what is the blockage that you could see for insurance companies making it so hard for us to fight for these devices?
Because I really think it's an early stage procedure. And they would rather, I think in their minds, pay for things like facet injections or ablations or other alternatives rather than early stage. I think there's always the opportunity for kind of abuse of any new technology. So I think that they're concerned that if they pay well for it, that there's going to be an abuse in its application, despite the fact that tremendous benefits that it may have. And this is, again, and I'm not as big a believer, I'm actually a bigger believer in dynamic stabilization than I am with SI joint fusion, for example. But the different companies for SI joint fusion really did a good job, I think, of showing evidence after evidence after evidence of how that is an advantage to patients and in the long term may reduce overall costs. I think the same thing, if it goes, and this is part of our discussion about why we're doing this trial for multifida stimulation for early stage degeneration. If we save all the sequelae, then we save hundreds of millions of dollars if you can prove it, but you have to have the evidence to make that happen. So that's my belief in the United States. It's not that the technology isn't good, it's something that they're thinking about it either being overused or are we adding something that's not eventually going to lead to additional additive costs down the road? So I think as the more and more evidence is brought to bear, I think that you can influence insurance. I mean, it's kicking and screaming and against it, but that's the trouble with the U.S.
Yeah, I think we don't have this trouble, thanks God, so much, but we are moving into this direction because European health systems are slowing down. And even in Germany, Italy, France, we are moving into the great system of Great Britain. So we want to delay surgeries, want to pay less. I think yesterday was a big discussion and a debate in the German politician sim, and they were voting on a system where they decrease the costs by not paying this kind of procedure. So we're moving also in a bad direction. But I think education of insurance members is one of the most important, and education for our society members like the NAS. If we are pushing these technologies and we are agreeing that we have good benefits, I think insurance will follow as well, because right now, why is cervical arthroplasty now becoming almost the gold standard? Because patients are demanding it. And patients are demanding it, surgeons will follow because they don't have, if they have less patient, less income. And insurance will also follow because patients will aggressively go behind insurance and will make litigations to the insurance. I think this should be done.
Fantastic. We need to, I apologize to everybody. I ran over, me, I don't like to do that, but this was so thought-provoking and so important. So thank you for your presentations, discussions. To be continued, and we'll switch to the lab. And I think we're ready. Gary is here. He's running our lab so wonderfully, and Anthony at the switchboard. And we're going to have Dr. Nick Theodore, hopefully live. Here you are, and tell us who's with you, Nick. We see you. Can we have an audible?
All right.
You're sounding loud and
Are we live already?
we are ready. Can you hear us?
Yes.
I see Dr.
Okay.
Theodore.
All right. Well, welcome to our first live demo. We're going to do a robotic-assisted T-lift for the most part. What we're looking at, and can't see the screen of the robot, but anyway, I guess, there we go. So we've got three basic ways that you can register the robot. The first of which is intraoperative CT. So whether it's Globus's imaging system, the O-arm or whatnot, we can actually acquire the images in 3D in the operating room. Second is, which is a very common workflow, is preoperative CT. So you can actually get the patient a CT scan prior to surgery, then in surgery, get AP and lateral x-rays, which merge the preoperative CT with the patient. That actually cuts down on a lot of fiddle factor, especially if they're bringing the imaging system in as a problem, or if you don't have an intraoperative imaging system, then you can go straight to the case. The other thing about using a preoperative CT is that you can actually plan. So what we're looking at here on the screen is a plan for an L45 TLIF. We've actually planned screws out from L2-1 or L3-1. But the nice thing is that everything lines up. So as you're planning, you have the ability to make sure all your screws are lined up. The second thing is you can stay away from the adjacent facet. I think that's going to ultimately decrease the chance of adjacent level disease, and we're starting to see that now by staying away from the adjacent facet. The third thing is that you're able to plan large and long screws. So for years, I remember tapping and putting a pedicle probe in and saying, okay, give me a 55 millimeter 6.5 screw. But here we can put in much larger screws because we can actually plan to the width of the pedicle, or in some cases, even a little bit beyond to expand the pedicle. So again, three workflows. The third preoperative workflow is intraoperative fluoroscopy. You can actually get two pictures, an AP and a lateral fluoroscopic image, and navigate off that. So you actually have three different ways that you can register to the spine. One of the things I want to show you, if we can go back to the pan view here for 1 second as we start, is that we've got two trackers in. We've got a dynamic reference array that we put into the PSIS on the left side. This is made to be able to move. So if a sucker cable gets caught onto it and it will move, you can click it back into place. And then the contralateral PSIS, we place what we call a surveillance marker. This improves our accuracy. This also lets us know relatively if the tracker gets bumped. If you're doing any sort of image-guided surgery and you bump the tracker, your navigation's off. If you're doing an MIS case, you may not know that your navigation's off. Having a second distinct reference point that's triangulated with the RF camera gives you the ability to understand if something moves or not. So we're planned right now, and I'm going to take a skin knife, it's a regular. And what we've done, we've planned screws at L4-5. I'm going to make paramedian incisions. There's many ways to do this. Some people do this through very small, just stab incisions, and you can do either way. I'm going to let Dr. Rosinski, my partner, do the other side, all the way through the fascia. Make it a little bit longer than you need, just so we're not struggling there. Okay, so we'll start on the right side at L4. Yep. So the frame is turned green so that we know that when this circular is green around there, we know that we're on trajectory. We're going to start off with a burr to get through the outer cortex. And you see we've skived a little bit. So you can see here, this is a beautiful representation of coming down on the side of the facet joint. So how do you correct for that? Start a little bit above, get lined up. And then from there, we'll go to, that was to get through the cortex. Now we do have a drill now that is able to do this all in one. We'll go in, fall into that same hole. You can see we're in the hole, get lined up, take us down the pedicle. I'm not tapping anymore. I'm going straight to the screw. we're skiving a little bit there. Let's see. We're not in forward. I don't know why this is not. We'll just resettle the arm for a second. Make sure that we're on trajectory. We see the tap, we may be a little frozen. So tap for 1 second. Sometimes when we have a very frozen cadaver, we'll get a little bit of stiffness in the bone. Yeah, that's on. Off. And we just pulled the screw out. Go to L5. Our bone quality is not great here. Yeah, don't pull in the skin. Yeah. You can see going down that same track now. We'll do the tap for a sec. Yeah, the bone quality is a little soft. And you do have to be careful in soft bone that with the drill has a positive stop on it. So you definitely are safe in most cases, but you want to make sure that much better here. Now we got some good bone purchase. Sometimes with such good bone purchase, we'll take this off to be able to take this. Then we'll go on to and you see the robot will move up and away from, assuming that there's a tower there. Coming into trajectory here on the left at L4-5. Got my able-bodied assistant here, Dr. Rosinski. So again, let's get through the, good. And you're just gonna let the drill come down. Now you're gonna touch, so again, look what's happening. As you're hitting that facet, you're sliding off. So let's get yourself positioned right over. All right, and then back up just a tiny bit. There you go, and go ahead. Full speed. Yep, push a little bit. Now, you felt that, you saw that. So you have feedback, and I think that's the most important thing. People think you're doing something MIS or you're doing something robotic that you're losing feedback. The reality is you're not losing feedback. You still can see, you can still feel. Should go, let's, yep, we're sliding down that side, so let's go a little bit more medium. Yep, into the hole. Yep, there you go. Beautiful. Spectacular. So you've done this how many, 500 times, 700 times? So this is his first time, right? Second time? How many times?
I don't know how many times. Good amount.
Fair.
Good amount.
All right.
More residency than here.
Beautiful. That's enough. You're just getting past into the pedicle, you're good? And it'll just, yeah, we're good.
What's Dr. Brzezinski's heart rate right now?
His heart rate is 110,
Not even
but it's
close.
down from 140.
What's your heart
Not
rate
even
when
close.
you have a fellow put in a screw with robotics or without? Is there a difference in your heart rate?
Heart rate's lower with robotics, 100%. Because I can see, you know, and you've got, and everybody's got feedback. Otherwise, my hands on, you know, I'm watching and I'm, you know, so it's definitely changed the paradigm of teaching, that's for sure. You can see the whole, two things, listen, you hear the chirp of the pedicle. There's zero doubt that you're not in the pedicle here.
It's called bone music, Dr.
Bone music.
Oh, music, that's
I
right.
love it. And I know that you play that in your car on the way into work in the morning.
What about power?
So you can, so I will tell you that, you know, you do this your entire career, you're going to be probably susceptible to ergonomic shoulder injury for sure. Putting in power, you still have some of the same feedback. I tend to, for the MIS cases, you know, still for it's a single level, just doing freehand. But you definitely can use power. If you're doing a big scoliosis case, it's very nice. And you do still get some feedback as you're doing that.
Thanks.
So again, we're not the best plan there. So we've got a little bit of, so what you could do, just to come out for 1 second, we can go to plan for 1 second. And we'll go down to left L5. And let's just take that screw a little bit more medial. Let's see here. Why are we not, where's our plan? So the nice thing is, you saw we were skiving a little bit, we can change that plan so our entry point is going to give us a little bit more reliable landing spot, then pull the screw out laterally a little bit. Let's do that. Then we'll reposition. So the nice thing is that you can always change on the fly. For a single level case, it doesn't make a difference, but for a multi-level case, I'll tell you that planning is critical because you want to make sure everything lines up.
Hey, Nick.
Yes.
This is Rod. I have a couple questions for you.
We're still a little bit lateral.
Can you hear me okay?
Yeah, we can hear you.
Okay, great. So what are your thoughts on, you know, I've started using the robot in the last year, and it's kind of a
come out one
different style of operating. And, you know,
Yeah,
I
that's
do
what we make
think,
it more medial. Come out for a sec.
I do think robotics is going to change the game in spine surgery. And I think it's going to do it in several ways. I think the first thing that it's going to do, and I think you talked about it a little bit, but, you know, I do think there is a cognitive load that we all kind of bear when we do these bigger cases. And I think some of the cases that, you know, all the surgeons today showed, like, you know, the deformity cases, the revision cases, don't you think that it's, when you use a robot and you do it
You keep slide. There you go.
precisely like the way you're doing it, don't you think it's funner to operate and it's not as stressful?
Yeah, 100%. So we trying to quantify what we call cognitive load, and you know, if you're doing something, whether it's freehand for sure or with image guidance, your attention is either looking at the anatomy or looking at the screen. And the fact of the matter is that, you know, when you've got this locked into place and your trajectory is reliably locked into place, it's less of an issue from a cognitive load perspective. So I will tell you that, stress level goes down for sure. I'm not holding Dr. Rosinski's hand or the fellow's hand anymore as I used to say, okay, we're a little bit more remedial on that because we've taken the time to plan. So 100%, it is probably added, 2 coronary arteries and a significant amount of less stress in my life. But again, you've got to be always diligent, and things can go wrong no matter what technology you're using. So it's really about knowing the system, what the limitations are, and then what your bailout strategies are. So 100% it's a different way of doing things. When things go well and you've got a well-placed team and you're doing and using the technology on a daily basis, it becomes a lot easier. Feel like you're in?
Yeah.
Yeah, you can hear it. So we can hear bone music, as Dr. Chapman talked about. So you've got the tactile feedback.
Yeah.
You can actually hear that we're in the pedicle. We've got great purchase. Dr. Rosinski's getting tired now.
And then Nick, can you talk about, because this is one thing I struggle with using the robot,
I think you're good.
is can you talk about soft tissue? Because, you can put in all these screws and they all look great and they're perfectly placed. But then if you're doing it percutaneously, how do you get it to fuse? Because this eventually has to fuse, right?
Yeah.
So what are some tricks, like you showed some of those cases where you did percutaneously for trauma, but most of the cases we're doing, they're degen cases.
Yeah.
So for example, on this case, is 4 stab incisions really minimally invasive? Or is it better to do midline and do transfascial? Can you talk about what
Sure.
you normally do? Because I do think the soft tissue thing is a big deal, and we oftentimes don't talk about it.
Yeah, that's a great question. So I will tell you that if there's, the disc, if you can get a good reduction, if the patient's not, if the stenosis isn't critical, if you don't have a severe stenosis. So if somebody, let's just give you the extreme example, bilateral synovial cyst with complete obliteration of the canal, probably not going for indirect decompression. In that case, what I'll do is I will make a midline incision and plan cortical screws. So small midline incision, cortical screws in a sort of an upward and outward trajectory allows you to exploit the midline incision, then do a regular laminectomy, and then go ahead and just connect the screws if we're not doing an interbody. So a 70 or 80-year-old person, grade 1 slip or severe stenosis where you're gonna have to take a lot of the facet out, the midline incision, cortical screw, beautiful opportunity to do something in an MIS version. In a younger patient with an adequate disc height and where you're going to get good indirect decompression by 2 things: expanding the disc height and realigning the spondylolisthesis if they have it. This is what I prefer. On one side, on the left side here, you've got 2 screws through the fascia. On the right side, I would do a T-lift. I'm going to show you, let's just show the plan for that for 1 second. We don't have to show the whole thing. Yep. Yeah, so we've planned a T-lift here. And in this case, what we would do is I would just put a retractor in. I'm not going to do the whole thing. I would put a retractor in, drill the facet out, and now with oscillating drill technology, the DuraPro, for instance, I'm really now, it's safe when it touches the Dura. So literally that facet can be removed in about 3 or 4 minutes under image guidance. You got an image guided drill. We'll remove that facet on the right and planting on whichever side you want, and then enter the disc space. We now have technology too, Rod, where we're able to clean the disc space out. So we have a disc brush, goes into the disc and basically vaporizes the disc. So we're able to do a very good, without violating the end plates, removal of disc material so that we prepare for a fusion. I'll put a couple of end plate elevators in, under direct vision, go ahead and open the disc space up. And then the nice thing is your watch, you've got ring curettes, you've got all trackable instruments, which is the interbody. And then ultimately, once the facet's out and you're in the disc, under image guidance, we're able to put the implant in, at L4-5, put that in, and you're watching exactly where it's going. So the other thing you've done is completely eliminated X-ray in this case. So once the facette's drilled out, I'll have planned the interbody device, be able to mallet that in and then expand it, and then you're done. So you can see, literally the screws you can put in about 5 minutes. The TLIF drilling under image guidance takes 5 to 10 minutes. Disc space prep is probably the most important part once you're in there, and however much more decompression you're going to do. So with a lateral retractor, if you need to do contralateral decompression, you can do hemilaminectomy. If it's really more of an indirect decompression, doing a nice vasectomy and getting a nice expandable interbody in there allows you to reconstruct the spine, reconstruct disc height, and then also realign the spine as you lock the pedicle screws down. And that's your MIS TLIF.
So, Nick, you're obviously a superb surgeon and engineering visionary. How good are you to rebalance the spine, honestly? This is my single biggest remaining gripe. Can they hear me?
Rebalance the spine. How good are you at doing it?
Rebalancing? Yeah. So listen, I think one thing I'll tell you is now with expandable technologies, which are lordotic, we're doing pretty damn good. The other thing is, which we didn't talk about, was picking the right patient and then picking the right operation. In the prone position, we're doing now prone lateral surgery. So getting really good correction in the prone position, doing 2 operations, doing lateral interbodies in a prone position where you can exploit lordosis. Your fellow was just telling me about a high-grade spondy he did where, positioning is everything, but utilizing the positioning so we get that patient positioned correctly, getting our devices in. So it is all about balance, and it is all about restoring balance. So I think we're pretty good, but you have to understand up front, we're not just doing a TLIF for the sake of doing a TLIF. We're also being able to use technology, like I said, lordotic cages, everything else to be able to reconstruct the spine. You always have to think about that. And so the reality is, think of where you want to be, and you think of what the best operation is to get there, and tailor that approach to the patient.
Want to thank you and Dr. Morzinski, unless there are other questions, and Globus for this very nice demonstration. This looks really cool. So thank you.
Thanks. Appreciate it. Thank you.
And in a quick switch of plans, so that we stay on time, but also give the lab a chance to retool for the next cervical pedicle screw fixation session presented by Dr. Shaffrey. We are inviting Dr. Rudolph Bertagnoli back up here to kind of complement his prior dynamic fixation lecture with something that I think raised a lot of eyebrows. I've seen this before, and that is basically a dynamic stabilization of a multi-level degenerative spine. So Rudy, look forward to this.
Yeah, thank you, Jens. And my next lecture, I will move forward from the smaller posterior procedures, and we are looking forward, can we go further on? And I already mentioned it when that's the title, because I chose my title, Refuse to Fuse. It's not because I want to compete with fusion, but I want to show you a way that maybe fusion is not all the time necessary in degenerative cases. Because we are talking a lot in the last years, if you go to all the meetings, we're talking about new cages, 3D printed cages, lordotic cages. We just heard lordotic cages. But these are only better fusion products, and it's still a fusion philosophy. It's not really a new concept. What is often sold as new is, in principle, remains unchanged. It's more or less a rigid stabilization by eliminating motion. If you put in a cage, you eliminate motion. If you put in create a fusion, you eliminate motion. So this is a product evolution and not a paradigm shift. And I think the real question is, which fusion brand is better? It is, do we still need to fuse? This is our real question, because when we discuss technologies, we must also compare mobility system, not brands. It's not the car A versus B or versus C. This is an optimization within the same paradigm. But if it comes to, is it better to ride a car, a train, or a plane, or even an air taxi, that is changing the mobility concept itself. Dynamic reconstruction is not a better cage. It's a different answer to instability and degenerative conditions. You restore stability while preserving motion, and that's the big difference. So refuse to fuse, restore motion, and preserve function. This is the topic of my lecture today. And we have seen this as we are treating a chronic disease with different phases. And like with other chronic diseases, a continuum of care is necessary, in my opinion, because in the past, we have developed more or less a black and white view. So what we have done is decompression or fusion. There was no room in between, and still a lot in the mindsets of our colleagues. And not everybody is ready now to go something in between to look at this grayscale. We have also developed a kind of static view thinking in two planes. So we are not, a lot of surgeons are not asking for a flexion extension or for a dynamic MRI scan. We are looking at static views. But the reality, the spine is a dynamic organ. So if you look at this dynamic MRI scan, you see what is on the left recumbent, you think everything is okay. But if the patient is in dynamic MRI, standing up, leaning forward, sitting, you see, okay, now you see the problem very obvious. So we need, if we want to treat motion, we need also to have at our standard standard diagnostic, we need functional X-rays, MRI scans. This is very mandatory. The cascade, we have seen that. It's a moving end. Right now, if it comes to the treatment option, we have, if we're going from the left to the right side, we are increasing the treatment size. And with the treatment size, the risk and the collateral damage. We have to keep in mind this is all the time also a thing that we have to understand. How much risk do we bring our patients into when we go to a big procedure like a fusion procedure? You see there already there's a big gap between open disc surgeries and fusion surgeries. And we more or less have only 3 steps available. So have we created a new disease when we do fusion, adjacent segment pathologies or transitional zone syndromes? Now I think it's very clear. We have a lot of literature that shows exactly that this is something that we have created when we are fusing our patients, because again, DDT is a soft tissue disease and can affect all the discs like osteoporosis. So you do not have when a patient has osteoporosis, all the bone densities in all the bones are not optimal. And if you have degenerative disc disease, all the discs may be affected. That's the reason why you have a lot of times patients with lumbar problems, but if you look at their cervical spine, they have problems there as well. And we have a lot of patients coming with both areas, and we are treating them. Because why do we create adjacent segment problems? We eliminate motion, and therefore we increase the stiffness in that area. And we are also creating, by doing so, an abnormal pattern of stress flow, because we do not allow a compensation in flexion, because nobody of you except myself does have a nice lordosis at this moment in our lumbar spine. All of you have a flat back or a slight kyphosis if you're sitting there like you. So that means this is a typical course of patient that gets a fusion when he has a degenerative disc disease like this patient. And you can imagine this is a floating fusion. What happens to the level 3, 4, and 2, 3? This is a no-brainer that this patient will come back for a 3rd operation. Or we're seeing more, these pictures, beautiful, hundreds of screws, well-placed, but the patient is now an ankylosing spondylitis patient. You make out of a mobile patient an ankylosing spondylitis patient. And what is all the time the problem? Why we went through the L5S1, did not want not to be fused nicely. So we went to the pelvis. We even fixed now the ISG joint. So this is now a big problem. And if you are not doing the right angulation, the right profile, and a lot of time it's difficult to do that, then your patient will have still problems with his posture, and a lot of times you go back, you do a relocalization procedure by an eggshell osteotomy, and you're bringing your patient back into balance. But the question is this necessary all the time? Because approximately 30 years ago, we started to introduce a really new concept, restoring segmental stability without definitive irreversible destruction. And you see the difference. Here, a patient that has been fused developed an adjacent level problem at L5-1. And you see how much is the motion travel when the patient is extending and flexing. And look how much the angle at the upper level is. So it's creating a hypermobility for sure, because the spine wants to compensate the missing compensation capability out of 2 levels now at the 2 adjacent level. So we have 5 discs in the lumbar spine and 2 are already fused. So the 3 that are left, they want to compensate that. And if you go for motion preservation, you see a harmonic distribution of motion through all the 5 levels. The patient bends forward or sitting, you have a straight spine. If he's leaning backwards, he has a nice lordosis. So in 2001, the FDA trial, so it's almost 25 years ago, started here in the US, and 24 months follow-up of 292 patients. And the summary was that the ProDisc was shown to be superior to fusion, even at the fusion rate of 97% in a lot of factors. So this is something that has been demonstrated clearly. And why? Because if you look at the conceptual differences, so we have a couple of things that we do commonly. We remove the disc, we restore disc height. But this is what we're doing with both technologies, but then the difference starts. We eliminate motion, restore motion, we eliminate balance, restore spinal balance, progressive damage to adjacent segments, and we are not overloading adjacent segments, but we cannot protect the adjacent segments. This is also something we know in nowadays. Because we keep it on the natural history level, we see degeneration at adjacent levels because we cannot treat the disease. This is the problem. And it does not preclude fusion. That's all the time a good thing. You can't go back to fusion in the future, so you save the patient maybe 20 nice years when he's young. We also have figured out which are the ideal indications with our good indications, with our expanded indications. And we see if you do more, you can expand also wider your patient population that you use this technology. So this is a single level application. See, without doing an angulated cage, we don't have, this is a 3 degrees disc, that means 6 degrees. It reflects the normal position, and the patient is now able to find his personal individual profile. We have not to calculate, we have not to put in a 12 degree cage or 15 degree cage to keep in lordosis. No, as soon as you put the center of rotation to the right spot, the patient will find its own profile that he needs. So this is the beauty of it, or like this case that demonstrates clearly the benefit of motion preservation. You're not creating a floating fusion. If you treat this patient, you keep the level, you treat the levels that are affected, and you have a mobile spine 31 months later, and a very mobile and functional patient. So you even can treat, this is a two-level case where you have an asymmetric degeneration. We also have to address asymmetric degenerations. In the 4-5, we have a scoliotic degeneration and a kyphotic fixation at the 3-4 level. So if you remobilize that well, this is a surgical procedure, the disc will work well and maintain a normal profile, and you have a mobile spine. No need to address the upper and the lower levels, no need to do it more than necessary. And now coming to the what I call extended group, this is out, it's not in label here in the US. I address this, don't do it at home because you are running out on a very thin ice and nobody will support you because this is not approved here. We are lucky that in Europe we can do what we think is good to the patient. As soon as the implant is improved, we can do 3 levels, 4 levels, 5 levels, so we don't have this limitation that you have. But we are running into this problem. So this is a 3-level indication. As you see here, we have 2 levels. It's all the time the typical things. We have no space at 4-5. We have no space at 5-1. And we have a hypermobile segment at 3-4, the typical evolution of a natural kind of fusion disease. And by putting in the disc, you remobilize the 2 other levels, and we reduce the hypermobility with the disc. And this is only because we're using a ball and socket concept. We are using not an unconstrained disc. We're using not an elastomeric disc. This is something you have to know, and you will know it if you have done a couple of thousand. I have so far done about 15,000 discs in the cervical and lumbar spine. After a while, you understand what you're doing, even if at the beginning you are not understanding what you're doing. So you can go to 4 levels, but you have to be precise. Precision is key and mandatory. And this is the reason why we are also working on a robotic-assisted application, because with a robot, you can understand much better how to put in your disc in the right spots. It's a little bit more difficult with to find the right spot for to figure out that your robot knows where he is, because we don't have these nice anatomical structures in the front than we have in the back. And you can go 5 levels, so that's what you can do maximum in the lumbar spine. And you have still a mobile spine, and you don't need to look at the ISG problem. You don't have not to fix the pelvis to the spine. You allow the patient to do there. And we can go even further on, because what are we doing with these patients? Okay, you see there's a 54-year-old degenerative scoliosis, slips, lateral listhesis. We see a progressive, on the right side, a 56-year-old surgeon that was minimally invasively fused 4-5, but still not addressed the problem above, and still maintenance of the degenerative scoliosis that was progressing. Now we have to look again on the global motion segment restoration. So this is very important, because we know anteriorly you have the disc as a dominant mobile structure, and posteriorly you have the facets and the ligaments and tension bands. So if you have a more progressive degeneration with a development of a degenerative adult scoliosis, you have to do more. You cannot use the disc alone, because then you will have a failure, for sure. The disc is not able to correct rotational deformities like in scoliosis. This is not possible. And because if something happens in the front, all the time something happens in the back, because a motion segment consists out of an anterior and posterior elements. And if something happens in the front, something happens in the back. So, and you have to address that. You have to analyze both sides, not only the disc. And the motion segment is a 360 structure. It's an anterior disc end plates dominant mobile load-bearing structure, of course. Posterior, you have the facet and tension bands, ligaments. These are guiding the motion and prevent hypermobility, so that's very important. And the instability is therefore a whole segment failure, anterior and posterior. So we have to give up anterior alone or posterior alone. We have to see the segment also all the time, three-dimensional, 360 degree. And therefore, when we want to restore it, we have done this in the past with 360 fusions, because we have seen posterior fusions alone was not as good as 360 fusions, because we could not restore the doses as much as we thought we could. Therefore, we have developed all these cages, and now I've started something in 2007, what I call 360 motion preservation surgery. So we're still addressing both sides and still maintain the function. So this is important, especially when it comes to stenosis. So the concept is 360 motion. And what is it? It's a combination of arthroplasty in the front that will address the disc failure and the posterior dynamic device that control the facet joints that lost the control and the ligaments that lost the control of the segment, and allowed the segment to rotate and to address other levels also to degenerate. This is the regular evolution of a degenerative scoliosis. So, but you cannot use all implants that you think. We cannot use kind of hinge implants that are available from different companies, Dynasis, we have discussed this before. These are flexible fusion implants. These are not really second generation motion implants, because when the segment moves and flexes, what happens to the position of the upper pedicle? It translated to the cranial side and also to the anterior part compared to the lower pedicle when you fix it. So this is very important. So you need a rotatory translating device like we have designed with the DSS. This is a true dynamic device. You see here, this is really opening a device that allows distraction and rotatory translation, but it will block rotation. So and that's the key. You can even remove the facet joint and the system will allow you to control rotation back to normal 1 to 2 degrees. So this is very important. And only with this combination you can control a scoliosis, a degenerative scoliosis. Here, a case, you see a slippage at 3-4, at 4-5, and degeneration at the levels above, not as severe, but you see here and the facet that's opening. So this is something you can do, a combination you do in the slipped segment, a 360, and you can go with the disc at the other levels. So this is something that helps you even 24 months later to maintain a mobility and not to allow progressive degeneration when you would fuse L4-5. It's the segments below and above is very much in danger to progressively degenerate, and the patient will have a second surgery. For this kind of patient, where you see already, okay, you have a retrorlisthesis L5S1, no disc space available. You have a disc space loss almost 80% at 4-5, not moving too much. You have a lateral and asymmetric degeneration 4-5. You have an asymmetric degeneration 3-4 as a compensation. You have a slippage 3-4, grade 1, and you have also an hypermobile segment above at 2-3, and then beginning degenerative scoliosis. So this is the MRI scan, severe stenosis, and also hypertrophic facet joint. Yeah, I would say the whole spine profile is not in a very good shape. So what you can do again, we can control all the problems. So we control the AP profile by using the system, and we control the lateral profile, and we restore disc heights in all the levels, and we have a full functioning spinal, lumbar spinal unit. So this is the new concept. It's a paradigm shift. We're doing the same thing like with fusion, but less aggressively maintain motion and the mobility. Therefore, it's no need to go to the pelvis. It's no need to go to the ISG joint. And in case something happens, we can all the time go back, and then finally we can do a fusion. Or let's look at another case. Again, similar case in dynamic spondy, isthmic spondy, 3-4 degeneration of the disc space, almost, I would say, 80% or 70% disc height loss, and the degeneration early onset at L2-3. Same thing, stenosis. So what you can do here, so you can, of course, do also what we call a hybrid. So we did a fusion at one level, but the rest is mobile. So that means we are not eliminating 3 levels out of the 5 levels. We are eliminating only 1 level. So, and you see here, even 4 years later, you have a nice mobile spine and a happy patient. Let's move to the real spinal problems that we face day by day, degenerative scoliosis. So we can go, if it's less than 20 degrees, we have had a great experience in series that you can do a standalone. This is on the kind of borderline between discussing posterior 360 or standalone. This could be done with standalone, but you have to understand motion preservation where you put in your device. What was said before, you see, I on purpose set the L3-4 discs out of the midline into the concavity. So this is important. If you put it in the midline, your patient will tilt immediately into the curvature because you have no control from the back. So this is something you have to know. And if you have, again, like a pro disc with with a one center of rotation, you can exactly understand what the segment will do. If you have an unconstrained disc, you're out of control. You are like this, I would say, Chinese dishwasher jongleurs, especially if you're multi-levels, you are out of control what this disc are doing with the next disc. So that's the reason why we like and prefer semi-constrained discs like the Pro Disc. So the critical thing starts when it's more than 20 degrees. Now you must go 360. You cannot have a standalone device. Like this case, you see, it's a 54-year-old guy that has chronic pain. He has his pain pump, morphine pump. He has a severe degeneration at 3-4, 2-3 with a kyphotic angulation and already a severe scoliosis. What can you do with this case? Here you see the CT scan, the rotation. So now this is the more challenging case now. You have to know exactly what you're doing, otherwise you will fail for sure. So what you do here, you control the rotation, you correct the scoliosis with the posterior dynamic device, and then you create the lordosis with the anterior disc. So you see, we corrected both planes well, and you have 6 months later and 24 months later, you have still a mobile spine that is maintaining its position. For this case, that's a gastroenterologist from New York. It's from 2004 to 2007. He progressed significantly. Nobody knows really what is the cause for that. In 2008, he got this procedure done, minimal invasive, cage and screws. And you see the screws on the concave side are compressed, and on the more or less concave side are distracted, on the convex side compressed. Also is the counteracting curvature, so this was the wrong decision. Normally it should be the opposite. But anyhow, you have an oblique takeoff of the L4 vertebra. So this is important that you address that. And this is his CT scan, so the patient was not getting better with this fusion. He could not perform his procedures anymore because he has to bend forward. And you see here why it's relatively clear. So what we did with that case, we removed the cage, we put him asymmetrically to the right side, so to horizontalize the level, because it was all refused. We put a disc in between that can adjust the level in between. We did the derotation with a special derotator tool. We fixed this derotation, only one level 3-4 as a 360 fusion, and we did the uppermost part mobile. So this is 8 years post-op. He's playing tennis, he's a very happy guy. Or this case of a 59-year-old degenerative scoliosis. Here we did a hybrid. You see a topping off on the upper levels, and L5S1 on the lower level. So that means it helps the patient to balance his spine, because L5S1 is the most important level for 551. Also for scoliosis patient, if you fix that, your patient is unable to compensate profile disturbance that he might have. For this, it's a 360 fusion from the side, and we have seen that. And even we can go further on. This is not anymore degenerative scoliosis. It's a spastic lumbar scoliosis due to multiple sclerosis. So this was a good friend of mine, a golfer, and he says, okay, I cannot perform anymore. It's a special card. And he has already this muscular stimulation, as you can see here. And with this, what we did, you see, we corrected the scoliosis dynamically, and we put in a disc in the front, and the patient is still, especially because he has this spastic lumbar scoliosis, he needs this movement to get out and in of his cart, and he's still mobile. Okay, this is his lateral profile, and you see you can recreate very nicely the lordosis, but everything is mobile. The patient can bend forward and can shift his seat. Or this case, you see also a significant, he is a marathon runner, so he's from France. So you see a big shift on his lumbar spine. You correct this with the dynamic device, and then you put in the artificial disc in the front, and if you look carefully on the 2-3 level and the 3-4 level, again, asymmetric positioning on purpose. We go into the concavity to maintain it there. And then you see you can recreate also the lordosis quite nicely. And if you look on the whole balance, here had also a curvature in the thoracic spine. So you rebalance the patient, you bring him in a good position, and the patient will autocorrect his thoracic spine to a certain point, and he also has created a nice lateral profile. If you look at the lumbar, nice lordosis, compensatory thoracic spine. So his whole posture changed, and he's also very happy, and he's again running, because these are sport guys, they want to run. If you fuse him, you have to go higher up. You have to go until T11, more or less, and then I think his sport activity is already gone. Or one of the last patients in the lumbar spine, you see here, this is a parachute guy, had a skydiving accident, so he was really in a bad shape. They fixed him like that. He was partially had a neurological damage, partially he'd also rupture of his aorta. You see they put something on his aorta bow, and this was the result when he came. You see they did not do a proper decompression. That was the reason for his neurological problem. And so what we did a combination out of everything. Because you see, we removed the rod, we mobilized 4-5 and 5-1. 3-4 was already damaged, the 3 vertebrae, so we put in a fusion, we did a central vertebrectomy and a dynamic rod on top. And the patient, guess what he's doing? Parachuting again. Crazy guy, but Good. Now let's go to the cervical spine, because also in the cervical spine we can follow a little bit the same rules, except that we can't do 360 because we don't have implants. And we're working on them, but we are not there yet. So it's a multi-level application, more than 3 levels. So you see here, and again, a lot of times you have typically wise 5, 6, 6, 7 hypermobile, 3, 4 hypermobile. So what you can do, this was a 4 level, so you can do a 4 level. So 4 years later, and you still see the patient has full mobility. Again, for a sport guy, this is very necessary. Or you can even go to 5 levels. You can autocorrect these levels. So how far can we go? How far should we go? On what we call the fringe indications, myelopathy, kyphotic deformities, failed fusion, ADR procedures. So you see, if you are really in motion preservation, you can stay in motion preservation a lot. So this is a myelopathic patient. He was a pilot, and he will not pass aviation tests. When you would fuse him, everything was recommended to him, front, back, laminoplasty, everything, because he had already signs, motoric signs of myelopathic signs. His X-rays was not looking so bad. So this was what we did 20 years ago. And patient is still mobile and very happy with his 4-level procedure after having this severe myelopathy. And he passed every year his aviation tests, and he's still pilot. I think he's working at Delta now. Okay, let's go even further on. This is something that should be done only by experts. This is kyphotic deformities. People think you need a lordotic prosthesis to correct that. But I tell you, you don't need a lordotic prosthesis. It's not a cage. You have to remobilize the segment well. You have to position the center of rotation on the right spot. And then you will allow the patient to find its own profile. And a lot of people think it's out-of-fused. Most of the times it's not out-of-fused, really. And if it's out-of-fused, only the outer shell, you take the outer shell away, and then you can remobilize it quite nicely. And this is 2 years later, you still have a mobile spine. Adjacent level, okay, fixed a plate. Now adjacent 3, 4, 5. Almost no disc space, 3, 4. Also, you see an anterolisthesis, a slippage. You see this problem. Okay, you do take away the plate. And you see here the facet joint. You all the time have to check the facet joints. If they are not working, the whole thing is not working well. Hybrid construct. This is something. Is an orthopedic colleague of ours. He came with that late. So what we did. Hemicorpectomy, so we took away 3 millimeters of each end plate, so we put in 2 end plates. 5 years later, 6 years later, he is still working for the doctors of the third world. He couldn't stop his work, but now he can. Or this female, 48 years, we did a 3-level disc. Then she was working well, then she fell down the stairways, and you see she had a hangman fracture, she had a C1 fracture, and she got a halo vest for 6 months, nothing healed properly. So what can you do? And even with this accident, you see the discs are still intact, still working. The weaker part is the upper part. So here you see the fractures. Here, the luxation of the C2. The C1, the arc is broken in the back. So what we did, we have designed a special implant that you can stabilize it from the front, no necessary to go from the back. You can control everything from the front, and you will have a happy patient. She's sending me every year a letter for Christmas, because she was almost 8 months with a halo vest in kyphosis and was really in a very bad situation when she came. Or this guy is a very important chest flutist. He developed the swan neck, and he had also a lot of levels below. So we have done this again with the similar implant. and the patient is here a couple of years later, a very good condition. Failed fusion, failed ADRs, you see here, 3-level cage patient, and you see the upper level is already not fused, and the 3-4 is also becoming damaged because we did a discogram here. You see the free contrast dye going into the canal. So what we did, we removed the cages, and you see when you put in the disc in a good manner, automatically the patient has his profile back. He's also an orthopedic surgeon, or this guy. This is a mistake. If you do a single level procedure and you are not addressing the upper levels, you cannot correct the profile. It's like with scoliosis. In scoliosis, you cannot treat only one level and hope that the curvature is gone. The same is here with disc kyphosis. And you see here the patient had permanent pain. He has the pain stimulator here already implanted. So we remove that. We put in 4 discs, and you see how nicely you can create a profile. We have not changed the profile. We allow the patients now to get back to its own profile. So this is something, the difference. Or failed ADR surgeries here in M6. M6, we know it's a prosthesis that is an elastomeric prosthesis, and if it breaks down quite commonly, there is polyurethane involved, and polyurethane is a very aggressive material and creating osteolysis. So you can remove that. And at that level where we had this significant movement, we put in a plate, but here was the osteolysis, and we can create the profile nicely back to a normal profile. I think motion preservation is not a simple product. Motion preservation is a philosophy, and you have all the time to look at it's not the front or the back. You have to analyze the whole motion segment if you want to treat it well. You have to look at the profile in the AP and the lateral position, and then you can make a good decision for your patients. And in the meantime, we have, I think, 4 more procedures that fill the gap between open or decompressive surgeries and fusion surgeries that we can apply to our patients in a nice way when we do understand how things are working and what can we do. Because spine stabilization can be arthroplasty. This is stabilization by restoring mobility. Posterior dynamic stabilization is stabilization by reducing or modulating hypermobility, only if you use the 2nd generation devices. And fusion is stabilization by eliminating mobility. So you have 3 ways to stabilize your spine. How my practice has evolved in treatment of DDD, I'm using all these devices now more than 30 years. Over 92% of my DDD patients, we're not talking about these big scoliosis cases and other cases, will be treated with motion preservation surgeries in the meantime. And if people ask me after 3 decades experience in spine arthroplasty to fuse or not to fuse, I definitely tell them refuse to fuse, because life is motion, motion is life. And the future belongs to those who continue to learn. Experience is invaluable, but experience without innovation becomes limitation. Because I'm working since 40 years in this field, and if you are not innovative, you do the same stuff that you have been trained on 30 years ago, then you will not evolve and you will not help your patients. Spine surgery has changed dramatically over the last 3 decades. Motion preservation requires a new philosophy, not simply new implants. Better biomechanics, less invasive strategies, biologic thinking, dynamic reconstruction instead of rigid fusion. Also robotics. Robotics will be a very important part for motion preservation, for screws, dynamic systems in the back, also for positioning the discs with the centers of rotation, because it's very easy because you can simulate what's going on, and the robot helps you to position the prosthesis exactly on the position you want to have it. Experience creates excellence, but innovation creates future. Again, refuse to fuse, restore motion, and preserve lives. And the art of preserving motion, I have dedicated myself almost all my professional life in this art, and I've lived a wonderful life. Thank you very much.
I think I echo the sentiments of the auditorium, jaw-dropping stuff. Congratulations. So I'm going to ask in a second Dr. Shaffi to come up to comment, but we have a special guest online, and Corey, can you help us bring Dr. Ziegler on? So from the World Famous Texas Back Institute, the center that brought us disc replacements to our shores with the help of the Viscogliosi brothers, which shall never be forgotten. I just wanted to invite him for an early comment in terms of North American perspective on disc replacements, your contribution, but also maybe reflecting on what he's seen there. Jack, are you live?
I am. Can you hear me, see me? One of those?
Yes, I see him here. Can we feed him onto the screen? So one more second. And Dr. Ziegler, thanks for joining us today. It's always great to see you here. And we're hopefully, we're shrinking. The incredibly shrinking Dr. Bertagnoli. I've never, ever seen that in my life. So that's kind of scary. Infinity in action. And we see our excellent fellow, Dr. Mohammed El-Houshemi, working hard on the next lab.
Jens, can you see me or hear
So
me?
the infinity scope is being put into play. I hope you all like our new Seattle Science Foundation logo. And we see we're back to baseline. Oh, here.
Jens,
So-
can you hear me or see me?
Dr. Ziegler, bear with us. I can see on my camera, if we can feed from my phone to the audience, but it should be possible to feed us live in there. I heard it, there he is, so there is encouragement. We'll figure out the AV stuff one of these days. We'll figure out, hey, here he is, Jack.
Oh,
You look
good,
great.
good.
No, we
Perfect.
can't hear you yet. One
Hi,
second.
Jack.
1 second,
Hey,
1 second.
Rudy.
Yes, here we go.
All right, good. Hey, thank you so much for asking me to say a word or two. Rudy, it's great to see you. You look terrific. And, 25 years ago when I met Dr. Bertagnoli, I was in awe from the first day. And now 25 years later, I'm still in awe. And I think it's wonderful to have people like Dr. Bertagnoli to help explore the boundaries of what's possible with this new technology. We're still mired using it for degenerative disease and still having so many obstacles. But it's wonderful to see the possibilities, and hopefully even our deformity colleagues can see maybe there is an alternate universe at some point using motion preservation rather than structural fusion. So, Rudy, it's wonderful. Keep up the work, and we appreciate your partnership and your being a wonderful colleague. So I'll turn it back over to Jens and the people in Seattle. But
Stay live where you are, Jack. We'll ask Dr. Shaffi, putting on his hat as the former SRS chair, come up here. So we saw a couple of deformities that I think as a former board examiner, I would fail people if they'd show this kind of stuff. But what are your thoughts on what you saw in terms of anterior-posterior 360 dynamic stabilization? And Jack is here as an extra arbiter.
No, I thought it was absolutely fascinating. I think one of the things which is sort of we were talking earlier, the last session about the technical tour de force of what's being done. So, so what I saw, for example, is many of these cases, there were all these osteophytes, bridging osteophytes. When you completed your arthroplasty, that was all gone, okay? So to be able to go and to reduce a lot of the degenerative processes, I think is really important. And one of the things, again, that you don't want to have something where it re-ossifies, you don't want to have this. I think another challenge is that either the surgeon himself, Dr. Bertagnoli, or here in the United States, many of us use access surgeons to do a 3 or 4 or 5 level lumbar arthroplasty, again, is a technical tour de force to be able to go do this. So I think it's fascinating. What the issue becomes is, can you transfer what you're learning over to the general population's ability to replicate what you're doing?
I think that's the big challenge in nowadays, because nowadays you need to have really a ton of experience, and you have to have an understanding. My first profession, I'm a mechanical engineer. I studied in Switzerland, and that helped me a lot to develop techniques, tools, because you have a different perspective on all the things, and also what you're doing, the precision. But I think the future, with the help of robotics, with the help of AI, that will be a game changer. So, and will allow also surgeons that might not have the ability to do this kind of architectural ideas in the brain and this three-dimensional views in the brain, because you have to think like with scoliosis, you have to think ahead. You have not to think segment, you have to think curve, you have to think AP profile, lateral profile. So that's a very challenging and very comprehensive planning that you have to do before. And a lot of times people, so I'm happy that God gave me the ability to do that, what I'm doing, but I'm very dedicated to do trainings, because it's very important that we have to train our young colleagues in what we are doing, so that they can continue from that point on and not make all the mistakes that we already made. So I think Stephen Hochschuler one time says, okay, it's all the time more difficult to become a pioneer because you have the errors in your back. Sadler is better on because he's more refining things, but he's more on a safe territory. So this is also something, and I think the future technology, and we have seen today a very nice thing. I'm very much in robotics because of my colleague, Dr. Nikolai Hindi. He's one of the trainers in Europe with the robot from Globus. I think he's performed more than 1,500 cases so far. We are working now on a tool where you can also position a multi-level disc, because then it's even more important to have this kind of tool. For a single level, maybe it's quite easy to put it in, but if it comes to 3/4 scoliosis, then it's really a challenge.
So I want to just comment on that quickly and then ask Dr. Theodore to comment on the robotic aspect. I've been a student, a grateful student of yours, but I'm incompetent in terms of I don't fathom my lumbar discs as perfectly as I'm happy with it too. I can't think about three. Maybe Jack can also talk a little bit about answering Chris's question, how three-dimensional visual is that, and then we'll add Dr. Theodore to the mix. So lining up these disc replacements that they're perfectly placed. Jack, do you want to make a quick comment on that?
No, I just wanted to, I think Chris was right on point. You know, we all aspire to be Elon Musk. You know, all of us would love to develop electric cars and rocket ships and satellites and become trillionaires, but we all can't do that. But he has shown us that it's possible. In the same way, we all can't do what Rudy does. You know, as a very experienced North American surgeon, this is not something that I'm capable of, but I admire the fact that Rudy is showing us the potential expansion of the field. And hopefully, as he says, as technology gets better and experience gets better, it will be something that more surgeons can do in the future. But this technology is kind of in its infancy, and it's just growing up. And here's Rudy now showing us what will happen in its adolescence and its adulthood. So it's wonderful to see my friend again. Thank you, Rudy.
Thank you, Jack.
I saw a thing about one of the futurists on television a couple of weeks ago and said, we're 3 to 5 years away from downloading our minds into the overall world cloud that will live forever if we can make it for the next 3 to 5 years. So maybe in 3 years, Rudy, we can download your experience into Nick's platform, then everybody can have the procedure done.
So Nick first, and then Dr. Menga is with us also. Dr. Menga is in Colorado right now, but he's practicing in Miami. So Nick, robotics and optimizing our implant placement for dynamic stabilization.
Well, I mean, first of all, that was absolutely phenomenal talk. I mean, and the disconnect I see is I see the preoperative picture and I'm like, oh my God, what am I going to do with that? And then I see what you've done postoperatively. My problem is I don't know that I would have been able to guess what you did. And that's the problem, is scaling your knowledge, because the outcomes are amazing. You can't argue with that. And but being able to teach how the thought process, the technical aspect we'll talk about in a second, but the thought process I think is more important because as you showed the motion preservation devices, and then we can add in biology into all of this as far as, you know, stem cells and everything else that we can actually bring to play to treat the aging spine. How do you sit and look at an X-ray and an MRI and see a patient who's a pilot and say, I'm going to do a 5-level artificial disc? I mean, that's the first part, and I'll let you answer that. But the second part is 100%, and Nick Al-Hindi is a perfect person to help you with this. I think enabling technology will help us get to that point of, number one, probably from your biomechanical standpoint, figuring out where the optimal placement is of that disc, and then two, we're using enabling technology to help you get that where you want to get it. But there's still obviously tremendous amount of artistry and you know, thought that goes into it.
Thank you.
Okay, Dr. Menga, can we go live to wherever you are now? I think you're not in Miami. You told me you're in Colorado. Is that right?
Yes, I'm in Colorado. Thanks, Jens. Thanks for getting me involved.
And just introducing to the audience, many times contributed to the interesting case discussions with his former partner, Dr. Molinari from Rochester. Now excited to have you in Miami. Your thoughts on seeing dynamic stabilization with these deformities?
I think it's amazing, and I think as everyone has noted, it's. I was looking at the X-rays, thinking, okay, maybe he decided to fuse this one or did this here, but you can't predict. And those are some outstanding results. I guess the question I had is more, I know as far as time, maybe not necessarily get into the technicality as far as like indications and contraindications, similar to what we face with adult deformity surgery. Bone quality is something that we take into account. Then you had cases with 360 doing front back. And I guess a couple of questions. One is, this goes more into contraindications for doing surgeries like this. How do you address, or do you run into issues with heterotopic ossification, especially when you go posteriorly to decompress, not only take down the facet, release the facet joints, but also to decompress? That can then lead to maybe failure or back pain from the heterotopic ossification with the 360 procedures. And the second part of the question is, how does bone quality play a significant role on how you decide to approach these patients, knowing that risk for subsidence with patients with bad bone? And do you have a threshold for bone quality?
Yeah, I think very good questions you raised up. And I think the number one, heterotopic ossification, is a fairy tale so far, because it happened from the literature when the Charité prosthesis was done very badly. Then we see heterotopic ossification. Why? Because Charité prosthesis is an unconstrained disc. And an unconstrained disc is exactly doing what a degenerated disc is doing. It's creating hypermobility. It's unstable. And if you have an unstable mechanical situation, your body will answer to it by putting in ossifieds. Because what you're doing with an unconstrained disc, you are more or less simulating a nucleus. But you take away all the tension bands. A natural disc works only in presence of tension bands. You have a strong annulus, you have a PLL, you have a strong ALL, strongest ligament in our human body, and you're taking away everything and you put in a disc that's not able to control all these movements. So that's the reason why we have seen heterotopic ossification with this kind of unconstrained disc. With the pro disc, we don't see it too much. Of course, in the cervical spine, it's a different story, because I personally believe that what we see with Asian, Japanese patients and OPLL, we see with our European patients an ossification of the anterior longitudinal ligament, because we see two types of ossifications. We see early onset, that's definitely something to do with the surgical procedure, but we see also late onset after 1 year, after 2 years. And we see heterotopic ossifications when you put in a plate, when you're not doing anything, when you keep it on the natural history. Some people have the genes, obviously, to develop ossifieds, and some people don't have. And if it happens in the neck, for instance, my friend Michael Meyer was giving a great study, so 20% or 25% heterotopic ossification, but nobody cares because the bone doesn't hurt, except is it making a femoral stenosis, except it makes a posterior stenosis in the canal. Then you have to do something, but this is only 1 or 2% of heterotopic ossification discs. So this is
SRS, former president, and we're just now seeing dynamic stabilization, a great segue for Dr. Samdani's lecture later for pediatric dynamic stabilization. But what are next steps for SRSSO to take this kind of a rebalancing concept seriously?
Well, I think the problem's going to be, again, I think that people are very open. And I think that, what happens is to be able to systematically look at what you've done and present it in a way, in an open forum and publish on it, I think is the way that this gets moved forward. But I do think that there also has to be a way, and I think there has to be maybe the Burton-Ollie School to go and to train other people to be able to replicate what you are doing. If you are the world's greatest artist and you can make some type of beautiful painting or sculpture that no one else can do. It's a unique art of beauty. But I think when we were talking before, when you have something that is being able to be used by the masses, whether it's an iPhone or whether it's a self-driving car, then when it's be able to be replicated, then I think it's something that people are going to go and advocate for. So I might have an individual patient would come and I would say, look, I'd go to Rudy to have this done if you want to avoid a fusion, but that doesn't mean that I'm capable of replicating what you are doing. But I think what you've done, which is really good, is I think you're putting together a toolbox that allow people to incrementally move towards doing things in the direction that you're doing it. So I think, I think most people in this audience, if we have an L4-5, spondy, is that potentially something that you would go and remobilize the spine and do something like an arthroplasty and a dynamic stabilization as the next step, if they have a component of scoliosis and whatnot to do it. And I think that's something that's achievable by most of us here. If you have a more advanced cases, some of the ones that you showed were just blew me away with the absolute tour de force of being able to do that technically. I think that is probably, 5, 7, 10 years off. And the problem is nobody wants to advocate for something that causes a disaster. And even during Jens and my, kind of lifetime, Nick's, that we, there was a thing that was this close to pedicle screws being banned throughout the United States. I mean, it was a very, very close thing due to complications occurring. And this gets into what I'm talking about, I'm going to show, when you introduce a new technology, you've got to make sure that new technology is at least theoretically as safe as not. And that's the one thing that I have, I'm absolutely blown away by the functional and outcomes, and I saw the results, and they weren't people that are 2 weeks out, they were 6 years out. But the fact is, for most of us, including myself, for me to do a 3-level, a 3 or 4 level arthroplasty with posterior dynamic stabilization, I'm gonna periodically, while I'm learning that, gonna have some complications. You were talking earlier, learning curve means complications, okay? And that's, this is a lifetime of achievement getting to where you were able to do that. And that's why I think is the issue. From the SRS perspective, nobody's gonna wanna advocate for something that suddenly that they're gonna ban a huge swath of treatment because to do it. Now, I could have, so some of the ones that he showed, I'd have done a 3 or 4 level T-lift on, okay? I would not have nearly hit the home run that he hit. For the 0 ODIs, I don't have very many of them, okay? But I'd have probably had an ODI that went from 45 to 20 doing what I'm doing with, 5 years down the road, probably doing something else. So I think this is wonderful, wonderful stuff. I just say that as we're able to teach it and incrementalize doing it. And again, having the tools, like for example, I'd never seen your dynamic stabilization device. I've seen previous ones, other ones. But if that is durable and that holds up and that doesn't loosen, that offers all of us an ability to move incrementally in that direction. So that was really good.
Yeah, thank you. I agree. I think training is the most important thing in that, because we have seen at the beginning there was a very good training program also with the AO at the beginning. Then when Synthes was acquired by unfortunately, then this training program dropped almost down to zero, and this technology almost dried out. And we need to go stepwise, like we need to start a trainer program, train the trainer, and then we can replicate and multiply the thing. We cannot, one surgeon cannot train everybody, so we have to bring together from the societies dedicated surgeons that want to be in this field. Then they can be trained because it's a smaller number, but these trainers should then have the ability to train others. So I think this.
We have Mr. Anthony Viscogliosi for final comment. He's the CEO of the Viscogliosi Brothers Spine. So, Anthony.
Thank you. I'd also like to say CEO of Companion Spine that's developed the posterior dynamic stabilization technology portfolio that Rudy was speaking of. I'd like to come back in for a thought for all the physicians in the world, surgeons in the world that are listening to this and will listen to this in the future. What Dr. Bertagnoli was showing us today is 40 years of incredible experience and thinking and education. It is known in the field of healthcare that any innovation, let's talk about robotic surgery, and let's talk about pedicle screw fusion, takes a 30-year period at a minimum to become mainstream. Today, robotics are not mainstream. They will be. So it will take a generation and into the second generation for motion preservation technology to become mainstream. We are entering the end of the first generation, a 30-year period. And now that there is enough evidence that exists that motion preservation, it can be done, that an electric car can be made. Remember, electric cars were introduced in 1911. 1911, and it took 3 generations for electric cars to become mainstream. We're only at the end of the first generation. This technology is going to be transformative in your, maybe not so much in your lifetime, but by the end of your professional career, all of the surgeons in this field will be doing, 100% will be doing robotic surgery. 100% will be navigated surgery. 100% will be using motion preservation in the next generation. Can I ask, does anyone know of anywhere in the United States where there is a motion preservation fellowship?
Dr. Ziegler, are you still there?
Yeah, Jens.
Who comes to mind? Can we put Dr. Ziegler on the video screen? Yeah, can you, did you hear? Yeah, here you are, okay.
Is there a motion
Yeah,
preservation?
yeah, I'm still here. You know, our fellowship is heavily weighted towards motion preservation. We did have one of the slots dedicated for motion preservation, but all the fellows rotated through it. So, you know, we still offer a huge experience. But Mr. Viscogliosi is correct that this kind of technology should really have more dedicated fellowship. And particularly when we interview for fellows, it's an amazingly high, disappointingly high number of residents from both neurosurgery and orthopedic programs who have never seen a lumbar arthroplasty and have seen just a small number of cervical in their training. So, you know, we need for the future to kind of catch up with the present or the other way around, but we need to see residencies believe in this more, hire faculty members who believe in it, who will do those cases and allow residents to see them during their training and then have dedicated fellowships as well.
So my point to Jack's comment is that it will now begin, that there will start to be motion preservation fellowships around the world and robotic surgical fellowships around the world. This will lead to a 30-year period where everyone will be doing those two technologies, and AI will be used as a decision assistance tool to take what Rudy does in his head and help everybody do it, to choose the right, just like we're using machine learning to choose the length of the pedicle screw, the size of the pedicle screw based on the CT anatomy. It is exactly going to be done to choose which type of solution is proper for the aging spine, for degenerative conditions and into deformity correction. I'm telling you, this is coming. You're all going to be part of it, greater or lesser, depending on the point in your career that you're at. And for the fellows program that we were at last night, this is your future. Navigation, robotics, and understanding the application of preserving stabilized motion. I'd just like to conclude, thank you for the time, to say this. Rudy said arthroplasty is restoring mobility. Posterior dynamic stabilization is mobilizing mobility. Infusion is eliminating mobility. They all work in the right circumstance. So it's up to us as a generation of leaders and educators to expand the understanding, just like Rudy showed us today, on what the possibility is and start to pursue a greater understanding of that possibility of modulating mobility and restoring mobility. So thank you for the opportunity. And industry needs to support it. And it's not just VB Spine or Companion Spine, but I challenge and ask Medtronic and Johnson & Johnson and Globus to also do the same. Our patients need it, the patients want it, and the solutions have been demonstrated to be safe and effective.
Extraordinary words and great wisdom, and the challenges out there for all of us. Thank you for all of you. And just a quick claim, I want to be the first to have said that I want to lay claims to the name for that AI advisor, and I'll propose to call it Rudy. Just like we have Claude now, I want to have a Rudy advisor, okay?
That's perfect.
And I want to have his avatar right there, okay? Let's call Rudy.
There you go.
Now,
All right.
Dr. Shafri, you're going to go back to show us some hardware in the lab together with Mohammed El Houshemi.
There we go.
So back to hardware. Thank you, Rudy, and thank you for your beautiful commentary, Mr. Viscogliosi. And for the audience here, you've been very patient. Why don't we go row by row, maybe starting on this side, out. So when one row goes out to get some lunch boxes, the next one goes in. And shall I do it like that? So Jared, Spencer, Bill Foster, you want to go first? And then tag team the next on the opposite side, okay? And Chris, do we have a live feed from the lab? I'm sorry that we're running so behind. Those who know me know that I'm kind of notoriously anxious when I run behind. So I'm very curious to see this because we were going to look at, actually, this is Anthony. He's one of our absolutely wonderful collaborators. And I see Tate from Medtronic. Tate, can you hear and see us? Tate, why do you look so grim? Smile. And there's Gary, our New York Yankees and Giants fan. Yes, with a new logo. Gary runs our lab and he keeps everything on time. I'm sure I'm on his SHIT list now for running late. But I hope it's for a good cause. I think you all agree that this is super exciting and stimulating to hear and see. And we could make up for some time, but I think that the thought of doing motion preservation, here we see the big backside of Chris. So Chris, you're on your backside right now. There you are.
I'm going to
Okay.
go around the other side then.
Okay, we can hear you now, and you're coming to the other side, and that's fantastic. And Tate is with Medtronic, so I think we're going to see some
we
Medtronic
go.
instrumentation. We hear and see you loud and clear, so tell us what you're going to do, and then I think Mohammed is also going to help you. One of our fellows is just graduating.
So first of all, I was asked by a couple of the different attendees, what's the difference between a pedicle inlet screw and a pillar screw? And what pedicle inlet is the trajectory? The pillar screw is something that Medtronic has tried to go and proceduralize and refine it. And so some of the things include this, this thing that attaches to the Mayfield head fixation device, which can go and stabilize different things. It includes a variety of different clamps that can attach to the vertebrae. And the reason why is we want as little motion as possible to make our image guidance as precise as possible. So one of the things with this is, again, that you're just as Anthony had just said, I'm somebody who's been a real Luddite as far as image guidance, but all of a sudden I realize that there's certain things that I can or cannot do. And again, Jens had taught me very precisely about the different anatomy. So if we look here, and are they able to see the screen as well? What you can see here is basically kind of a starting point for the pedicle inlet. And if you go and you see there, and you see the projection with there right into the inlet bone. Now, if you look, that if I'm imprecise with this, I could very easily get this over into the vertebral artery, and no one would be happy with this. Now, with this pedicle, which is a fairly good size one, the fact is that I would have the option, for example, of putting a true pedicle screw in place. But if I measure the distance from the back of the lateral mass to the back of the transverse foramen there, and you've just seen that with the yellow line going back, I know that I can put this screw in, and that length is what, 12 or 14? Okay, then I know that if I put that length in, that I am going to be safe if I put that level. Now, if I move a little bit further lateral on this and then angle more medially, it lets that screw length even be longer with that. But again, you have to have a bigger exposure if you're going to do this. So I'm going to transfer now from the turkey foot to the actual the drill, and you can see this drill tip is 2 millimeters, and it's an end cutting drill. Okay, so you can see here, and again, I have some options as far as my starting point is concerned, but I'm gonna basically start in this direction. Is there a foot for there? Here it is. There it is. So I'm going to just make a little tiny hole to start. And if you look in here, you can see that I'm starting to drill down, and I'm going to drill down into that inlet right here, okay? And continue to drill down in there, because that bone is extraordinarily dense in that area. So I'm going to take my drill out, and then take a navigated drill here, and sort of follow the same trajectory. Same trajectory. This looks to be the top. Is this the drill? Okay. Here we go. Okay. There's a little bit of light missing. There we go. So with this, I had drilled it with the Midas, and you can see if you're looking in. I don't know if there's a camera that's looking directly in, but there's a little tiny bit of a movement as I'm doing each of these different steps, and that's why there is going to be an advanced clamp that clamps these together, and despite the head being rigid, there's still a little bit of mid-cervical motion. So with this now, you can see that this is a 14 screw, that's being put into place. Now, I've moved towards using all reduction screws in this just because it makes it so much easier to line everything up. But this screw has got, this is a standard screw here, but this screw has got an enormous bite that is present. And with this, you just saw the kind of the 1 minute that it took to go and to do that step. So go back to the turkey foot again, and we will do our next level down right here. And again, I'm looking to line up my screws, and again, to alter it a little bit so that I'm going to try to stay away from, there we are, the vertebral artery. So you can see here that this is a little tiny bit more challenging. And people say, okay, well, why is it, why can't you just go, why is it you can't go and put a pedicle screw in every one? It's because, again, the space that we're going to put this in is, there we go, is reduced. You can see with this, to get into that dense cortical bone, I can fairly easily do, but to cross the isthmus and enter the vertebral body, it is a bigger challenge. So I'm going to move again to our navigated drill. Let me do this right there. And again, so I'm in both planes looking to go do that. Here we are, to get that into that dense cortical bone. And I'm now into and that bone there is exceptionally dense. And it's sort of, got it stuck here because I stopped it, which sometimes you don't want to do. Well, we're getting the added power on there, but here I pulled it out. But it looks like, if you see here, this is like concrete surrounding the tip of that screw, and this isn't some NFL linebacker. And I'll take the either one. And so basically, with the dense bone, this is a drill that we can do the exact same thing, drilling into this dense bone because it's just so dense. And I'm looking at the tip, and again, just getting into that, and then taking it out, and I'll take the tap. Tap, yep.
Chris, are you having skiving concerns right now?
I'm not, just that the hole was a little small at 2 millimeters, but I am right now into that very dense bone. And so you at least for me, when I'm doing this clinically, I want to drill and tap and put my screws in. I want this to be a millimeter or so beyond, just so that I do not, and again, this just incredibly, you can see that I'm sort of white knuckling it, putting it into that area to go do it. And and again, as we precisely do it, if they can see into the hole, you can see that these screws are absolutely perfectly aligned. So if we drop a rod in, it's not this Z-shaped rod, or if we have somebody who's got a coronal deformity, if you put the straight rod and move with the reduction screws into the appropriate position, how that goes. And again, here's the next level down. And again, the angulation that we need for a true pedicle screw crossing the inlet versus getting into that dense bone. I think is a difference between it being a safe, easy, and reproducible procedure versus one that is potentially at higher risk. So you can see there, we're into that dense bone very consistently there. You just give me the tap, it's fine.
Chris, so I was fortunate to have many great teachers in my life, and you're one of them. I learned from the great Kuniyoshi Abumi, and I think you know him very well also.
Yes.
How he puts pedicle screws in. He does not have guidance. He does something that I always learned to be very clever. He oversizes the initial pilot hole and then uses kind of just as Midas to kind of let him guide himself in the pathway of least resistance. So what are your thoughts on oversizing the near pilot hole so that you then have a less constricted pilot hole that guides you possibly in an aberrant place?
You know, I think that the way that the configuration of these screws are, that as you know, with the work that you've done, if you disrupt the posterior cortex, it weakens the screw. And this has been shown by a lot of good work. So for me, I don't want to disrupt that. I want to get the strongest screw absolutely possible. So I'm going to have my trusty assistant go and put a screw or two on his side, just to show you that, that this is something that is easily learnable. And all you have to do, if you want, I'll just step on it whenever you feel you're lined up right. But what you can see here, and so it's usually a little bit more superior on the sort of right at the superior aspect of the facet joint in just a little bit. And that usually gives you that, there we go. And so I'd go a little tiny bit more lateral and a little bit more, well, you have to go up on the thing there. But the fact is that on this side here, I would.
Can you pull up the C3 and C4? C4 screw. Yeah, C4. Yes. That's C4.
There you go.
Very large mass of bone here.
That looks good there. Do you want me to step on it?
Yeah.
Okay.
You tap.
Sure, you want to tap?
Tap.
So, Dr. El-Hushaimi, are you microphoned? What is your thought right now? What's your confidence level?
Sorry, the volume is low. Can you raise the volume?
He asked what your confidence level of this going appropriately.
Yeah, the issue here that there is a lot of overgrown bone from the previous method. You can see it from here. So we should have done like a proper cleanup for these facet joint before that. So this is here the issue, but the confidence is you can have this feel when reaching this sharp solid bone. So yeah, I tapped it down all the way.
So, Dr. Shafri, one classic question for these multi-level posterior spondylotic C-spine reconstructions is, do we decompress first? Do we instrument first if we have an option? what's the best sequence in your eyes to be safe and sound? And how do we combine loosening of the spine with release and decompression versus safe hardware placement?
Well, I think that the nice thing is that, particularly with the position, is there a possibility to get an overhead camera into the wound so that they can see?
Yeah, we should have it, yeah.
So what I was going to just show you, and I'll put one last screw in on my side. Do we have the camera? Oh, there we go. So if you see there, you can see how my screws here are absolutely perfectly lined up. So if I wanted to drill around and do a decompression here, or if I want to do a post-positioning laminectomy, it is extremely easy for me to do that. And so sort of going back to the screw placement on my side here, as you can see there again, so this level here, this is 7 right here, okay? So for me, on this one, for this screw here, because I know it's 7, I can go, and a lot of times, people get nervous because of what goes on, but you can see I've drilled all the way down. That's a drill, I've drilled down to 25. Can you have that 22 screw that you had, and I'll take the tap. So this just goes and shows you that, and this screw, the 7, and sometimes you can see that the vert is way out of the way at 6 as well. And what you can do here is, this gives you the flexibility of the entirety of the procedure, that I am right now. That's down to past 25, and as we see here now with this screw in place, that, just how easy that is. And you can see the screw length here is that a screw in the 20 millimeter range. And just hand me the rod for a second. And people, when the end of this, are like, oh my goodness, the thing I hate doing is putting the rod in place. And this is not even with the reduction screws. But you can see here, to go and to drop a rod in here, it's that easy, okay? And if you've got spondylolisthesis or something with the reduction screws, it just gets to be even easier. So, you can see multiple levels on both sides how quick and easy and reproducible this is. Any question, Jens?
Looks absolutely great. So one question again is timing of reduction and kind of fitting that in. So when do you, so one of the biggest problems, I'm going to start there, with multi-level posterior C-spine surgery, as we saw in the equipoise trial by Zohar Gogavala and the group on the East Coast, was that posterior surgery had far more back pain, or neck pain, I should say. The finding was that most of these C-spines were actually fused into kyphosis. So they found that kyphosis, which was iatrogenic, so multi-level posterior fusions was the probable cause of the problem. So tell us a little bit about, again, do you intraoperatively scrub out and reposition the head position? Do you do dynamic loose stabilization? How do you get lordosis reestablished effectively?
So what I do is I use these kind of reduction screws. Do you see this?
Yes.
And what I do is that I will put, for example, in this case, I would put reduction screws at the very top, and at the very bottom as a minimum. I, in reality, put them in all levels. Then I have a curved rod, and what I'll do is once I'm done with all screw placement, I'll reduce the reduction clamp. I'll loosen this. I will sometimes bring the neck into a bit more lordosis. But with these screws, it is so powerful to pull the ends, and with the rod being curved, if you hand me the rod again for a second, And so what I will do is I will put reduction screws. You have the rod bender. And so what I will do is I will go and I'm going to have my rod contoured like this. They're going to go, it's going to go in the central screw here on either ends with the reduction, and it is going to pull the spine into lordosis. And for example, for a C2 pars or pedicle screw, I'm typically using like a 4-5-26 screw. For my T1 and T2 screws, I'm using a 5-5 screw, and the screws in the middle, I'm using the reduction screws, but they're now pillar screws. And as that reduces down, the force to be able to go and to put the spine into lordosis is incredible. If you give us, if you'd like, if that's a major point that everybody wants to see, we can put in a C2 screw and a T1 screw, cut this rod, and show you exactly how the spine moves, doing what I said.
Rod, do we have time? Rod says yes.
Okay, then let's do it. So let's go up here to, 2 is right here, is that right? There we go. Okay. And I'll take the tap, and then I'll take like 22, a long reduction screw. Okay, I'll take that one then.
And can I ask you questions whilst you're doing this?
Yes, you can indeed. You can go ahead and put that in.
So dual core rods, so dual caliber rods, when you cross the cervicothoracic junction, when does that become a necessity? I've seen some, like you were at the same session, CSRS papers where they said that's a huge advantage. So putting like a 5-0, 5-5, or a 6-0 rod into the upper thoracic spine, and then switching that to a 4 rod. So this single dual diameter rod system, is that something that's relevant, and when do you switch to that?
So I don't, back when you and I worked together, I used to use dual rods all the time. And sometimes I would have a fracture at the point of the connection. So I use a 4.0 cobalt chrome rod, and I have, I can show examples, and then you'll probably see one in my afternoon talk, where I've done that all the way down. I've done that all the way down to, T6 with a 4.0 cobalt chrome rod. And I usually will add a 3rd or 4th rod with it. But the bottom line is that I do that the tap, and then whatever the longest reduction screw is. So we just because we've got a little bit of a limit of the inventory, this is going to be a little bit of I'm going to be a little off with doing it, because normally I will put, like I said, a 4-5-26 screw, into C2, and I'll use 2-3-5, usually 30s, in T1 and T2. But just so that you guys, just put that down. So just, so with this, what we're going to see here is, let's get a rod cutter and cut this out here for me. Yeah. And what you're going to see here is, and this just is a little bit easier when you have it. So let's put the center one down first. Let's not get all that other crap that so most of the stuff I take off of what, like all of my implants. I've got sort of my special sets where I don't have all these locks and everything else that are put into place. And let's do the, here we go. Just I'll take the top one. There we are. Just push down the rod a little bit. Just get a rod holder and push down at the end of the rod. Just go above. And just push down at the bottom of the rod here. Just get to the very end. And so what you're going to see right here, another cap. And this is a 4.0 cobalt chrome rod here. And the whole thing is to have it so if you have multiple reduction screws and you gradually bring this down, you can see the rod is rotating a little bit. So we've got a bit of a limit, but what happens if you have multiple different ones, and what this rod is doing, it's rotating a little bit, which it will do. They gave us about 1/10 of a set here to do this. Just go ahead. You grab hold of the rod with it. We'll do it this way. Let me rotate the rod here like this. No, just do the center one. Just do the center one and lock that one all the way down.
Sorry, Chris, you have to untrain Mohammed.
That's okay. Do you have coronal benders?
No, Ben.
So what's happening here is that so we show you appropriately. I don't want to rush through. So what happened is we don't have a formal, hold on, rod. There we go. Formal. There we are. So we don't have a formal rod holder here. So we're doing something. So I'm going to give me another one of these. Just keep it held right like that. Okay. So as I was saying, I usually use reduction screws all the way down, but we're going to do at these two levels. At these two levels, we're going to lock the rod in the sagittal plane here. Okay, now you can come off of that. Now it's locked in the sagittal plane, as you see. We're going to fill in, and it's, again, a little easier to do this with reduction screws.
Hey, Chris, does your later date navigation technology, and want to thank Medtronic for supplying their equipment here, can you now establish sagittal profile reduction parameters with your intraoperative navigation technology?
Yes. It involves putting a little pin into the spinous processes of several of the levels, but the answer is yes. So we only have a limited number of the reduction caps, and that's okay too. But you can see here, and you can see how much that curve how much lordosis we've put into the spine here. This is substantially deeper down than it is up here. And if we'd have done osteotomies, it would be even a greater degree of change. So this is sort of when I was talking on the thing about the power of this to be able to manipulate the spine. And I'm going to tell you that, let me just have that. So just so you can see, this is sort of the destructive testing phase. But if you see here, I am really, really pulling hard, okay? You see the whole thing moving.
Yes.
And with lateral mass screws, there's no way you could possibly do that in an elderly cadaveric spine.
So Chris, this is Rod. Can you hear me okay?
Yep, I do.
Okay, so actually, when we're in that lab, you actually demonstrated this really nicely. The screws line up so nicely in this, and then you're able to grab C7, which a lot of times you have to skip or leave out because of the junction. And you could actually see when you finally tighten C2 how powerful those segments are.
Well, you can see this is if you look back in again, this is C7 right here. And you can see that I was able to line that up perfectly with the other. We skipped C3, so it's 2, 4, 5, 6, 7, 1. But you can see looking in that 7 lines perfectly up with 1, with lines up with you can see the open one right here. That's 7 right here. This is T1 right here. You can see there's the entry point for T2 would be right here, that easy. And the rod just drops right in. Just to your point, Rod.
Yeah.
Final question, then we'll have to move on, and we'll have the great honor of having Dr. Nick Theo talk about spinal cord injury. I see a lot of patients now running around with 3 or 4 rods crossing a cervical thoracic junction. Now, you and I have done some pretty hairy cervical thoracic reconstructions, and I've honestly never done that, but am I missing out on something? Should I put in triple or quadruple rods?
The only time I do that is if I do a 3-column osteotomy. So let's say I did a T1 complete vertebral column resection. I think there's an added degree of stress across that. So in those cases, and this is what I was talking about before, that I've done some things where I've used, for example, a laminar screw at T1, a laminar screw at C2 as an added point of fixation. Then on the other side, use a side-to-side connector and put in 4 rods with multiple different points to allow that to happen. The other advantage of that laminar screw connector is if you compress across that, it can help, because it's posterior to the instantaneous axis of rotation. Anything posterior helps go and push into lordosis. So I use that as another corrective tool. Or the other thing I've done is used a band behind the spinous process under the spinous process of T1 and T2, and then up superior or through C2. And again, is that a tension band to pull that into lordosis. My only proviso is you have to be a little careful if your foramen are real tight. As you pull that into lordosis, you could narrow the foramen. So that's why you want to do some kind of simultaneous posterior column osteotomy.
Fantastic. We'll close this very successful lab now, and thank you and Medtronic and Mohammed for their great work and support. And we'll switch back to lectures here, and we'll have a flying change over there because we'll get prepared for Dr. Amr Samdani's lab later, showing dynamic stabilization techniques and also scoliosis correction. So Dr. Nick Theodore, Professor, Chairman of Banner Health, before that, well-known national figure in Johns Hopkins and the Barrow Institute. Great to have you here. One of the big unresolved issues, do you want to plug your laptop in?
Let me see if,
We can either.
let me see.
Can we have,
No, that's okay. I think
is that yours? Change?
Change?
So one of the big unresolved issues, you resolve that in spine care, is obviously spinal cord injuries. Okay with this one? Is spinal cord injuries, and he'll tell us a little bit more about the numbers and the ways to try to get past that in biology versus engineering versus something else, pharma. Thanks for being here.
Thanks.
Great honor.
All right, so, continuing along with the theme, what I'm going to talk about in this next talk is really, again, a long career in looking at spinal cord injury. How do we prevent it? I thought Amr Samdani did a beautiful job talking about in the operating room, what exactly do we do when we have monitoring changes? What do we do when we have a spinal cord injury patient? Unfortunately, we don't have a lot to guide us, and nor do we have a lot to offer these patients. So these are my disclosures. A lot of this work was based on a large DARPA grant that I had when I was at Hopkins, and I'll talk to you about that. When you look at historically, this goes back to antiquity. When we talked about spinal cord injury, in the Edward and Smith papyrus, an ailment not to be treated. Even back in the day, somebody got building a pyramid, a rock falls on their back, they're paralyzed. Really, we can't do anything for this person. And it really wasn't until the turn of the century that Harvey Cushing wrote up a beautiful paper on looking at spinal cord injury and understanding what happens and exactly what the pathophysiology is. And interesting, if you go back to that time, even herniated discs, we had no understanding of myelopathy or what was really going on. But it was the battlefield experience during World War I that really sort of opened his eyes and opened up everybody's eyes to the fact that this could be an ailment that could be treated. 80% mortality rate when you looked at the World War I data. World War II, we got better, decompression, taking bone fragments away from the brain and the spinal cord, and then also getting these patients out of theater, getting them into the secondary care. when you look back, and this is only Mr. Viscogliosi and Jens Chapman, and I know who this guy is, but this is Ben Casey. And, Ben Casey was the original television doctor in the 1960s. He was a neurosurgery chief resident. He was the chief resident for all 5 years of the run of the series, which I tell my residents is why that you may be able to have to stay around. But it was interesting that even in that time, it was a little nihilistic. We'll see if we get sound on this. No sound. I'm just curious. No sound. All right, well, we'll play that another time. So when we look at what happens during acute spinal cord injury, we realize that there are a tremendous amount of things happening at the same time. So you've got the primary injury, which is the insult to the spinal cord, whether that's during derotation in a scoliosis case or a car accident. At that time, we get vascular disruption, we got vascular changes which lead to ischemia and infarction, we have lipid peroxidation, cell death, and then we start getting into later phase problems with glial scar formation. And you look at this, there's two things, right? So there's exactly what's happening from a pathophysiology response, and then there's the after effects, which are largely vascular and then leading into immune response and everything else. The problem is people have spent their entire careers on one tiny facet of the problem, whether it's one mechanism, one molecule, one problem. And the reality is there are a lot of things going on here. And if you happen to be, it's choosing the right target is the most important thing. If you happen to be this unfortunate guy in the Thai military, his job is holding the target up for the sharpshooters to practice. Imagine having that job. Choosing the target of what we treat in spinal cord injury is a whole different subject. So this dates back 30 years now. This is Heinrich Chang. And Heinrich Chang did a beautiful experiment where he cut a segment of spinal cord out and then took 18 intercostal nerves in a rat and reimplanted them into the segment of the spinal cord he removed and got the rats to walk again. I was a resident. I said, this is what I want to do. I mean, this guy's curing paralysis with surgery. I mean, how amazing is that? So what he did was, again, cut a segment of the spinal cord out, harvested 18 intercostal nerves in rats, reimplanted them, got the rats to walk again. I said, I want to do this. I had him flow. He came out to Phoenix. He was in the lab, and he taught me the surgery. And I said, let me bring the microscope in. He goes, we don't need the microscope. He just cut right here. And well, it turns out he wasn't cutting out a whole segment of the spinal cord. He was leaving about, 10 or 15% of the spinal cord intact, which leads to the rat to walk again, regardless of what you do. So when I actually repeated the experiment and cut the segment out as he described it, no rat walked again. So you can be a little nihilistic here, but it got me thinking. We started working on, this was back in the day, autologous macrophages. We did a big study in dogs on this. Again, not working. This was a medication, a Rho pathway antagonist that was applied epidurally. And I thought to myself, this is the first patient in the world that I did, and it was in Phoenix. Michael Failings was the lead PI, and I thought to myself, is this medication really going through the dura and treating a spinal cord injury? Well, again, this study turns out not to have been effective as well. Then we started looking at neuroscaffolding. And if you think about it, when we do spinal cord surgery in emergency, situations, we do a laminectomy to decompress the spinal cord. However, guess what? When we do a decompression in the brain, what do? We open the dura and we let the brain swell out. We don't do that in the spinal cord, and there's reasons for that. Although it has been done historically, even dating back, almost over 100 years ago, nobody was willing to do that. So this is Bob Langer out of MIT, probably one of the world's foremost biomedical engineers, said, what about building a scaffold that we can put into the injured segment of the spinal cord? So you can see in the upper left, normal spinal cord. After a contusional injury, what you get is a buildup of necrohemorrhagic material, swelling in the spinal cord. You open that up, you can place this small scaffold into the spinal cord. The scaffold then acts as a substrate for axons to grow. Think of it as an internal bandage. So we do a myelotomy and take away that pressure that's in the spinal cord, that blood and hemorrhage products, implant the scaffold. Now, this is spectacular. Look at this. In the control group, you see on the left, at 6 weeks, the spinal cord has a giant hole in it, that cyst, that myelomalacia. And on the right, where you've implanted the scaffold, there's a preservation of tissue. So the thought was, okay, even though the scaffold is inert, maybe there's some benefit to it. So this is about 10 years ago, actually about 12 years ago. This is the first patient in the world. This is a 25-year-old motorcycle rider who came into my emergency room in Phoenix. We were going to, here's his fracture dislocation here, Asia A, with a severe spinal cord injury. We got him realigned, and then here we are in 2014, looking at the spinal cord, making a small myelotomy, and what you saw was this, basically a cavity. There was a hole in the spinal cord where this injury had occurred, and it was under pressure. So we were irrigated into that. What you don't see in the video is about 15 minutes of me thinking to myself, am I actually going to cut the spinal cord open in a 21-year-old kid? And the reality is that we don't have anything else to offer this patient in the thoracic spine. So a very small myelotomy released that pressure. Once that cord was open, we see a pulsation of the spinal cord. And here's the scaffold going in right here. And that's that. So.
And sorry, how long after the injury was this?
Immediately. This is the day of, within 4 hours of his injury. So what we don't have is the benefit to understand what's going to happen. Now, and amazingly, this kid starts moving his legs, and everybody's like, oh my God, it's the scaffold. Well, I can promise you it's not the scaffold. What is it? It's emergency surgery. So it's surgery done within an hour or two of his injury. That's number one. Number two, probably opening up the dura, draining spinal fluid. And number three is doing a myelotomy and releasing that pressure. So again, it got me thinking. So this study, got funded. There was a lot of interest in this, especially after the first patient. Ultimately, 21 patients were done. There was a little bit of improvement, but we were only doing thoracic patients at the time. But ultimately, it comes out there's no benefit. There's really no benefit to this. Is it because there's no stem cells or what? But the reality is it still, continued to get me thinking. This is an Israeli company called Matricel that I've been working with that is now taking this one step further and making that scaffold with, stem cells derived from the patient. This paradigm, though, cannot be done acutely. This has to be done in a delayed fashion. But imagine now being able to take make a patient's own stem cells, make a custom three-dimensional scaffold, and then reimplant that into the patient. So this is work we did in large animals at Johns Hopkins. Basically, we've done a spinal cord injury. We were opening the dura. You'll see sort of a removal. You can see the cavity there, and we're irrigating out this sort of necrohemorrhagic material after an acute injury. And then you can see these little microbeads, and these microbeads are three-dimensional printed beads with stem cells in them. And the question is going to be, is that going to change the course of spinal cord injury? We'll wait and see. This is a delayed paradigm. So what do we have today? We have essentially, unfortunately, only two things in our armamentarium: decompression, which I would argue needs to be done as soon as possible, and secondly, as Dr. Samdani spoke about, mean arterial pressure management. And the fact is that decreasing that ischemia becomes an important part of what we do, because time is spine. When we have acute compression of the spinal cord, nobody's going to argue, just like if I stick my thumb in your eye, that I could make you go blind if I hold it there long enough, that we want to get that pressure taken off as soon as possible. So when we published the guidelines 12 years ago, and we start iterating on those, we realized that there's probably a benefit to increasing mean arterial pressure, or at least certainly avoiding hypotension. We spoke earlier about what's the best agent for that, and the adult norepinephrine Levophed is probably the agent of choice. And if you look at this now, we can elevate our art in spinal cord injury. We can actually start thinking about what our colleagues in brain surgery do. And you can see the theme here in spine. We're always a little bit behind the brain guys because we've been monitoring, intracranial pressure and treating that for the last 50 years, but we haven't been doing that in the spinal cord. But you can. And how do you do that? You can put a lumbar drain in and measure cerebral spinal fluid pressure and utilize drainage of spinal fluid to help you get a better, what we call spinal cord perfusion pressure. My inspiration for that whole paradigm really came from the thoracic surgeons, because back in the day, cross-clamping the aorta had a 40% rate of paraplegia. Imagine an operation that you did that had 40% of people paralyzed. But that was it. And what happens is once you cross-clamp that aorta, the pressure head increases and the CSF pressure goes up, and it goes up at the expense of local perfusion of the spinal cord. So why not drain the spinal fluid? This is a study that we published about 15 years ago, maybe less than that, where the most important line is the green line. If you're draining spinal fluid and increasing the MAPS, you improve perfusion across the continuum of the acute injury. If you're just increasing marine arterial pressure, it works for a while, and then its efficacy decreases. And the same with just draining spinal fluid. So the bottom line is that there's probably a merit to increasing mean arterial pressure in addition to draining spinal fluid. So we did a randomized prospective study that was funded by the Department of Defense. Unfortunately, because of a number of issues, we only enrolled 11 patients. But what we did show was that we were able to significantly improve the pressure profile, and there was a trend towards neurologic improvement, although we did not have enough patients to do that. But now there seems to be increasing evidence across multiple things, Brian Kwan and Sanjay Dal and others, showing that treating spinal cord perfusion pressure, not MAP goals, may be the way to go in acute trauma. And I would ask Amr after whether or not this is something we should be thinking about potentially in the treatment of children with scoliosis as we're doing these, as we know we're going to be invoking these changes that could occur. So we're moving towards this multimodality measurement. We devised a device here that measures real-time pressure you don't have to turn the drain off to get pressure, and also allows us to measure temperature and other discrete biomarkers at the time of injury. So really, nothing has really changed, but one thing I will tell you is that the direct number of mean arterial pressure is not necessarily correlate at all to blood flow. And this is what we'll talk about for the next few minutes. This is the problem, right? Amr talked about a case where, and I've seen this many, many times in my career, you give somebody narcotics, they drop their pressure, this is in adults too, by the way, and all of a sudden their exam in a patient who has a sick spinal cord decreases, and they're affected. We increase their blood pressure, they get better. So unfortunately, when we don't know what the end organ is doing, our posture is, well, more must be better. Let's drive the MAPS up to 90 or 100 or 110. I will tell you that we do have excellent evidence to show that in an older patient, we start pushing the MAPS above 85, 90, we start getting heart attacks, we start getting stroke, we start getting pulmonary complications, and I've seen blindness caused by press, from increasing the pressure too much. So the question is, can we monitor the spinal cord perfusion? So we were lucky enough to get funded by DARPA, and in an ambitious 5-year project for $15 million, we're developing technology, and again, it had to do with ultrasound. And this is the actual, you can see here, perfusion of the spinal cord utilizing high-resolution ultrasound. Look at that. I mean, this is the spinal cord the size of your pinky, and we're able to see microvasculature. And the real issue is, can we measure at the site of injury and around the site of injury what the perfusion is in the spinal cord? So it turns out the answer is yes. But the problem is a little bit more complicated, because you want to measure that perfusion intensity, and that first of all, you need to build a device that's small enough that you can implant onto the spinal cord to give us that regional information that we're looking for. And so this device looks sort of like a spinal cord stimulator. It's small, has a micro ultrasound array. And the ultrasound array, interestingly enough, doesn't just measure perfusion. It's not just diagnostic, but it's also therapeutic, because we can actually deliver low intensity ultrasound, which I'll show you later, can improve blood pressure and can do other things. So it's pretty exciting about what the possibilities are for this technology. So this is what the device is going to look like. You'd see you'd come in after your injury, you'd have a decompression. We'll take the device and implant it, and usually it will be adherent to actually spinal hardware, and then allows us to pull it out. And it has to be, the first device is wired, and it will be pulled out like a drain. The FDA does not allow a second surgery to be able to remove a device, so that becomes a challenge. And this is sort of what the device looks like. Again, like a spinal cord stimulator, that size and feel. And you can see it gives very good resolution. This is the device implanted. These are pedicle screws in a pig. If you think pedicle inlet screws are hard, you can go put those in. The next question was, once the device is built, how do you quantify blood flow? And this is where things get very interesting from an engineering perspective, because, yeah, we get these beautiful pictures, but we have to translate those into a number. How do we understand what's happening in a perfusion level? When you use ultrasound, interestingly enough, it's really easy when you use microbubbles. When you inject microbubbles, because the ultrasound sees these contrast bubbles, you get a beautiful picture. Problem is, in the ICU and in a human, we're not going to be, the FDA is not going to allow you to continuously inject microbubbles. So Dennis Rakovich, who's actually starting his residency this week here in Seattle at University of Washington, got his PhD in my lab looking at this and understanding how we can do non-contrast ultrasound to measure perfusion in the spinal cord. So this has been really an amazing situation. Thought that it couldn't be done, being able to take that and then utilizing our ultrasound device and getting a measurement of perfusion at the site of injury. The next question comes, how do you get this, if you're in surgery, placing this device, how do you understand where it is? And this is where segmenting the spinal cord, deep learning, operating networks, again, all these engineering things come to mind. So having one idea as a surgeon means absolutely nothing until you bring a team together that can actually put all these things together. But understanding where regional blood flow changes and how we can make this management and how we're actually treating the patient. So you can see here, as we segment hundreds and hundreds and hundreds of pictures of spinal cords, we're to the point where with machine learning, we put the probe down, it knows where it is, it gives us an adequate measure of perfusion, and we're able to move on from there. This was just published in Scientific Reports. And again, this is the actual device. That's amazing. We're able to do this now in real time in animals. We'll get to the humans here shortly. Here's the device as it looks like as you placed it on this rail. So you would actually clip the device onto the rods of a pedicle screw system or cervical lateral mass system. Allows the device to be held in place. You see the blue device, which then can be removed. So our first case was a couple of years ago, and it was amazing to see that this on the left, which you see is Canon high resolution ultrasound, on the right is ours. You lose a little bit of resolution when you miniaturize. We're making really one of the world's smallest ultrasound transducers. So you lose a little bit, but you can definitely, with machine learning and can optimize the pictures that you get so that you can see, is a hematoma in the spinal cord, is a hematoma expanding? What about pulsations? Important. We see that when we do spinal cord surgery and decompression. We always say, listen, if you see the cord pulsating, that's a very good sign. Seeing that pulsating in real time is actually pretty amazing as well. So this is the device that's been implanted. You see a small hematoma in the center of the spinal cord, and you see that right in the middle on the right-hand image, that line that goes up through is the central sulcal artery. So we're using that as our surrogate for perfusion. And then we were able to get readings on our patient here over time. And you can see here, so it's a very cool, and imagine not having to take a patient back to get imaging study out as somebody gets a little bit worse. Is there a hematoma, whatnot? We're able to see that in real time. And ultimately, again, as we get better at this, we realize that, as I said before, I mentioned that there's another possibility, and that is utilizing ultrasound for neuromodulation. And we've published several papers now looking at the fact that low-intensity ultrasound can actually change not just neuroparameters, we can actually block motor evoked potentials. We can do things that we wouldn't necessarily want to do, but we definitely can neuromodulate the spinal cord. But we can also look at things like blood flow and blood pressure. So we're able to now augment blood flow with low-intensity ultrasound, which is actually pretty cool. And ultimately, what we're looking at is, restoring autoregulation. And the fact of the matter is that what we want to do is get to this point where normal autoregulation is restored. We don't know when that occurs, And now that we can measure this, we can probably say, hey, listen, 5 days is fine in the ICU, 3 days is fine instead of maybe 7 days or longer. So what's happening on the cellular level, just a few other things that we've been working on. This is something called spatial transcriptomics. We're able to invoke a spinal cord injury in a rat, and then over time, see what's happening on a gene level and a DNA level. And this is actually very interesting because what we're able to do now is see that after you have an injury, what happens, what genes are activated. So we're now being able to look at the continuum of spinal cord injury and then understand what's happening over time, what genes are upregulated, which genes are downregulated, which actually helps us understand not only what's going on, but where we might be able to intervene in a more reliable fashion. Another technology we've looked at, stem cells have gotten a lot of airplay in spinal cord injury, but really have never taken on because we don't know what to do. Do you inject them? When do you inject them? Do they stay where they need to go? How do they form these connections? So we use a technology the cardiologists were using called a stem cell bioreactor, and it's basically a permeable sheath. You put the stem cells in the sheath, put that into the lumbar subarachnoid space, or it can be placed vascularly. Once you have a spinal cord injury, all the factors, the cytokines and all the other injury factors that are released activate those stem cells, which then pour out all the things that you want, all the protective things. So what we did was be able to place the stem cell bioreactor in a large animal model. We did a spinal cord injury, and then ultimately we're able to watch this. And a couple of things we found which I think were fascinating. First of all, the stem cells in the bioreactor survived. They actually lived, and they were producing. So this is showing you live cells, and they actually produce reduce these pro-inflammatory cytokines and increase anti-inflammatory cytokines. So this may be a stem cell therapy that we can actually use without having to subject the patient to stem cells, which have tremendous potential risk, immunogenic and other. But if you can keep the stem cells in the bioreactor and let the bioreactor just exude what you want, I think it could be helpful. We've been able to, there's a lot of talk about disrupting the blood-brain barrier for delivery of chemotherapy in brain tumors. We've done the same thing in spinal cord. And then I want to talk for a second about some big data stuff. So one of the interesting things is, it's hard to do spinal cord injury studies because the patients' numbers are not large and they're a difficult population to study. But one of our students looked at a very large database. And one of the problems with all spinal cord injury is bowel and bladder dysfunction. Well, it turns out that we know that catheterizing patients early is probably better than leaving a catheter in. Well, we were able to look at this in a systematic fashion and understand a couple of things. One, when we started catheterizing those patients early, you realize that those patients actually had a spontaneous return of bowel and bladder function much higher than those patients who were not catheterized or who had continued fully catheterization. And this is it right here. To the highest rate, I should say, of regaining bladder control, and it probably has to do with the afferent signaling. Think about this. If you're intermittently catheterizing, your bladder fills up, that sends a signal to your brain, I've got to pee. Those patients have that feedback loop, whereas if you continually drain urine with a catheter, there's no stimulation, there's no feedback, and those patients did not recover anywhere near as much. So this is a beautiful study that was done without any prospective study. This is all done on database work, which has allowed us to think about building a device which allows leaving a catheter in, which is great. But in those patients in whom it's too difficult to do intermittent catheterization, imagine having a catheter that clamps on a timer, allows pressure to go up in the bladder, again, giving you that signal and allowing you to continuously drain urine. The other thing we looked at was biomarkers for spinal cord injury. Unfortunately, we don't have a lot. We've got imaging biomarkers and we've got physical examination. So Tej Azad, one of my fellows who just finished his fellowship with Amar Samdani as well, we published a beautiful paper this past year in Journal of Clinical Investigation utilizing a multi-analyte blood test utilizing cell-free DNA for spinal cord injury. Now think about this. This test, we're now testing a myelopathy, and there's definitely a signal there. Imagine a blood test for myelopathy. You see a patient with cervical myelopathy. How bad is it? Or are they progressing? Or are they normal? We don't know. But what we do now have is a discrete blood test that we can use to study these patients. It turns out that it is incredibly sensitive because it has to, and it goes right back to this, not related to brain injury or other trauma. And this is distinctly designed for spinal cord injury. So it also correlates with injury severity. So at the end of the day, if somebody has a severe injury, we know where they are on the spectrum compared to having a more mild injury. And it also has a very good chance of predicting 6-month recovery. What does every patient and their family want to know when they've had a spinal cord injury? As devastating as these injuries are, am I going to get better? Well, now we have a blood test that may give us an opportunity to help predict that and help us manage these patients. And as we test this in myelopathy, what I will tell you is that it opens up an entire window, because right now we're relegated to looking at a picture and a physical examination and deciding whether that patient needs surgery or not. We have no other objective data. This gives us an opportunity to look into this and follow these patients, timing surgery for when it might be most beneficial. The last thing I want to talk about, last 2 minutes, is electrical stimulation for spinal cord injury. This is work that was done largely in Switzerland with Grégoire Courtine and Jocelyn Bloch. And one of the things that they found that we're seeing now with ultrasound too is patients with autonomic dysreflexia who have significant changes in their blood pressure when they sit up, or using electrical stimulation to do that. We can do that now also with ultrasound. So that brings up a whole new paradigm of treating these patients after the fact. But utilizing functional electrical stimulation for spinal cord injury, I think, is enormous progress. So what they've done is taken really an off-the-shelf spinal cord stimulator and programmed it such that you can get this patient who has not walked for 10 years following a thoracic spinal cord injury, Asia A, and get him up out of his wheelchair and walking. And the fact of the matter is, this is absolutely incredible. And what I will tell you is that the stem cells, the rest of the stuff is probably not going to be the answer in the short run. I think the answer in the short run for spinal cord injury, at least from a mobility standpoint, is going to be electrical stimulation. Right now, I think we're doing a much better job. I think spinal fluid drainage and perfusion management is going to be sort of the mainstay of the acute phase. And I will argue that the better we do at taking care of these patients acutely and preserving any sort of neurologic function, any sort of tissue preservation, allows whatever paradigm comes next, whether it's stem cells or electrical stimulation or whatever, to be more effective, right? If you have no spinal cord, then nothing is going to be effective. If you preserve spinal cord, I think any of these things are going to potentially be helpful. Again, the work does not occur in a silo. This is the team at Hopkins is moving to Arizona, and after the summer they're moving, just so you know, I'm not moving everybody in the summertime, it's too hot. But, it is really a tour de force when you bring together 70 engineers on a team to be able to solve a problem. It really has been an absolute joy of my life. I look forward to seeing this technology translated into man. But I want to thank Jens and Rod and the Seattle Science Foundation for the opportunity to come and address you guys today. Thank you.
Outstanding work. Great perspective. In the here and now, let's just start with the moon shot, the Mars shot right off the bat. How much does it cost to have one of those bioelectric prostheses in a patient per annum? So we saw these great breakthrough things from Switzerland. You mentioned the researchers. How much does that cost on a first run? We know this is just pioneering stuff. How much does the per annum upkeep cost?
Yeah, well, so the spinal cord stimulator is cheap. Everything else that goes around with it is super expensive. So what you're looking at is not implantation of a device, which might cost $15,000. Getting him to the point where he's up out of the chair requires multiple engineering support, programming, and some sort of transcranial stimulation, some of these algorithms, and putting that all together. It's not something that you're going to be able to put on at home and get up and walk. That's not going to happen, but it does prove a point. And once with that type of technology, we get to that point, the cost will come down. But again, that's right now, we're talking about a handful of patients, very carefully selected, who are able to get through this and get trained to the point where they can get up and walk. But it is expensive, but it is going to be the answer in the short run, as far as I'm concerned.
Really good. I loved your perspective from resuscitation towards everything from pharmacology to biotech to actual engineering technology. From a population standpoint, isn't it much cheaper to have mobilization technologies like neurorobotics that fit more patients, that allow for early mobilization to happen?
Sure. I mean, exoskeleton is what we're referring to. Amazing technology. That's not cheap either, by the way. And the fact of the matter is, there's certainly benefit to mobilizing those patients. There's no doubt about that. Again, scaling that, I think what we need to work towards is something where we can bend that cost curve a little bit so that we can treat more patients. Because right now we're still in the experimental phase. What works? How well does it work? How much of the population does it work for? And then how are you going to pay for it?
I want to, again, also recognize the importance of this evolving ultrasound technology. We are the beneficiaries of having a very nice one here. The other day when we had a cord signal decline in surgery, was really helpful to have that there and be able to look at the cord three-dimension. We don't have the bubble test yet, but cord perfusion and measuring that as the next thing more reliably would be a really big deal. That's become a mainstay for you now, right?
Yeah, I mean, listen, when I was a resident, we first pulled the ultrasound out, the whole field looked like a weather map, right? We used to say, okay, it's going to rain in Cleveland tomorrow. The resolution has gotten so much better, and it's so easy to use. I will tell you that for every acute spinal cord injury case, it takes 2 minutes if they've wheeled it in. Number one, how does your decompression look? Which is the most important thing before you leave the operating room. And then you've got some data on other things that are happening. But I think really the most important thing for us is, do we do a good job of decompressing the spinal cord?
Excellent. Final question then, just on a pragmatic basis again, MRI scans. So a former neighbor of yours, Bijan Arabi, he's been here several times. He seems to get MRI scans every 24 hours at latest.
Yes.
He could literally run a videotape of serial MRI scans on patients. How often after cord injury should we get these pragmatically?
I would argue that if you have an initial scan that sort of gives you the roadmap, if you were able to measure, perfusion and other things in real time, you probably don't need to get another MRI scan. That's what I would say. Remember too that Bijan, who's brilliant, a lot of his stuff is based on research. One of the problems, obviously, with getting serial MRI scans is there's a huge potential detriment to the patient by packaging them up and taking them every 12 hours or 24 hours for the MRI scan, where their blood pressure can drop, where they can have a pulmonary compromise, et cetera. So MRI scan is not a benign intervention. I'd argue that the better we get at bedside monitoring, the less we'll have to wheel patients in and out.
Great stuff. Thank you so much, Nick. Congratulations on your work. And let's switch to the lab and see how Professor Amr Samdani is doing and his team. Can we have, okay, I see with the backside of Dr. Gary, and he's having an argument about Phillies. Can you hear us? And Anthony's coming with a microphone. So we're going to get a live treat of pediatric scoliosis correction and techniques. And I want to recognize that Dr. Samdani is not just a world-renowned pediatric neurological and deformity surgeon, but also brought two of his fellows with him, Dr. Mohammed Al-Sharif, he's now at the University of Colorado, and Dr. Michael Rothbaum, who's doing a neurosurgery fellowship, I believe, at the University of Washington. So, Amir, can you hear us?
Yes, we got that, Jens.
So, great. So, Gary is still between you and the audience, but he's working hard on fixing things up. And again, it can't be said enough how much Gary and his team make these labs possible. So maybe you can just introduce your team members, Amir?
Yes, no, absolutely. And, if we can, we'll shine the camera out into the field as well. So, very lucky today because I have our fellow Mohammed Al-Sharif from 2022, who's got a very busy practice now in Colorado. And then Michael Rothbaum just finished with us in 2026 and decided to come join us for this course because he's finishing his neurosurgical residency right here locally. And then another very important member of our team made the trip is Matt Benetham from Depew Spine, who's our rep, and couldn't do this without any one of these three. And these guys have already fired the screws in. If we're able to just show the wound, that would be wonderful.
That's some robot. Do you have a dual robot? Did you use the 2 robots set up there?
There you go. I mean, and I'm telling you, and we checked on fluoro. I'm sure these will all look perfect knowing these guys. But, just want to go ahead and start talking. Jens, you can hear me okay?
Yes.
Wonderful. So, just going to overall big picture with pediatric deformity. Typically, we have right shoulder elevation. What you're looking at here on your, let's see, okay, the camera's a little reversed. That's right. Where my hand is the head. And then now my second hand comes in. Now this is the feet. I'm standing on the left side of the patient, which is where I typically stand just because most of the curves are concave to this side, and typically the pedicles will be a little bit smaller. We've instrumented approximately T4 or T5 to T11, T12. Usually the most common instrumentation levels for pediatrics deformity would be T3 or T4 down to L1, L2. But I think this level of instrumentation will go ahead and serve our purposes. A couple of quick comments. Typically, the right shoulder is going to be up in these deformities. And before we start correction, just want to let you know, I'm a big believer in releasing the spine. We pretty much do Ponte osteotomies on every single spine, and you'll do them around the apex. Typically about 4 different levels will get released. They're probably not necessary for the flexible curves, but I just find to maximize 3-dimensional correction, because here not only are we trying to get maximal coronal correction, we're really trying to recreate kyphosis, which is one of the primary goals of our surgery, because if we're able to recreate the kyphosis, that's when we find that we're able to get best compensatory curve correction in the lumbar spine and the coronal plane, but also, as Rudy had shown a little bit earlier, the compensatory sagittal plane correction in the cervical spine. A lot of these patients will often be kyphotic. If you're able to recreate that kyphosis, you're going to see some reversal of that cervical kyphosis and hopefully lead to less issues down the line. Overall general principles of correction. We've got our concave left rod, which we're going to overbend into a lot of kyphosis. So typically this will be about 40 degrees, and then we'll use the concept of differential rod contouring, where we underbend the convex rod, about 20 degrees of kyphosis. This is perhaps the most important part of this procedure, and the part of the procedure that we have the least objective data on. Here is where robotics and machine learning and AI is really going to be able to get us to get surgeons that are earlier in their career to be able to do this procedure, much like a Chris Shaffrey, let's say, would be able to do. Because right now, this is totally by feel and by just looking down and saying, all right, I'm going to try to bend 40 degrees. We actually did a study where we showed a bunch of x-rays and we had surgeons bend how they would bend the rods, and it was all over the place. So again, a lot of work to be done in this space. Typically, we're going to start on the left side, the concave side, and what'll happen is, the thought is, as you're lengthening and correcting the spine, which we won't be able to see here because our cadaver obviously doesn't have scoliosis, is you're going to go ahead and lengthen the spine and pull the spine into kyphosis. What you have to be very, very cognizant of in a very severe spinal deformity where the apex is fixed, that's when you can actually end up pulling the spinal cord into that concave pedicle. It's pretty rare, but think about a congenital or a revision or some of those a couple of the really severe ones I'd shown earlier, where you may have to use a different mechanism of correction and not drop the left-sided rod first. So I'll just go through the way that I typically do it. There's so many different ways to end up with the same result, but in my hands, this typical set of sequence of events is what gives me the best correction, not only on the curves that are more flexible and 55, 65 degrees, but also on the curves that are on the higher end, 85, 90, 100 degrees. Once our screws are in and we've bent our rods, we're going to go ahead and get our reduction instruments on. And we will start proximally and work our way distally. Let's see, give some to Mohammed as well. Go. Thank you. and maybe the top 4, because I think they're a little bit limited. There we go. And typically, we would go ahead and put as many of these on as we reasonably can get. And once these have been placed, we'll take our concave rod. I really believe in symmetry, so oftentimes I'll cut the rod in a way where, the nipple is either to the bottom or to the top. Typically for me, it will be on the top. And I'm going to slide this through our reduction instruments and rotate the rod into its appropriate sagittal plane. And I don't know if you can see or not, but at the top here is, let's see if I can move. I've left the rod long on the top here. I'm
Yeah.
moving my hand out of the way.
Yeah.
If you may be able to see this on this side here, but I've left it long because when we correct the deformity with the right shoulder being high, I'm working on the left side, that left shoulder is going to start coming up as we start correcting this. Once the rod has been rotated, and I like rods that have a marking on the top like this one does, we'll put it into its appropriate sagittal plane, and we will line up the rest of these with either hook holders or with more reduction devices as well. So we'll go ahead and line these up. Once these are lined up, then we try not to stress the ends of our construct because we want to really preserve those, and we'll start dialing these down and start reducing our rods as we bring this down. Yep, there you go. This is actually a different hook holder, so we're gonna grab it.
Amir, there's a question from Mr. Viscogliosi.
Of course. Yes, please.
As you indicated, the bending of the rod is done in the operating room at the time and is maybe the most skilled thing that you do. Why is it? First of all, is every pediatric patient CT imaged?
The majority of AIS or pediatric patients will not get a CT scan, just trying to minimize the radiation burden on the children. And the majority of, there are some pre-bent rod options and planning, but it hasn't really come into widespread use just yet because there's still just not as good an understanding of exactly how much to bend and the time frame that's required for these patients. So we've typically still been just bending them in the operating room, but over time, there'll probably be more planning and start getting bending done earlier as well.
Yeah, because I'm just wondering out loud with you.
Yep.
That if you had, if you were, let me ask the question this way. Is it worth getting the CT image for a child patient, pediatric patient, if you could get pre-bent rods that are more scientifically designed to affect the derotation and the anatomy that you want to create?
Yeah, so generally, we're going for maximal correction, and our bends are really only in one plane, which is the sagittal plane. That's why they may not have as much utility, at least the ones I've seen right now, but clearly, there's going to come a time when we have a better understanding of trying to dial in how much bend we're going to need that accounts not only for what we're trying to achieve postoperatively in the sagittal plane, but also how much of a bend can be tolerated by the screw bone interface as well. Because right now, if I have a great screw bone interface, I may bend in 50 degrees of kyphosis, but if I feel that I have some screws that may just be 5.5s or 5.0s across that apex and that are short and they don't feel that strong, I'm going to be much more concerned about building in maximal kyphosis.
Okay, great. Thank you for that.
You're very welcome. I hope that helped. So what we've done is we've left the rod long at the top because we know as the spine corrects, we're going to go ahead and start getting that right shoulder to come up. And one of the, let's see if we can grab this rod, guys. If you can give him a rod holder or something. Mo's going to go ahead and hold this rod in place while I bring down, which I'm going to call T5 today. I'm going to bring that down. the links are going to be fine. And then typically at this point, as the spine is correcting, I'm watching what those top screws are doing. One of the most frustrating things with what we do is you get a great correction, you got a good sagittal correction, now that left shoulder is up because you've gotten such a big correction. And I've gone to now locking these top screws. So let's say we've instrumented T4 to T12. I'll lock T5 down and hold it in place because the rest of the correction that I want to happen is to happen distally. I want the rod to lengthen, the spine to lengthen distally because T12 will also often be tilted left-sided high. So as it lengthens, it will go ahead and level out T12 as well. Let's see. Good. We got that. So we got that first one on. And now we're just going to keep marching down. So now that it's exactly. May need a cob to just take that tulip and just turn it. Here it is. Now we're going to go ahead and take our reduction instruments. And often we'll have a few more of these. And we'll have these already lined up and can just march our way down as we move down. Bring this one up as well. There we go. So then the rod reduction will occur. Many times here, we're trying to pull the spine into kyphosis. And again, cadaver is not hyperlordotic, so you're not going to see that, but we'll start seeing the spine pull up as we march our way down. See if we can throw in some more set screws, guys. Yep, at the top. And then one here as well. Up top there. Yeah. This one may need a little more.
Some more.
Yeah, I may need a little more. Maybe drop it right there. There you go. Good, and Mo, you can probably let go. Take another one, and then just add these to the bottom. Matt, this will go through all the way?
Yep.
Good, and then the rest of these we leave fairly loose because we're gonna use the looseness in these to help us correct the spine as we bring that convex rod down. Another one? Good, coming back. Exactly. So now we've pretty much gotten this left-sided rod down. If you guys want to fill in some of these set screws. And then once these are down, yeah, we'll pop all of these off. Then we'll start working on the other side. Typically at this point, what I like to do is, do you have a pair of pickups there, Matt? What I like to do is as we're measuring and cutting for the other side, I still actually do a little bit of, do you have a little pickup, Matt? I do like to still do a little bit of inside tube bending. Most people do not do that. I like to get a little extra correction with some inside tube bending. I don't think we have the benders here today, but I would usually do some inside tube bending from the other side as well. Yeah. Yeah, exactly. We're going to drop this down. Let's get these last couple of ones down. And one of the big differences that's happened is because of differential rod contouring, we don't spend as much time derotating the spine, which we're going to show you right at the end, because I feel that a lot of our derotation has already occurred with the differential rod contour and what we've done. The rod sizes that we would typically use would be, yeah, we can start lining these up, would be I usually use a 6.0 cobalt chrome rod on the left side and often the same on the right as well. Let's do one thing. Do you have a little set screwdriver? Let's just rotate that rod and turn down us a little bit. Mike, do you mind just turning the rod a little?
Yep. There you go.
Want to really make sure that it's lined up in the sagittal plane. I think this one must be the one that's tight. Give that one more shot. There it is, that looks better. Now I'm gonna tighten one at the bottom and one at the top. The other thing that we'll often do is, obviously we're worried about the shoulders. We don't want that left shoulder to get up too high, so we're tightening up top. But many times I'll also tighten one of the distal screws, not the LIV, but distal, because the way I see it is if you have the top, let's say T5 locked, and you have T11 locked, and you're going down to T12, when you are correcting the spine, the only place where the spine can go at that point is into kyphosis. So oftentimes we'll lock the top and the bottom. You can see here, this will be our next rod, which is under bent, and we're going to start dropping this other rod down as well. May need a hook holder. Yep, there you go. And oftentimes, by this time, the spine is straightened out pretty nicely, and the second rod usually goes down pretty easy. I'll take a rod holder. And here, what we're going to do is, I'm going to line up this rod. Yep, I like that hook holder idea. I like that. Maybe at the bottom and at the top. Yeah, and then grab one at the top as well. Take one more. Just want to make sure. And again, many times we would be using just reduction tools. We just need a couple more. Man, another one or no? Another hook holder? Just to make sure the rod's going to fall in. And here, we're going to start from, again, T5, the second one down, and really tighten our set screws as we march down, and then so we're able to cantilever this in. Good. And then Mohammed, if you can just follow with, yeah, exactly, with the set screws. Drop these set screws in. In patients that I may have had the neuromonitoring signal changes on, I would definitely then just go with the convex reduction first, is what we'll typically do. Good. All right, so now that the second rod, whoops, is almost down, take another reduction. Zoom in here. Yeah, another one can come off. And then now that we're putting in these last couple of set screws here, what we do at this point is we're going to start setting up for our derotation, which is really our final maneuver for correction. Derotation, compression, distraction. We'll add a couple more of these set screws in here. Yep, 3 more.
So as you're doing this, again, this is beautiful. That correction looks fantastic. 2 quick questions. So one is, we see all these diagrams with these large derotation blocks, and that's always so intimidating looking. Is that something that you actually use?
So, we've done a bunch of different papers on this, what kind of techniques to use. And where we've landed up, and where I think the literature supports, is if you use differential rod contouring, segmental derotation is usually enough. The downside with segmental, i.e. one vertebral segment at a time, is you're maybe at a higher risk for plowing, so you can't be too aggressive with it. But what I feel is if you do an end block, each of these vertebrae is going to be rotated to a different extent, and you're going to be limited by the one that's least rotated. So I like to just do segmental, so I don't use the blocks anymore. Some great surgeons do, but in my hands, I just go to segmental derotation. And the segmental derotation, basically we're going to find a neutral vertebra, which we're going to call T11 here, and bring this down. We're going to tighten those set screws down. There we go. Put on a couple more. And there's so many different ways to do this. Some people will use reduction screws all the way up and down. I think that works well. Many times, as you know, the derotation tubes aren't going to be standing straight up. Typically for us, this would be way over to the side. They're going to be really angled like this, and we're going to be spinning them over. This will be used to hold a counter rotation. We got these as well, perfect. We're going to attach these, unitize these on the bottom. And another one at the top. We'll go ahead and do this. There you go. So now we're going to just rotate. We're going to use the bottom as a counter, and we're going to de-rotate across the top. This is really primarily when we're at the apical level in the thoracic spine. This is to help improve rib prominence, which is one of the things that really affects the self-image for many of these patients. But I find that derotation, which we're going to do right now, certainly has value, aesthetic value. So again, this bottom one, I'm going to hold steady while we really rotate this top one over, and then we tighten those set screws down.
Chris, I'll hand my microphone to you. Is this something that in adults, meaning like 65-plus patients, is relevant, this derotation maneuver, or is this something that should be really reserved for osteodense pediatric or adolescent patients?
Yeah, I think that Amir made exactly the point. It depends upon how strong and dense your bone is. So if you're doing just segmental derotation, I think that there is some advantage, and you kind of saw that with some of the stuff that Rudy was showing and other things, is that you want the spine to be appropriately aligned. What happens is, you know, and you've taught so well, Jens, the older you get, the more you have to loosen the spine to get any type of correction. So your osteotomies or interdiscal work and whatnot then is needed to be able to have the screws affect the alignment of the spine without exerting a tremendous amount of force on them. So as I showed on the case that I had done, and that whatever 39-year-old, that I was, because the bone was pretty good on her, that I was pretty aggressive using reductions and fixed angled screws to be able to go do that. And I don't know what Amer's belief is, but in general, over the convexity screws, I've been using fixed screws because just again with the differential rod, the differential rod bending and whatnot, I think that over the convexity, I think fixed screws seem to work better to allow that rotation to occur. So I think all of this, all these principles are good. The advantage of young people is their bone is much better, so you can be much more aggressive. And that's why I like to use the reduction, the tab reduction screws, is then you can much more gradually be able to go and induce it. But I think the concepts are still the same. Jens, what are your thoughts? You do so much of this.
Yeah, so I usually de-emphasize derotation at this point in time. For older patients, I do think that getting coronal sagittal balance together is what they really want. And again, my deflection question goes to Professor Samdani, and that is costoplasty. Is that over? Do you do costovertebral articulation releases? I've always found that, especially mid or upper thoracic spine, to be particularly necessary to kind of get a little bit of a derotation effect.
Yeah, so, you know, we do costoplasty about 10% at a time. We used to do them routinely. Professor Suk, you know, has done them routinely throughout his career, but now only for very severe spine deformities where there's a rib prominence that's in excess of 20, 25 degrees on the scoliometer is when we'll do costoplasties.
Then final question from my end, maybe Dr. Theodore or Dr. Shaffrey or others have other questions. In selecting the lower, you mentioned the neutral level before, and you said something like T11 in that particular cadaver case of yours. I've seen the trend, and Dr. Skaggs has lectured here several times, to fuse less, to be shorter in your fusion level choices. So in your case, is less more, or do you strive for having a truly neutral vertebra as your caudal anchoring segment?
Great question. So less is 100% more. My starting point for LIV is the CSVL, and then the vertebra that would be neutral or close to neutral above that level. I do think that derotation, although it's got an aesthetic appeal in the thoracic spine, for the LIV, if we really want to get compensatory correction, I feel that LIV has to be corrected in 3 dimensions. So I will derotate, often a counter derotation at the LIV, and that's more that I'm able to save levels and to get the best 3-dimensional correction.
No other question of mine. This came across really, really well. Thank you. You're not just a great participant and creator of case discussions, but also a great in vivo teacher. So much appreciate you being here and taking the time to show us how it's done in your capable hands. Thank you very much.
You're very welcome. Thank you.
As we're breaking down before the next lecture, I want to just take a little commercial break. So can I ask the representative maybe of therapeutics and bone foam to come up? So we've seen some of the great big company names. We want to thank Globus. We want to thank Medtronic. We want to thank DePuy Synthes for their implants and for their know-how. We'll ask maybe our representative, come on over here from therapeutics to briefly come up to the front here. Tell us your name and what you're representing.
I'm Sean Lesage. I'm the Area Vice President for Therapeutics. I'm a biologics specialist for over 25 years in the industry.
And you have a product here that's basically a bone graft substitute. And tell us about that. And I'm reading the name Pearl Matrix. So what's this all about?
So this is the first amino acid P15 technology to come to the market. This is our second generation product. The first generation was iFactor. This product actually is the first of its kind to actually show clinical superiority and overall success in a level 1 study. And those were studied in 60% high-risk patients.
Great. And so again, how many patients were that? And what was the premise there in the Mayo Clinic study?
So there was over 290 patients in this clinical study, and we compared it against patient's own bone. And actually, at the first 6 months, what took autograft 2 years, we've seen that in the first 6 months with this study. And actually, Mayo Clinic just is going to be publishing a study, a head-to-head study versus Infuse. And so we don't know all the details yet, but we do know that it does produce more bone, about 30% more bone than Infuse.
So the age-old question was conduction versus induction. Are you making the conduction or induction claim now?
Well, it's a little bit uniquely different with this particular product, with this amino acid. Traditionally, you think of inductive, osteogenic, and so forth. This does have an osteoconductive component with the carrier, but this actually works on a different cellular level, more second or tertiary conduction.
And I saw you brought a little plate here. This is not, we have to take it away from Dr. Shafi. It's not a dessert.
Don't eat it. Yeah.
Don't eat it. So why did you bring that? What's this showing us?
So one of the challenges with biologics is the handling characteristics, right? So while this second generation is made out of collagen, so you can see that it's very fibrous. And so that fibrous allows for better handling characteristics. But the first generation works well, but its indication is in cervical. This lumbar application,
okay, here we are.
You can see all the fibrous carrier. So it's actually closest thing to almost irrigation resistant when you put it in where you need it. And it does have a complete 360 indication by the FDA. So this is the first level 1 PMA IDE product to have a full portfolio indication for lumbar spine. So
thank you, Sean, and thank you to Therapeutics for your support.
Thank you very much.
And we have some handouts for those. And we'll also ask Bone Foam to come up here. So thanks, Sean. I think Bone Foam, this is a company I did not know of before, and they had a nice exhibit here. Is our Bone Foam representative here? Otherwise, we'll ask Companion Spine to come up here. And they have a slightly bigger prop here.
A little bit bigger.
So maybe you come a little bit more in the center here in front of the screen. All right, so who are you to come in front of this screen here?
Absolutely. Jake with Bone Foam, not State Farm. That's my one-liner.
Okay, and so Bone Foam, what's this all about here?
So a couple of years ago at AORN, we had surgeons coming up to us saying, you're doing positioning for trauma, orthopedics, all of this. Why don't you have anything for spine? So this was the first area we wanted to tackle, and surgeons specifically talked to us about. Hold it. Wanted us to tackle, which would be anterior cervical. So our system is really focused around making it efficient and repeatable for your staff, taking a lot of the fine tuning off you guys. There's a reusable system here, and there. So that goes on the bed, straps directly onto a standard OR bed, Jackson flat top, what have you. And then there are some patient straps to help hold the patient in place, get it a nice repeatable position for as many of your patients as possible. Designed for high BMI patients as well. So we've got tons of length on our straps. You won't run into any issues there. 2 arm straps, adjustable head pillow. Anesthesia really likes this. Gets the patient to a nice ramped position with a big hole in the back of the head of the pillow here that's going to allow you to lift the chin, and it will cradle the head and help to hold it in place. And then finally, this is kind of the most important piece of it, is our Y strap. It hooks around the shoulders and goes to a singular pull point at the foot of the bed, allowing us to get better traction than traditional methods such as tape, as well as getting tape off patients, right? So we have patients who are somewhat older at points or with fragile skin, and that can create issues. So our goal is just to simplify it for your staff and for you guys to come in. We pull traction, we can lock it out for constant or do intermittent, and then we can see where we're at. We usually say we can get another half level to a level. It's anecdotal at this point, but working on it.
So I'm looking back in the room, and one of our fellows here, Hagai Amsakam, has a giant smile on his face, and so I think does Dr. Karami, because no more 3-inch foam tape, right? You approve? You want this? Dr. Karami says yes. He wants to see it in the hospital. It's a trial.
That's great. Yeah.
Okay. Well, thanks for being here, Jake.
Absolutely. Thank you, guys.
And the final smaller company that we saw in slides before, I'm going to put the hat on before. Do we have somebody from Companion Spine here? Who would like to come up? Mr. Bill Faust, come up here. You're wearing a nice green suit. Do you recognize that hat?
Nice hat.
It's a nice hat. Okay. Tell us who you are and tell us about Companion Spine. We heard. You want to wear this hat?
No, it's
I'll give you
okay.
my hat.
All right.
I'll give you my hat.
So for those of you that I may not have met, my name is Bill Foss. I'm the Chief Revenue Officer for Companion Spine. Companion Spine was founded by Anthony and his brothers in 2020 with a purchase of products from Medtronic, including the Dion product that Dr. Bertagnoli showed today, along with 40 other patents and other technologies that we purchased. We then added to that company by repurchasing Paradigm Spine, the Coflex device, which Dr. Bertagnoli also showed today. So those two devices in the United States comprise our current product portfolio. The Coflex device, which you saw here, as well as the Dion device. Now, in the United States, we specifically address the two degenerative disease states of the lumbar spine, degenerative disc disease and lumbar spinal stenosis. That's our specialty. That's what we do. No tumor, trauma, scoliosis, that's not us. We are early stage intervention in those two degenerative processes of the lumbar spine. Now, outside the United States, we have additional product lines in Europe and other parts of the world that apply to these same categories: motion preservation, the two predominant degenerative disease states of the spine. The acquisition of Paradigm Spine, which the brothers sold for a nice number in 2019 and bought it back for a much less number in 2025, has a complete portfolio, some of which Dr. Bertagnoli showed earlier today. So we are a broad stage global company focused on those two degenerative disease states of the lumbar spine.
Great. Do you want to introduce the members of your team here?
Yes, with me up front are Kyra Coulter, who's our marketing manager in the United States, and Spencer Kandari, who most of you know, who is our regional specialist here in Oregon and Washington. And of course, I think everyone's met or knows Anthony Viscoliosi, my boss and the founder of Viscoliosi Brothers, as well as Companion Spine.
Thank you, Bill, and thank you. I'll only take about 20 or 30 minutes right now. Just kidding. Viscoliosi Brothers has a lifelong mission of being totally dedicated to your world. Myself and my brothers are not just CEOs of a business. We are totally committed to supporting the transformation of innovation in spine care to truly have a gigantic impact on human healthcare. Over the course of our careers, we've been innovators with technologies particularly focused in motion preservation. And in the last year and a half, we have acquired the former Stryker spine, and that's now VB spine. And with the organization of more than 1,500 people now, and the combination of unique innovation that we've supported, my brothers and I strongly believe in the opportunity that the future holds for integrating the entire system of enabling technologies in navigation and in robotics that Dr. Theodore was speaking about, focusing on the innovations that I think we're going to hear more about Amir discussing in pediatric deformity correction, and particularly with the efforts that Dr. Bertagnoli has worked on for his whole lifetime, and that is to integrate the concept of using stabilized motion to restore form, function, motion, alignment, and stability, while at the same time alleviating pain in the lowest cost care setting possible. You are in for a great future, and we'd like to be supporting that future very strongly. And you can see it by the technologies of Sentinel Spine, Companion Spine, VB Spine, and even Woven Orthopedics that we have supported to help you take care of your patients in the best possible manner. Thank you for the opportunity to present. And I'd just like to say one final word is that we're really excited as a business to bring to you the only company that's focused on solely degenerative spine diseases, that's Companion Spine, with a complete portfolio solution addressing the very earliest stages of the disease to the latest stages of disease with a dynamic coupler that Dr. Bertagnoli was talking about that are used in the entire continuum of care. So look forward to meeting each one of you more in person, spending more time together.
Thank you, well spoken, and thank you to all the companies, but also especially to you as a CEO coming here in person means a lot to us, so thank you. Hearing us speak, taking notes. And of course, I thought that this would be a very good opportunity to recognize the smaller companies, but this would obviously all not be possible without their support, but also the support of the major manufacturers, Globus Medical, and Medtronic, and DePuy Synthes that we just saw. And if you thought I forgot about Sentinel Spine, that'll be the last lab of the day at the hands of Dr. Bertagnoli, showing a ProDisc L. Is that right? You're going to show a ProDisc L? How to get those perfectly into the center. And centering the spine, Dr. Shaffrey, you heard the request, the mandate.
Oh, you want me to speak?
Also speak. So this is a common problem in our aging and polymorbid population, that is that we have cervical, thoracic, and lumbar problems in combination, and what to do there, and how to get this all done without doing a magnum opus in one setting is a huge challenge. So nobody better than Dr. Shaffrey to kind of put it all together.
There we go.
Yes.
Well, I'll just tell you, I, again, want to commend Jens, Rod, the whole Seattle Science Foundation team for what is always such a tremendous course and opportunity. And so I'm so honored to be here with people like Rudy and Nick and everybody who's here, Amir, showing such great stuff. So one of the things, and I'm going to show a case to kind of bring this to light. This is a 46-year-old person who comes to me having had multiple different surgeries. Most of them turned out to be, it was probably for Sherman's kyphosis, but in the depth of time, it's a little hard to know what the initial operation was. But she came in here to see me with a history of just unbelievable, intractable, unrelenting neck pain. She said, my neck, I not only have neck pain, I have these incredible headaches, symptoms of greater occipital neuralgia. Said she can't eat, sleep, work, do anything to her horrific neck pain. So she had seen multiple surgeons, and basically each of them said to her, you need to have a fusion from the occiput to the rest of the spine. And she goes, what are your thoughts? One guy said he might be able to stop at C1. Can you stop at C1? What do you need to do? So I looked at this and looked at our traditional measures, and you're going to see some additional measures that I use to try to go and determine where exactly the true deformity lies. And some of these things, like the occiput C2 angle, T1 slope, and some other things, which I'm going to go into a little bit more detail, led me to do the operation you're going to see in a second. And she came back, and so I said, look, I don't think you should have any fusion whatsoever done to your neck. None. I said, your problem is a thoracic and lumbar problem, and I did 2 different VCRs and did this realignment, and you can see her neck, and suddenly her NDI is 12, she's fully appointed accountant, and I promise you, if you'd extended her up to her skull, she would have not done well. So how do you go and determine where the deformity is and how you go and correct it? And what you can see here is that, some of these different angles are dramatically different. And this occurred because of relaxation of the spine, because I corrected her deformity elsewhere. Her deformity was not a predominant cervical deformity, and her deformity elsewhere led her to having severe neck pain. So one of the first concepts we talk about is kind of the thoracic incidence. And just like when we do the spinopelvic incidence, what happens is how your T1 vertebrae is aligned, if you have a flexible cervical spine, drives the alignment of the rest of the cervical spine. So one of the first and one of the principal things that I'm looking for is what is the T1 slope. And one of the things that you can see here, if you have a rigid spine and you have this T1 slope, it's going to protract your head forward with this. And if you have a flexible spine, it is going to go and result in more cervical lordosis to compensate for this. And because your head in general averages about 4.5 kilograms, there's an awful lot of force if your head's either protracted forward to be able to go and drive symptoms. And this is some work that was principally driven by Chris Ames about this whole concept of the C2, C7 sagittal vertical axis. And if you look at the results from this correlation with people being symptomatic is far greater than Steve Glassman's famous paper about sagittal malalignment of the thoracic and lumbar spine. You get your head protracted forward, and the reason why, this is an image from Chris Ames showing that's what her muscles are trying to do to be able to keep her head centered over the center of her pelvis, is doing that. And this is what I'm showing, that the correlation for this C2 to C7 SVA is very, very highly correlated with neck disability. And the correlation is much better than Steve Glassman's work that kind of revolutionized the spine. Now, the second measure that I look to is something called the C2 slope. And I think that this is the single most important marker to know whether you have a true cervical deformity. And again, it's very highly correlated with patient results. And so what's happening is is that this measure, and you can see there from the bottom of the cervical spine to the horizontal, that number correlates extremely highly with the presence of true cervical deformity, and it also correlates very, very highly with all patient outcomes. And let me see, there's some, so I'm gonna have to go here. There was some warning thing on here. And what's happening is that knowing what the C2 slope are and the C2 and T1 slopes are really gives you a great estimation of where the deformity is. And if you restore those to normative values, you're going to have really good results. So basically, what this is in a nutshell, if I will always in every patient measure the C2 slope and the T1 slope. And if I have a high C2 slope and a normal T1 slope, that means the deformity is localized in the cervical spine, okay? If I have a high C2 slope and a high T1 slope, then this is a combined deformity involving the cervical spine and the thoracic spine. If I have a normal C2 slope and a high T1 slope, then it's a thoracic deformity that your body's been able to go and compensate for. So basically, by doing these measurements and doing the C2 slope, the T1 slope, the SVA, that gives you the vast majority of information that you need to know to where the deformity is and where you may be able to do the smallest but most ideal compensation for that. So another thing from Chris Ames, and this is, I think this classification is usually more a matter of being able to look at through things systematically. Is there a coronal component? What other things? What's the cervical lordosis? What's the T1 slope? What are these? What's the C2 slope? And by looking through these things and working through this classification, it really helps gel and coordinate where exactly the deformity is lying and what you need to do to be able to go and to correct it. So again, for somebody, and this person again has a very high C2 slope, what is recognized is that this is going to require a cervical deformity correction in general. If you start to get a little bit higher in your T1 slope, you may, for example, carry it down to T4 to get a little bit of additional correction there. But this involves your thought process as far as how you're going to treat this. And at least for me, every cervical deformity case gets, at our institution, an EOS x-ray, but at least a long cassette x-ray to go and evaluate where these are. Once you know where it is, then there are a variety of different osteotomy techniques that can be used to decide how to loosen the spine and how to correct it. So when we're again into this decision-making, we're looking at the magnitude of the deformity, the flexibility, whether there's neurological compression, what's the integrity of the anterior and posterior columns, and whether something is truly focal or more global. And again, this is another one of these many sort of camped cornea cases that I see. This one was due to juvenile rheumatoid arthritis. The whole spine was fused, you can see, and it required a 3-column osteotomy for me to get this degree of correction. Now, it's not perfect, but after I did this, I was going to do another set of osteotomies, and she said, that's enough. When I'm looking here, this is a person that's got a pretty terrible deformity, but a lot of this is due to a myopathy that's done it, and the person had relatively poor bone quality. This is something that I could do posterior column releases and realignment, but because it's a myopathy, I'm going to take this down further to make sure that I've got enough bony fixation below the origin of the semispinal cervicus. Another one of these complicated cases that I did. And again, you can see it relaxed a bit with the patient being supine. And with this, I decided to do there's some missing slide. I decided to do a front back from that. This is another case where it's flexible, and I will occasionally use preoperative traction to be able to assess the flexibility alignment and be able to do something a little bit smaller. There's other things where the spine is fused. There's other cases with neurological compression, and this is a person with a pretty severe myelopathy for a severe PJK that got fixed into place above. And this is going to require a 3-column osteotomy, then an eventual extension down to the pelvis with another case done subsequently. And again, something like this where, again, a pedicle traction osteotomy is part of what was needed to correct the entirety of the deformity. So lastly, I think the workhorse for the cervical thoracic junction is the 3-column osteotomy. My one lesson to impart is T2 is the best level to do it. T1 or C7, the neurological compromise rates are far, far higher. This is me just doing a kind of a standard T2 osteotomy. I have a tendency to use bivector traction with these cases to be able to get intraoperative correction. You can see with some reduction screws and the results of this correction. The one thing to realize is that these operations are fraught with potential complications, and you really have to, gird your loins before you get into them, because there are different problems. I've got a lady now who's 3 months out that I did a horrific chin on chest deformity. Again, Parkinson's patients who's got a gastrostomy tube because she just really couldn't swallow. Well, part of it I think was Parkinson related, but part of it was due to a shortening of her esophagus, that I did a posterior only 3-column osteotomy and she couldn't swallow after that procedure. So these are the kind of things to get yourself into. So hopefully, the initial part talking about the C2 slope, T1 slope, and the overall assessment can really help direct where your deformity is. And then there are a variety of different techniques, including what we talked about, the pedicle inlet technique, to be able to achieve the best correction. So with that, thank you. Any questions?
So a common problem for us, Chris, this is excellent. And I love that C2, T2, or T1 slope emphasis. This cannot be overstated. This is, again, everybody's so fixated on lumbosacral alignments and sacral parameters. This is way more important. So thanks for pointing that out. Tell us about the influence of sarcopenia and malalignment. Because again, as we're having these structurally fixed measurements that we've now become so fixated on, tell us about sarcopenia and how that affects it. Some of those camptocormia patients are, I'm sure, completely wasted, and there's a reason why they fell into this camptocormia.
So in my institution, I'm always in trouble because I average seeing my patients about 6 times before I operate on them. So most of them, as Jens pointed out, they are a sickly group of patients. Many of them have other comorbidities, either some type of rheumatological problem like rheumatoid arthritis, they've got something like central core myopathy or something like that, or they have things like movement disorders, essential tremor, Parkinson's disease and whatnot. And all those are bad actors as far as surgery. So the first thing that I do is I begin a process of doing a multi-factor evaluation, including bone health and including nutritional parameters. So for me, I'm very aggressive about correcting both of them. I will not operate on the cervical thoracic area unless we get their Hounsfield units up to at least 160 in that area, okay? For the thoracolumbar spine, it's usually 120. For me, it's 160 for the upper thoracic area. And the reason why you're gonna DJK, you do these things, they're gonna break down, so that's important. I do put everybody into a very aggressive preoperative kind of rehab program. The problem, again, is these people are the most resistant and the most difficult because they're so debilitated. To get them into the pool or something like that is usually very difficult. Fortunately, in our region, there's several places where I've talked to the therapists and whatnot and said, look, can you even just to get them and paddle and float around in the water to get some type of exercise? For some of the people with severe chin on chest deformities, I've got to talk specifically on that, and I can show you a couple pictures. But I've gone and put gastrostomy tubes in beforehand because if they don't get their nutritional status up, I will not operate on them. So going and trying to optimize these is just enormously labor intensive, and the amount of disability. I mean, these people. I've said you never get an ODI over 60 unless the people are insane. This may be the one exception. And I've had people come in here and said, if you can't help me, Dr. Shaffrey, can you just, can you be like Dr. Kevorkian and kill me? I just don't want to live like this. It is so horrible and so miserable. Now, I will tell you the converse of that is that these people are also your most grateful patient. They come in and they can't move, but their head is up and they can interact on a daily basis and do things like that, and they are extremely pleased with the results of surgery. So the fact is you are going to have, and this also goes to your institution and other things, the complication rates for these are 100%. You're going to have some kind of problem. And if you're thought of as the tertiary center and there's a tolerance for this, but the fact is you are going to be, when you do these cases, each monthly M&M, there's some, thing, and Deb Bomix on our institution does a lot of complicated cervical stuff. And between Deb and I, it's like the ping pong ball of M&M, dealing with this stuff. But if you look at the results of these patients in 2 years, they are truly your most happy patients. And the fact is you get them through all this stuff and they just do wonderfully. So optimization is key. This is not a group of patients you just want to see one time and bring in. And there are ones, and I think Amir sees this, I've had ones where I brought them in addition to putting a gastrostomy tube. I've got a lady, I'll show a picture of it, that developed a horrific, she had completely eroded. When I put her in a little bit of traction, I can see the bone on the undersurface of her mandible and the bone of her sternum that was completely exposed because her chin was on her chest for so long and had a horrific fungal infection because that area had not been exposed. So I kept her for a month in the hospital as that all gradually healed and by secondary intention healed in. I'll put it together for those that come back next year, because this was one of the cases where I used the pillar screws and did it because her neck was such a mess. I did an all posterior construct. I'm waiting for her 6-month follow-up films to be able to go and show you guys. But I'll show it next year if Jens reminds me. But I'll show the thing where you can see her mandible, you can see her sternum. She couldn't swallow. And she basically came in, she was like croaking at me, kill me, kill me, kill me, because things were so bad. And that's what you can do to go and to change people's lives. So it is important, but it is not an easy thing.
Quick question. Sorry, my microphone keeps going out. Yeah, we're live again. So great insights. Abstract scenario, but we've seen it more and more. We all know of tandem disease and how difficult it is to sort out patients who come with two concurrent major disease areas, let's say lumbar and thoracic or cervical and thoracic spine. We've now had a couple of folks with triple concurrent disease. So briefly, in just abstract terms, sort out when and where and how to do what and what
sequence.
CT, L-spine.
Yes. Yeah. So many of these people will have neurologic symptoms, and that usually comes from the cervical spine. So I'm a big believer in fixing the cervical spine first, okay? You also want to make sure when you're going to be fusing somebody essentially from the occiput to the pelvis or seat to the pelvis, things like leg length discrepancy, other things, you need to know that and dial into it. So for me, I usually get the cervical done to try to go and treat the myelopathy. And then I usually will try to do the thoracic and lumbar as a second setting. And I'll leave my rods in the cervical spine, 2.5 centimeters long, so that I can go and put a connector and skip one level and then carry them down. But you saw there was ones where I did, and just in this thing where there's a couple thoracic, one thoracic and one lumbar pedicle traction osteotomy or 3-column osteotomy that I did for that exact reason, because of the concomitant diseases that go on. So I generally, if it's myelopathic, I do the cervical. Now, as Jens knows, and Jens taught me, for things like ankylosing spondylitis, because it's safer, most people will do, for example, a lumbar pedicle traction osteotomy to get them up first. And then they may talk about the neck because it's a lower risk. But if you're myelopathic, cervical first, and that's the nice thing about the planning softwares that different companies have, is you can check, and as you saw on one of the slides, I look to do what does an L3 pedicle traction osteotomy get? What does a thoracic VCR get? What does an upper thoracic VCR get? And that's, again, sort of the planning to do it. But the single most debilitating thing, and I'd be interested for everybody else, if you cannot see ahead, if you cannot interact with the world, that is what people complain about the most. And that's why, probably the biggest reason why I do a lot of these upper thoracic VCRs is to get their head up. If you do that, they are automatically happy, and then they can live with some of the other stuff. Nick, you do so much of this. What do you say?
Microphone. Here, bring your microphone.
You do a lot more than I do, but that, to your point, that it's just being able to interact with people when they're like that. And the other thing is that following in your footsteps, obviously T2 is the best level. I had, we did the T1s, we're having hand weakness and all the rest of the things that come up with it. It's disheartening to get somebody into a good alignment and then have them wake up with weak hands. I mean, that's just, it's a heartbreaker. So T2, I agree, is the way to go. I just guess, what percentage of those patients do you think, just out of curiosity, end up with a thoracic correction, which corrects their cervical problem in the big picture of things? Where do you think that just lies of all comers?
So it's a lower percentage, but the people that if you have a normal C2 slope, you're able to correct yourself and the cervical spine will unwind. If you have, and I've got even a longer version of this talk where I'm doing about occipital angles and whatnot, but there's some occipital, same thing, that if you're hyperextending, if you're at the maximum point of extension, this is word from Chris Ames, maximum point of extension, and you can't extend any further, that's also an enormous symptom driver. So what's happening is, to your point, if you have a normal C2 slope and a very high 1T1 slope, you can do the thoracic correction and you're likely to get correction elsewhere. If both of them are really high, then it's a combined deformity that Jens was alluding to, and you have to fix both of them. The question is, how many stages do you have to do to fix it?
Final question, we could spend a whole day on this, but given the mandate from Rudy and from Anthony to kind of look at motion preservation laminoplasty, it drives me nuts to see multi-level cervical spondylosis and then all sorts of complex constructs. Is laminoplasty underutilized, and if so, why?
Yeah, it's definitely underutilized, but again, it is an operation that is really technically demanding. So if you go and you just expose and you cut through the semispinalis cervicus insertion and you do this, it's not a good operation for a straight or even slightly kyphotic spine. Now, there is one, and I think there's a second company coming out with a lordotic cervical arthroplasty device. and I saw a recent presentation of relatively mild cervical kyphosis and myelopathy, where they treated it with, I think, 4 and 5 level cervical arthroplasty devices. And much like Rudy's work, I was like, wow, that is something that very well could be an improvement over what we're doing. So I do think as these technologies are improving, it's going to extend the range of what happens. But I'm going to be serious. When I got to Duke, the single most common cervical operation after a 1-level anterior cervical discectomy and fusion was a C2 to T2 fusion. And I don't like that operation, and so I do think that we can do things with better fixation and whatnot, to do something more limited in the mid-cervical spine, maybe even do things front back, maybe even do something that we saw with arthroplasty and some kind of a dynamic fixation. I think that, again, for those people say that everything known about the world, whatever the specialty, everything's known about spine surgery there is to know. I'm telling you, for you guys, you've got 20, 30, 50 years of stuff. That things are going to be so much better than what Jens and I and Nick have done through the years.
Outstanding, a great segue to the next lecture. Before you leave here, and Dr. Sandline, do you want to come up? And great segue to non-fusing the pediatric population, adolescent population. This is driving me nuts all day, Chris. So can you take your jacket off, please? This is an old custom in the masters, but the past masters give it up to the next master. So
I don't think I'm going to fit in your jacket.
I just want to give it a try. It's driven me nuts all day long.
Here we go.
Driven me nuts. Can somebody take a picture, please?
All right.
The new masters, and I think there's a customer. It's not all that bad. Come on. This is not all that bad. We have a real one coming for him. This is what resting on the shoulders of giants really looks like. Thank you, Chris.
Thank you, Jens. I appreciate it.
Corey will have one coming for him, right?
Yes.
Yeah.
Tailor suited.
54 XL is my size.
So do you heard the mandate? Do you want my jacket? Can I give you my jacket?
Oh, absolutely. I may have, I wonder where mine is. Do you want me to go run and go get it?
I'll stick it 54.
So you think you can do a
I could go
50,
change. It'll take me 2 minutes.
No,
Thank you.
We'll be good to go.
Again, another master.
Oh, that's right.
Fits a bit better.
A little bit better, yes.
Okay, so no further introductions. You've seen his mastery on many sessions before. Non-fusion for the thoracolumbar spine and adolescent deformity. Really hot button topic. And again, you heard the mandate. Tell us what's possible.
Yes, no, absolutely. First of all, just spectacular talks, the whole session. And already thinking back, whenever I come to courses like this throughout my career, I always think to myself, what can I take back into my practice? And I can tell you there's several topics that are coming to mind. So here are my disclosures. The most relevant one is I do receive royalties on the Tether product. I hope you find that I'm still fairly objective on its pluses and minuses, but let me know at the end. So listen, we all recognize that posterior spinal fusion is going to be the gold standard, right? You have a child that comes in with this kind of curvature, they can choose to have a posterior spinal fusion, reliable result, but loss of motion. But there may be a subset of patients who are going to choose to go down a different route, a growth modulation, vertebral body tethering route, where as they're growing, they're going to start getting correction. And what vertebral body tethering does is it truly just offers an option. It's not the first attempt in children in trying to modulate their spines. When I started at the Philadelphia Shriners, my mentor and good friend Randall Betts had done a big series with vertebral body staples. And as you know, what we're relying on here is the Hutter-Volkmann principle of compression, inhibiting growth, and allowing the concavity to catch up. And vertebral body staples at the time appeared to be working okay, but what we started seeing was that there was a fair number of patients that were going on to fusion. And quite honestly, what really opened my eyes was not only the ones that we were seeing at our hospital, it was when my colleagues, I remember Dan Ciccato calling, hey, Amir, you guys did a vertebral body stapling procedure done. Can you give me some tips? I'm going to have to fuse the kid. Where we said, why don't we step back? Let's objectively look at the data, because until you objectively look at the data, subjectively looking at your results can be very rosy-eyed. So I think that's probably a key message for everybody in this room, is you really want to see good objective data, because when we looked at it, it did not work. And the same thing has happened with vertebral body tethering. We have recognized that there's areas where it doesn't work. 10% reoperation rate, tether breakages, and there are other areas where the risk benefits may be in favor. This was the first child we did back in 2011. The mom had a vertebral fusion done and just was miserable. It was a long fusion, was having back pain, and really wanted to try something that was innovative, because at the time, there really wasn't an option. We had recognized that stapling was likely not going to work, and she was the first one that we actually did the procedure on. And the way we came to doing the procedure is we went to the SRS when it was in Kyoto, Japan, and started talking about looking for different options, and that's when we started coming up with vertebral body tethering. We did her, it was the first patient, she actually showed a little degree of overcorrection, and we cut her tether, and overall now she's 15 years out doing well. So from that point out, we said, okay, we're gonna start doing vertebral body tethering. But I recognized from our stapling experience, we needed to look at the data and look at it objectively, even though we recognize with any growth procedure in a pediatric patient, you're gonna need to see them when they're skeletally mature, and probably even afterwards, to really understand if it works or it doesn't work. After we did our first procedure, we actually waited 6 months before we did our second one. We put these poor kids in a brace for 6 months because we just weren't sure what was gonna happen. This is in 2011. So I get up on the podium, SRS 2015, look at our first 82 patients. I think we had about 28 that had attained skeletal maturity. We used the same criteria as the BRACE study, the NIH-funded study that looked at bracing. And what we found was, sure enough, these are smaller curves at the time. We don't operate on curves this size now, but reasonable correction both in the thoracic and lumbar spine. I was feeling pretty good afterwards, except November of that year, I get a phone call. I'm sitting in my office, and they're like, hey, Dr. Samdani, there's someone from the FDA, and they want to talk to you. And I'm like, oh, we're trying to get this study, and I got actually pretty excited, but then said to myself, wait a second, we don't really have a study going on. And they came up to my office, and it was the same guy who had actually put the Synthes reps who were selling Norion off-label and had put them in jail. I realized this afterwards. Let me tell you something. Frightening. So they come in, they go through all of our charts. We've done 100 patients for now, and if they had found a big complication, the whole field would have been in a very, very different spot for sure. In the end, they said, okay, don't write about it. So I stopped speaking about it. I didn't present on it for several years. Make sure that you consent the patients appropriately. There's no long-term data. And make sure that you don't publish anything. And listen, they were just protecting kids. They were not doing anything wrong, but it was probably the most frightening point of my career. And actually, I was thinking about, how I could relay that to everyone. And being in Seattle, I thought I would just try to replicate what happened here. And I'm telling you, that's exactly what it was. I thought we were winning, and then all of a sudden, it was over. And the reason why I thought I could show this is because we all recognize what happened this past year, right? You guys are champions. So I figured I could show that, recognizing that you actually already had a championship. But anyway, it was a pretty crazy time. So, but again, the FDA was truly just trying to protect kids. They worked with us and actually let us do an IDE study based off of retrospective data. We were able to go back and collect our first 57 patients published in JBJS and do a prospective analysis of those patients, and that's what got the IDE approved. And right now, tethering, it's got a very limited scope. It's not for everyone, but patients want options. I think Rudy did a great job talking a little bit earlier about if we're doing the same thing, if we're talking about the same thing 10, 15, 20 years from now, I mean, clearly we're not making progress. And now there's over 250 surgeons that have been trained, over 8,000 patients treated, and it's finding its niche. And I'll tell you where we've ended up with it. Our experience is pretty extensive. One of the first earliest sites, we've done over 800 patients. I've probably done over 400 myself at the hospital. And quite honestly, there's pluses when it works. It's spectacular, but there's times when it doesn't work. Reoperation rate, 20%. And here we're looking at a population that has a good gold standard. So we have to make sure we truly compare it to the gold standard to find out for which patient is it going to be ideal for. But the reoperation rates are primarily for overcorrection, because we were operating, as you saw, on those first 28 patients, it was curves that were 40 degrees. Now our average curves are closer to 50 degrees. So I do think we're going to do better on that side. We've seen the full spectrum of results. Some look spectacular, and some you just think to yourself and say, my goodness, what happened here, right? And you got to go back and do a fusion. How do we do this? Typically in the thoracic spine, we're able to do it through thoracoscopically 3 15-millimeter incisions centered evenly in the anterior axillary and the posterior axillary line with a couple of scope incisions in the front. This is what it looks like at the end, and here's just a short video just depicting how we're going to do this. And let's see, it looks like that's the feet are to your right, patients on the side, heads to the left. We go ahead and take the pleura, we're going to take the segmentals. I used to get asked a lot about whether that could cause neurological issues. We went early on, visited Professor Harms, who does a lot of anteriors. In an idiopathic, extremely uncommon, I have not seen it. Then we follow up placement of the thoracoscopically of staples. We're doing this all under fluoroscopic guidance. Mayo does do it using navigation. Eventually, I think there's going to be a big role, actually, as we move forward with advanced technologies. After the screws are in, we place the tether and then work our way down and then tighten and compress as we move down. And look at this. Wow, this patient looks pretty good here. And you can see they're back to dancing and they're doing everything. And look at this, boy, isn't that great? Well, if you're sitting in the audience, I know what Jens is thinking right now, come on, Amr, you're showing me one little patient here. What does the data show, right? We got to really understand what the data shows, because that's what's going to help us to decide where it works or where it doesn't. I can show a bunch of great cases, but until you look at it objectively, and quite honestly, not just even single center, you've got to look at it multi-center. And people who aren't vested in it, who don't have a financial incentive, that's when you're truly going to learn where it stands. And I actually do. I do get tether, I do get royalties on tether, so you got to make sure you get a really broad perspective on where it doesn't work, because there's going to be breakages. You're moving, you're going to have reoperations. You got to understand, how does it fare compared to the fusion? And of course, what's really the point of preserving motion, at least in the thoracic spine? Fortunately, we have a ton of literature on this. In the last few years, 450 patients. I'd say at SRS every year, this is one of the hottest topics and continues to be one of the hottest topics. And what we've found out is it's going to work well, and I'll talk a little more about this, in select patients, growth remaining, can't do really large curvatures, perhaps. Complications and reoperations have remained high. They have come down. We've got a couple of papers looking at our last 5 years compared to our first 5 years. It's probably going to be halved, but they're still going to be there and be more than PSF. And then how about motion? Overall, it does retain motion. So what are our indications? I'm not going to get into the big details here, but again, this is a growth modulation procedure, so it relies some extent of growth. We measure growth, you can measure it through age and look at parental height. We look at the hand, we really look at Sanders, and Sanders 3A on the hand is ideal for thoracic. Lumbar is gonna be more. It's gotta be a curvature that has some degree of flexibility. You're not gonna fix a 100-degree curve with a rope, right? You can go back in a couple of times, it's not gonna work. So you gotta make sure you select those patients appropriately. So looking at the literature, so what has the motion literature shown us? 65 papers on VBT and motion. Clearly a very important topic in this space. This is out of the Mayo Clinic, their initial paper published in 2021, showing that at least in the sagittal arc, you're able to maintain 21 degrees of motion compared to 30 degrees being normal. They did a follow-up paper, again, looking radiographically at motion, at what motion was doing. And here now they had 103 patients, 2.8 years of follow-up. Please remember, in a growing spine, that's probably not going to be enough. It doesn't mean we're not going to publish it, because we have to understand where we're headed with this, but you're really going to want to see 5 years and then several years after skeletal maturity to truly understand whether it works or not. They did see a decrease in thoracic range of motion and lumbar range of motion, but they did, again, retain sagittal motion here. So what we've been doing, my partner Josh Pays and our entire group, we've run all of our patients, fusion or tether, through a motion analysis laboratory with multiple markers on. And if you take a look at fusion or tether versus T12, I want to be honest with you, I even forget which patient is which. But as you move further further down into the spine, it becomes a lot clearer. So from our perspective, what we've seen is that it's really the lumbar spine that we want to try to save motion, is where that perhaps the risk benefit, and it's subjectively defined right now, we can do a shared medical decision-making model, which we've worked with Mayo and others on, but in the end, it's still a bit subjective on which choice the patient is going to make. Here's our paper that we had, that we did publish in JBJS, and not surprisingly, it's when you get down into the lower lumbar spine, that's where the motion differences are going to be greatest. Of course, the secondary effect is going to be downstream degeneration, but that's going to be further down the road, and likely most significant if you're going down to L4. So although between 2011 and 2015, most of our tethers were in the thoracic spine, what this started having us do is we started to say to ourselves, what's really the difference between that operation versus this operation? And where we've landed after seeing this happen a few times, right, where you get a tether, the result looks okay, they end up getting a breakage, the curve comes back, and now you're left with a fusion, is I really am not a big fan of thoracic tethers at this point. I think if you have a patient that's got a thoracic curvature, this is the operation, the right operation for the vast majority of patients. Now, there may be some that are dancers or gymnasts. That's where the thoracic motion may play a role. So at least in our practice, we generally tend to offer this operation where you can get three-dimensional correction in the thoracic spine. It doesn't mean I don't like thoracic tethers. Please understand, thoracic curves come in a lot of different varieties. If I asked Mo or Connor or Mike, how low you would fuse on this patient, you'd probably have to go down to the CSVL, so you're in the lumbar spine. So those patients that have a big overhang curvature, I do think vertebral body tethering can work as long as there's enough growth left. And here's just an example of one such patient. So whereas in the thoracic spine, we've moved away from it, in the lumbar spine, my goal, and I love to hear when Rudy was talking about refuse to fuse, because my goal, my hope is we can minimize the number of fusions for pediatric patients as we move forward. And we have been pushing the limits on this, as I'm going to show you through some literature we've done and some patients as well. Our current approach right now, thoracic, as I stated earlier, perhaps for select patients with overhang curves that you would be fusing into the lumbar spine. In the lumbar spine, exact opposite. I think to myself, do I really need to fuse this patient? Maybe the curve is really large and stiff, the patient's older. Those are the ones that I'm still fusing, but I'm really trying to save that motion. And this whole idea of hybrid surgery, and by hybrid here, I mean generally, although I've started doing some hybrids as well. On the other side is, what I really mean is, if you've got a double major curvature, doing a thoracic fusion where motion doesn't matter as much, and doing a lumbar tether, that's where we really have started pushing this. So here's just a very established, if you asked 10 pediatric spine surgeons, I think several of them would certainly consider this to be a good indication. Lumbar spine, not a very large curvature, it's flexible, and most importantly, the patient has growth remaining. Sanders 3A, that's what she gets, and shows some correction over time. But again, that's a single case. What do we see when we look at our data across our series? This was a paper that our fellow Alan Stein published a couple of years ago. We had, out of 551 patients at the time, 106 that had a tether down to L3 or L4. We looked at the data, and what we found was now the Cobb angles were higher. 50 degrees preoperatively, latest lumbar was about 20 degrees. Of course, there's a range there, so about 80% of patients at skeletal maturity ended up less than 30 degrees. But look, I mean, reoperation's still high, 18%, right? Mostly for overcorrection. Now we're starting to push the limits here. Here's a 14-year-old girl. She has a spondy at L5S1, so I really did not want to fuse her. She's got a trunk shift over to the left. And the main reason why we're pushing the limits here is she's a Sanders 6. So she undergoes a vertebral body tether, ends up having a little break, as you can see, so still has a curvature in the 20s, but I would argue it's probably better than having that spine fused, especially with the spondy down below. Now, this patient really started opening my eyes that although we've learned a lot over the last 15 years, there's so much more for us to learn. So if you take a look, not a big curvature, but look at that child's body, right? The trunk is she hates this. It's hanging way over to the side, hip is sticking out. And, long-term, this is likely continue to progress. She was pretty much done growing. She was about 15 years of age, done growing. decided, for better or for worse, to do vertebral body tethering back in 2021. And look at what happens here. Again, just showing us that how much we still need to learn about growth, because what she ends up doing, there's a slight degree of overcorrection that occurs proximally. So even though she was skeletally mature, she shows some degree of overcorrection. So clearly, the body can still modulate even if growth is done. So as we understand vertebral body tethering better, we're going to start pushing into the more mature patients. One thing that we're not going to do is the Sanders 46 patient, okay? This was a recent article that was published, and I think, Baron got it into in JBJS Case Connect. It was a 46-year-old. I do not believe in this. It is a good result 6 years out. If you're using it for growth modulation, it just doesn't make sense to me, but it is a good result. He got it into JBJS, but Sanders 46, that's where I definitely draw the limit. So how about different curve patterns? So we spoke about the thoracic curvature. This is the right operation. Lumbar curvature, I strongly believe whenever possible to do this operation. What about the double major curvature? That's where the hybrid comes in, and we've made a big push on this. We've done about 100 patients now. We've got a presentation coming up at SRS. We recently published actually a very early series of our first 20 patients. The key thing to look here, if you look at the Lenke types, these are primary lumbar curves. Because I often get asked is, hey, Amir, if you could do a selective thoracic fusion, why wouldn't you just do it? No, because these are primary Lenke 6s and 5s that have big thoracic, 4s that have big thoracic curvatures, and 3s. So that's the key thing. This is if your starting point is you're going to fuse into the lumbar spine. Now, it doesn't mean we don't have 1Cs in there. Of course we do, but those generally tend to be larger curvatures. And if you take a look here, these are large curves. Now the average Cobb angles are approaching 70 degrees in this. So this is where the indications are expanding. Again, trying to get to that holy grail of trying to avoid fusion or minimize fusion in adolescence. We're pushing the limits on these patients. When we look, so that was our early series. When we look at our series overall, actually closer to 100 patients now, majority of them for structural lumbar curves. There have not been any lumbar fusions in that cohort. There's going to be some, right? Anytime someone says, I've had 0, I mean, it's really hard. There's something's going to pop up, right? And I totally understand that. We do have to do tether releases for sure. I think what happens is the thoracic 3-dimensional correction, you got to do your best to try to pull that kyphosis out, is going to be protective for the lumbar spine. And look at this. This is a pretty big curve, but the child ends up overcorrecting. But fortunately, overcorrection now for us is not as complicated. Now they're usually just in for a day or two. You've got the patient's feet to the top of the screen, the head's to the left. They've overcorrected between T11, T12, and we're gonna go in and basically through those 5-millimeter portals, go in, take our harmonic, cut the tethers, and then once we cut the tether, we're gonna make sure that the tether and the scar is loose by putting an instrument on top and making sure that it's free. So what about this patient? I may ask for some audience participation on this one. You got a 15-year-old Risser 5, Lenke 3C. Anybody want to help me as to how we're going to treat this child?
I'll start with Dr. Theodore. You're coming to you.
I'm sending this to Dr. Samdani.
Yeah,
She wants to stay West Coast, sorry.
Skaggs? Yeah, not in my.
Okay, Chris, it's up to you.
Yeah, considering I've never done a tether, I would do a fusion probably down to L3, and that's going to get a consistently good result. If you can stop at L3, the literature shows the back pain is not substantially higher than what it is with the normal population.
Yeah.
But I think that it's all, while you're showing this case, it's kind of all on the borderline of different things. But in my hands, this would be a fusion, but I think that you could make a case to do a hybrid here. You know, it didn't say what the Sanders wrist.
Mature.
Oh, then.
Sure, yeah, Risser 5.
I'm going to go to L3.
Okay, good. And the main reason why I put this up is exactly for that point is just because you've got a hammer doesn't mean you need to use it. Here, we actually ended up doing a shorter fusion as well because you don't need it. Because if you go back and you take a look, it's a 3C, but it's barely a 3C. It's a 31, so Chris is absolutely right. I mean, either go to L3 or fuse short on this. You do not need the tether in the lumbar spine. But contrast that with this patient. Now, this patient has a primary lumbar curve. It's hard to imagine how you're going to be able to stop this one short, right? Because the lumbar is bigger than the thoracic. There's more rotation here in this child, and this child ends up getting the hybrid procedure. And that, I think, this child is a much, much better candidate than the child that I previously showed. Now, with vertebral body tethering, we're able to push the limits as well. So now this is a child, and again, I don't know what the right answer for this child is, right? Big curvature, 85 degrees, clearly does not meet any indication for vertebral body tethering. Local family, actually, very, very athletic child. She plays basketball, she's soccer. They are the right family who want to, try an alternative. 5 years ago, this is the operation, right, that we give this family, and you're not wrong for this. I'd say this operation works well, and in all likelihood, if you're able to get three-dimensional correction, will uphold for the long term. For this particular child, we ended up doing this here, which I told them that I was gonna likely bring her back. I already went over to the other side. I was unhappy at 12 months, right? I mean, that's too big of a curve in the lumbar spine. Tried to do a thoracic fusion. I brought her back and went ahead and retensioned this. She still has a curve in her lumbar spine, and only time will tell, which operation ends up being the better. I am clearly biased towards trying to save lumbar motion, but you have to make sure we understand what are gonna happen to the discs down the road, how is that spine gonna hold up over time. But I can tell you one thing, I do know what's gonna happen to the discs when I fuse them down below, right? That's really my thought process, is as we try to push these limits. What is our current practice for doing lumbar tether? I'll spend the next 5 minutes on this or so. Generally, our level selection is proximal to the end vertebrae. We go from the proximal, we go to the end vertebrae, and distally we go to the CSVL. I have been adding a second row of screws on this, tensioning posterior row first and then the anterior. Usually, you can obviously do this through a thoracotomy. We actually do this through a thoracoscopic approach down from T10 down to L1 typically, and then do a mini open retroperitoneal approach, L2 to L4, and make that incision a little bit more vertical to be able to pull the psoas anterior to posterior. This is what the posterior screws look like. The anterior screws, these are HA-coated screws. The screw pullout's not an issue. That's why those anterior screws are short. They're HA-coated. They're primarily there to add that second tether, perhaps to give us more time prior to breakage. One thing I have learned, we get an O-arm spinner and everybody, boy, there can be that canal can be fairly concave. So we're trying to place these screws in the posterior half of the body so we don't iatrogenically induce kyphosis, but once in a while you'll see a pretty concave canal, so just be cognizant of that as you move forward. And this is what it looks like intraoperatively. We retension the posterior row and then really just take tension out or slack out of the anterior row. And I have not seen iatrogenic kyphosis. It's something that Tom Errico and others throughout the years have been asking me, even in 3D. I think because in 3D, the anterior spine is so overgrown that you just don't get kyphosis. And that's exactly the reason why I don't think it's a good operation for most thoracic AIS, because you're not going to be able to recreate that kyphosis. It works both ways. I really think it's best suited actually in the lumbar spine. And I do double row, obviously. It gives more reliable postoperative correction, perhaps less tether breakages. The impact on motion though, right? Before we jumped in, we wanted to make sure we understood that. There have been cadaveric studies that have looked at motion in the cadaver, very different than what we see obviously in a young child. Maybe there's some restriction in flexion and lateral bending. Josh Pays led this study. We presented it last year where we did not see any motion difference between double row versus single row. So that is our common practice right now, because it does help us to decrease variability in our patients as they stand up. But like I stated earlier, tether breakages can occur. This is a paper out of New York where they did show a 13% breakage rate, even with 2 tethers. That's not been our experience so far, but we've got more follow-up that we're going to have to do. And the last thing I want to show is that perhaps, tethering would be most useful in a patient like this. This was a little boy. He was about this big and 8 years old, got a big curve. We know that the alternative for this is going to be some sort of growing system, which is going to lock him in to to multiple surgeries in all likelihood, overcorrection, autofusion. So we've started gently wading into this area here. So that's what we did for this child. I did do some disc releases, which is not what I typically do, but basically an apical fusion. Very unhappy with where this child was at the time, but I knew the child had growth. And sure enough, over time started showing some correction. Yes, the shoulder is up and there's some kyphosis, but overall probably better than a growing system. So in summary, I think that VBT in 2026, limited role in thoracic spine, but boy, in the lumbar spine, I feel very strongly of trying to push the limits with double rows, with the hybrid technique to try to minimize the number of lumbar fusions that we're doing. Thank you.
Amir, that was a fabulous, fabulous talk. I was going to ask for, so much of many of the kids that are coming to see you have got real cosmetic issues.
Yes.
And how does that factor in your decision-making? Because I've had people come to me for a second opinion, particularly where someone's done, I thought appropriately, a limited thoracic fusion, and they're, yes.
Yeah.
How do you factor that into your decision-making?
It's a great, great point. I'd say in the thoracic spine, because I generally am trying to talk them out of doing vertebral body tethering, if that's even mentioned, which I think is important for them, I tell them it's not the right operation for you. In the lumbar spine, where you can still have some residual correction, but what I find is the tether, you get enough correction because they're usually flexible enough that you're able to get that trunk shift corrected. So in the lumbar spine, I find that you can still get an acceptable cosmetic result, and that's what our studies show based off of the self-image score, but it is something to think about. I mean, if you're looking for a reliable way to get as good a cosmetic result as possible, this is probably not the right operation.
A second what Chris said, this was absolutely fabulous, and just like Rudy and all the other lectures, this visionary again, it shows your passion also.
Yeah.
It shows how sometimes passion is questioned by others, and you withstood the questioning very well. When do patients notice that these tethers, or do they notice that these tethers break? You obviously showed a radiographic progression, but are there other telltale signs like more pain or a loud sensation, something like that?
No, it's a good question. Majority of patients, I'd say, we just see it on a follow-up X-ray. I had a lacrosse player that was playing he's like, man, I heard something snap when we saw an X-ray, but that's in the minority. Many tethers are going to show at some point a breakage. If they have modulated by then, there's going to be minimal loss of correction. When we looked at our study, a tether breakage usually translates into somewhere between 3 to 6 degree loss of correction. So the majority of them are going to be clinically silent, but there are some. I mean, I did show you in the thoracic spine, the ones that needed fusion that are going to be clinically relevant, but I find that if you select the patient correctly, even if it breaks, it's likely not to cause a significant clinical appearance issue.
Very, very good. So would you let a patient who's had a thoracolumbar, sorry, let me ask this first. Thoracolumbar junction, threading these devices through the diaphragm.
Yeah.
Possible, not possible, easy?
Yeah, no, good point. So what we do is we actually make a small hole right at the junction of the diaphragm with the vertebral body, right up against the vertebral body. We put a little right angle clamp. We got the tether up in the thoracic spine, and we're able to pull it into the retroperitoneal space. I have not seen an issue with that. I did see one diaphragmatic hernia. This happened probably about 8 or 9 years ago, where we were trying to get down to L2, trying to do a more aggressive exposure thoracoscopically, and took off more of the diaphragm and did not reapproximate it. So since then, we've been reapproximating and not seen any issues.
And final question for me, unless somebody else has some questions. Reinserting a broken tether, possible, not possible? How difficult is that?
Yeah, so typically if a tether, it's definitely possible. There can be scarring for sure. Because it's a limited tether release that I showed you, those are a lot easier. If you're truly gonna go back and you feel the child still has enough growth left and you want to replace it, it is definitely a more challenging procedure, and you're gonna need one of your better general surgeons to give you a hand on that.
I said this is my last question, but it's not quite the case. So final question again is, how fast do these kids go back to activities that are unrestricted?
Great
Right away,
question.
you made an indirect reference to that, but I just wanted to hear that.
Yeah. So, when we started, we would shut these kids down for 6 months because we had no idea. We're like, are they going to pull out? Are they going to break? Then we went to 3 months, and now we're down to 1 month. Basically, once the incisions heal, go back. And I did have that one lacrosse player, big, strong guy, twisting motion, and it snapped. But other than that, I've not seen early breakages.
Reinstrumentation after these loud screws, I've done that before. Nick, Chris, and obviously yourself, I'll start with you. How do we get posterior hardware in there when we have these anterior retention screws in there?
Excellent point. So we published a paper on this a couple of years ago. It was on our, I can't remember, one of the guys may have done it in here. Connor, maybe, I can know. And it was on probably our first 25 patients that we had an instrument. The implant density was the same. It took a little bit longer, and there was more fluoro that was required, but the corrections were also very similar. So the vertebral bodies are large enough generally.
Clinical experience, Nick, have you used a robot? I'll get you a microphone.
Yeah.
1 second.
The answer is yes. I mean, the nice thing about utilizing, and I think the only problem I talked about earlier, which I think the savior is going to be converting MR to CT. Not going to be able to do that with hardware. That's the one drawback.
Right.
But utilizing, imaging where you can actually plan those around those screws makes all the difference in the world.
Chris, clinical experience, is it share?
Yeah, you can usually sneak a screw around, and every once in a while you may have to use a short screw
Exactly right.
to be able to go do that. Where the trouble comes is that for some of the older anterior instrumentation systems like the Canada device or whatnot, sometimes if you have to do something like a VCR at the apex, then you do have to go back in retroperitoneally and take that out. But with just a tether or just a single screw, you can usually sneak another screw around it. I'm actually having more trouble because there was a huge wave of people who had SI joint fusions done for back pain with degenerative scoliosis. And they put 3 or 4 devices across the SI joint and tried to sneak an iliac screw or an S2A or iliac screw through that is more of a challenge.
Could not agree more. I mean, that's fantastic. Thank you.
Thank you. And I'll go change. I'll get my jacket. Thank you.
Really, really good. So this is the final program now. We'll have our final lab presented by Dr. Bertagnoli using a Sentinel Protoscal device. And we'll ask the next generation surgeons, represented by 4 of our wonderful fellows, to come up here one after the other and ask our 4 legends in spine surgery to present some of their cases. They're all 4 different. And yes, all 4 surgeons will be tasked to provide their input. So nobody go away because we have our grand finale with 4 surprise cases. And there are no curveballs in there, but truly the expertise of our legends will be necessary. Rudy, are you live? Can we hear you? Can we see you?
Yeah, we can hear you.
Are you going to show us some tethering cases there, or what's happening now that you saw some tethering in the front of the spine?
Can you make it a little bit louder, more volume?
Okay, we got to get Chris here. He has the best voice. Can you hear us and see us?
Yeah, I can hear you, but we make it a little bit more volume.
Okay, more volume.
Yeah, okay, perfect.
All right. So we saw a great lecture on tethering. I think you would have enjoyed that. That's right up your alley. Introduce your team to us. Who's with you there?
Yeah, so actually what we are doing here, we'll do the approach to show you the approach.
Normally, hang on 1 second. So to the right is Amster Khan, so Hagai. And then who's next to you on the left, Rudy?
This is Josh.
Okay. Hagai.
Hagai.
Okay, Rudy, carry on, and we'll take the overhead camera.
Good. So normally what we do is when you position the patient, you have to make sure that it's in autograde position, so that you tilt the patient like that using a fluoroscope, that you have a perfect perpendicular position in the AP. Then you check the lateral X-ray and you create something. Maybe you can put the camera down here. Put the camera here. Oh yeah. Okay, this is what I call the trajectory line, the entry line. So we are marking the lower. Can you turn it around because it's upside down? You can change. Okay, this is S1, following the S1 plate. This is following the L5 plate. And depending on the angulation, you have a more smaller or a wider area. So when we need 11 degrees, it's approximately this width. When we have 6 degrees, I know this already in advance. So then this is the midline. Here's the umbilicus. And now we take a approximately knife, a 10 centimeter incision here and what we call on the corridor line. Okay. And we do the L5S1. I'm doing all the time from a what we call a bikini incision, and we're going okay, and now we are going in the longitudinal direction. So here is already the fascial layer. So you mobilize more to the cranial side. And we are doing what we call a strategic approach. L5S1, we go from the right side. Our strategy is keep the left side as long virgin as you can. Because if you have to go back to L4, L5, for instance, then we can go in from the left side. This is the right side here. In the future, if you have to come back to L5S1, we split the rectus sheath in the longitudinal direction. Okay, here's the rectus sheath. Oh, you have a Mikulicz. Do you have a Mikulicz clamp?
See? You want a clamp to hold it?
Yeah. No, keep this, please. So here's the midline. Here's the rectus muscle. I go in here, I separate the rectus, if you can see here. Then I take this shorter hook, this one, but shorter version.
Here, yeah.
We go in here. Here's the peritoneum. Hold this, hold this, please. So, and then I find the retroperitoneal space. Okay. Give me a 100.
No retroperitoneal scarring, Rudy?
Excuse me, we are already almost in the spine. Give me the 80, please. I'm already touching the promontorium. I'll show you in a few seconds. This direction. Need more light, don't see anything here.
You can make the skin incision bigger, Rudy. This patient won't complain about the cosmesis.
Close it, close it. So we're using the SIM frame here. Need more light. We don't have headlights, unfortunately. It makes it a little bit more difficult. The other side. Okay. Okay. Hold it. Do you close it all the time? Okay, and you close it up here, the screwdriver, close it. Okay, good. So the patient had a epsilon prosthesis, a vascular epsilon prosthesis. Okay, we're seeing the promotorium already. And we go now from the, give me the screwdriver again, here, open this. Going now from the right side to the left side, open. That has a big advantage because you also have the superior hypogastric plexus is more on the, located more on the left side. Okay. Give me the 100. 100, yes. I go. Okay. So I'll show you a few seconds. Open that. Close it. Okay. Open that. Okay, close. Hold it like that. Give me some electricity, please. Here.
OV.
So this is the median sacral vessel. Does not work here. It's not working.
There won't be bleeding.
That's 60.
Okay. So what we're doing now, I'm a fan from the Homan. Give me the Homan, the first one.
This one or
So we're using this.
you want this one more? Slightly
No,
more
it's good. Give him more light. Mallet. And more light, please. This way.
Rudy, can I ask you a question?
Yeah, we are already at the L5 vertebra.
Okay. Can we put
Okay,
that lap
so
sponge
we
out of the
fix
way?
that.
The lap, can you take
Give
the
an
lap?
empty one, empty. But you can already remove this and make it empty because we need 4 of them. So fix it. So, because we want really to have a steady approach.
Can we put the lap sponge out of the way? Rudy, can we take that lap sponge out of the way? Yes, thank you.
Okay. You see already here is the disc.
Beautiful.
So now we go, this was the first hook in L5. Now I can pull over, give me the next one. This comes in S1. Take away this one. But I'll take away this one. Okay. Wallet. So I put, okay, give me an empty one. Yeah. Put it here. Okay, no, yeah. Okay, fix it. So in a few seconds you see the rest. Give me the 80, please. 80. This gives you a very steady approach. And I've seen many approach searches that using Langenbecks. I don't like the Langenbeck because when you start to put in the disk, it can happen that would hold the first gear, please. That you so, okay. Okay. Next woman. A little bit difficult because we don't see anything too much because the light is here suboptimal. We don't have a headlamp. Take your fingers. Oh, okay. Take it away. Take it out. Take it out. Okay. Put it in. Close it. So we're almost there. Let's get under. Okay, final woman. No, we don't need to. Yeah, okay.
Wow.
Mallet.
I actually started in 30 years ago, probably more.
So, okay.
Hit the external, damage the vessel. Wow.
Okay, so we're already there. I'll show you shortly. I should open this one. Okay.
Wow, beautiful.
Open that one.
This one?
Yeah. Okay. Good. So you see our disk. This is actually our disk space. Okay. Can you put the camera a little bit this way so that it comes more this way because it stays straight? Can, yeah, that way. Can you tilt it? No.
He can move.
Oh yeah. Okay. Perfect. Perfect. So what we do now is we open the disk space. Now we see some osteophytes here. Knife. Hold this. And what I do, I create a flap, an annular flap. A lot of people are not doing that, but this gives us an immediate possibility to have a tissue that's dedicated to do that. So we have some osteophytes here. So we have some osteophytes. We take a chisel. Where's the chisel? Here, not, yes. And we opening the osteophyte here. Okay. Knife. Keep the knife in place. We need now the sutures. So we open now the flap. Forceps. Pick up.
Pick up.
Pick up, thank you. So this is now a flap. The flap has two reasons. Number one, I have a soft tissue available, long handle, not the small needle holder. It's the longest we have?
Yeah.
Okay.
Unless we can use one of these.
Yeah. So, and it's a natural protection to the left iliac communis vein. So, here, give me a mosquito. Bring it under. Okay. Other way around. No, other way around.
Sorry. Yeah.
So, when you have two circles, you have to make the next circle like that and not following the circle, okay? So now we go for the second one, knife, please. Thank you. This is now the left side. So we go, it's very important that you go all the way to the lateral side because we want to put in the largest possible prosthesis. We see a lot of times surgeons are afraid to do that and they put in the too small prosthesis. Hold it. Put it under. Yeah, yeah. Okay. Yes. Okay, can you see that? Now, knife. Now we start the discectomy. It's very important that you have sharp borders here. Really make sure that you do take out away all the disc material, including the cartilaginous end plate. We have an instrument that we call end plate curette. We go here. And we start already to mobilize the disc space by taking away all the soft tissue. And having the advantage of an anterior discectomy, you have a very good view what your end plate is doing, and that you can take away all the soft tissue. Okay. With the small, do we have a small one as well? A small one like this? Okay, so we're taking out the disc.
Only the round.
I'll give this. Take it. So we try to be very accurate. You see here the cartilaginous end plate. Very nice, these bleeding spots here, see that? Okay. This is what is important that you remove. Give me the end plate carrot once more. Okay, this is what you have to remove here. And the good thing is with the Pro Disc, you assemble the disc inside the disc space, so that has a big advantage in comparison to the en-bloc insertion, because you can bring the disc all the way back, even in a more collapsed space. Now give me the box correct, this and the spoons. Important is that you go to the lateral corners, because here are the strong tethers. And sometimes if you have a very collapsed disc, you have to make sure that you do a posterior release. So I take this away. This you have to, this is not this loose again here. So open. I make it like this. Take a, and you go in. Okay, good. Now I mobilize. We have two forceps, like you see here. These are the spreaders. Okay, I go in first with the left side. Then I have stabilized it. Now I can do a better job removing the soft tissue on my side. Now it's the right side. Okay. See here? Pituitary runs here. Pituitary.
Pituitary on the back table.
Yes. The smaller one. So we're almost done on this side. Pituitary.
Rudy, can you hear me?
Yeah.
So do you try to get through the entire posterior annulus? Do you also try to go through posterior longitudinal ligament?
Yeah, we get all the way down. The annular flaps are still intact, because this is a good, relatively good distraction possible. The other spreader, please.
We have it here.
The second spreader. Now I go in with my second spreader and put in a better light. Okay. I stabilize the disc on my side. Okay.
Wow.
So that's very important. If you don't take the tether away, you cannot open the posterior space, okay? So, give me the spoon curette. Okay, here.
Would it be possible for our lab colleagues to get one of those fiber optic lights down to this base? We have these little fiber optic lights, or is that too difficult right now?
Peter, Ronjur. Do you need an adjustment? Yeah, we need some more better light. Do we have an endoscopic light? So. Yeah.
Rudy,
Okay, so
do
we
you
get the
operate with
endoscope
loops?
light.
No worries.
Yeah.
Rudy, do you operate with loops?
Excuse me?
Do you operate with loops?
Do you operate with loops on?
Yes. And with a headlamp, because this makes the life much easier. Here we see a little bit working in the shadow.
Hagai, can you ask whether we have a fiber optic light there?
So,
or is
but,
it-
so this
we're
is
setting it
important.
up. We're setting it up.
This is important. You see, this is the posterior part that was attaching to the PLL, okay? This is the posterior annulus, okay? So some people leave that and then they push it. So, okay? You see that? You see, this is
Nice. Now we can see it. Very
Now
nice.
this is the PLL, and here you see the center. A lot of times you have a kind of rupture in the center that's causing a lot of inflammation and pain, okay? So this is what you have really to take away. Otherwise, your pain source is not gone. And hold this. Now I go back to the other side. So you see, the two, if the forceps is together, we have 6 millimeters. Now I have an easy 10 millimeter because we go all the time with the smaller height. The trick is not like with cages. We all the time get the small height and the large footprint, okay? So we are ready to implant the disc now. So what we do next, we mark the midline, okay? So, can you see? Okay. So we try our best to give you some light.
Okay, it's getting better. Thank you.
And
so how are you going to mark the midline now? X-rays, or what are you going to do?
Excuse me?
How are you going to mark the midline? Are you bringing a C-arm in?
What is this thing?
How are you going to mark midline?
The mark midline, yeah. Okay, we go in and we have a sharp chisel here. With this, we're going, I assume it's somewhere here. And this I can align very well in the X-ray, okay? Give me an AP.
Come on in, come.
So I will show you. I all the time take the foot pedal because you can much better handle and synchronize your movements with your arm. So, okay, mallet. So, and now if you look in the X-ray, okay, and perfectly aligned, okay?
Got it.
Show him the X-ray. Okay. Okay. And now out of my experience, it's a 6 millimeter. Take a screwdriver. but we will see. Maybe we can put in an L. Give me also an L prosthesis. Get this shit out. So give me also this. So I go in now. Mallet. Go a little bit up. So now we handle it. You see? Okay, can you see the X-ray?
Yes.
So I leave the handle on because now I can easily see the midline, and I take a marker like my chisel or this tool, and I try to bring it in, okay?
That's a nice.
Really well positioned. We have a little tilt that I will correct, okay? You have to be meticulous here. It's not that you can cheat. Okay, now we are in a good position in the midline. And now we go lateral. Give me already a double chisel. Give me the mallet. So I whack. Open whack. Okay, close it. So I start already with the chiseling. Yes. No, this was good. One, big whack. And go more to heads, towards, yeah. More, big whack. Okay, that's an M, it's not bad. Okay, close everything. Under fluoro control, I try now to get the disc done. So now you see what I see is that this angle is not the right one, get 11, because now what you see here, that I can toggle, okay? Can you see that?
Yes.
Okay, so this, therefore, I switch now to the number 11 degree. So I take this out. Please take this. No. Okay. You see, that's much better now. Give me the L. Give me the L, please, the lumbar L. So because I'm pretty much here. And now you see we have here, can you see now? Yeah, we have here, give me an angled hook to show you why I switch now to the next level. Give me this angled hook versus angled nerve hook. So you see here, I have more or less 3-4 millimeters here. You see that?
Yes.
So, and I want to be flush with the end plate, so I take the 11 degree out and I go to the large prosthesis, okay? Okay. So, and you see, this is the right on whack that we will use, okay? You see that? Fix it?
Yes.
Take away this one. Okay. So now we go in once more with our chisel, and you prepare 8 degrees on the lower end. And so now we go back with the double chisel. We already have a cut, so the chisel finds its own way. I cephalize here a little bit to go in because the upper cut is normally more shallow than the lower cut. For this reason, we have a single chisel. Can you see that?
Yeah.
So, because this is 3 millimeters longer than the normal, because then I will cut more in the upper. My upper cut will be a little bit deeper, okay? Good. So now we are done. And now, the good thing is it's like a railway. We have created the pathway. The disc cannot move in any other direction than the direction I want to put in. So we go in now, and you see the nice thing is with the collapsed position, not our block position. Here, there's,
Can go in
yeah.
to see.
Then, because if you have an our block position, you will be trapped now on the upper end plate. But because I put it in like a shoehorn now, it's working. I put in the polyethylene now, and because everything is in this special application distraction tool, it will open now the space, bring it all the way down. Okay. Okay, you see, it's very important that we see in the back side a gap. That means I have done a good release. And now I put the polyethylene in with my pusher, and I finished. You see, much faster than any cage and more precise because no bone blood, no bone graft, no screws. So, and now I remove this, and my disc is finished. You see, here's the polyethylene.
Can we see the overhead view?
Can you go the up view and you try to keep this in place, please? Okay. Can you see this?
Very nice.
This is the polyethylene. No gap, no step. It's snapped in. And here, the disc is ready to install. Now I can do some fine tuning. When you, this is sometimes the problem, wig-wag. Because if people keep it like that, okay, so now I have a special tool I can put on the top, and I can push the upper end plate.
See, we see the lateral, yeah.
A little bit further back, okay? So it's all the way down. I go with the lower end plate a little bit, okay. Perfect application. So
Rudy, how far away from the posterior vertebral body wall do you want to be with the proto scale?
It's very important that you go to the very posterior border, because we give the nerve hook. I show you here. So you see, if we go in now, okay, you see here's the bone, okay?
Yes.
And if you go up, your bone is here, okay?
Beautiful.
So the disc is applied. Now we go for an AP to finish up.
Do you repair the anterior annulus?
Yeah, we are refixing the annulus. But first of all, we check the AP. Okay. Good. Give me more tilt.
Oh, beautiful.
Okay. Okay, good. Okay, that's good. So you see, it's perfectly placed in the midline. And you can turn it around that straight, or this flat, more straight. Yes. Okay.
Very nice. Any questions, comments?
That's how they turn out. I was just commenting, Rudy, that's how they turn out so well. That's just an absolute beautiful placement.
Thank you. So now we are refixing needle holder. Pick up the annulus, flap. And normally what we also do, we add artificial dura as a protection sheet between the disc and the vessels. That's important because if you have to go back, you have a protective shield and you easily can access, like you open a book cover when you do that.
And again, why do you do that? I have honestly not done that. I've not seen any problems, but obviously you're the artist, you're the original macher. Why do you do that? Why do you?
Yeah, because if they have to go back, it's all the time. Can you make it more? It's the focus and yeah. Okay. So see, because here is the critical corner.
Yeah.
It's the left iliac communis vein, and if I put a shield on, I'll show you what I do normally. Give me this. Do you have an open one?
You want like just
No, like the metal, okay? So normally what I do, give me scissors, like straight scissors. I put a shield here. This is what I do with, B. Brown has this artificial dura. So, or in the past with Gore-Tex membranes, I put it here. You see? Can you see that? Okay, I fix it with 4 small 4/0 sutures, non-resorbable, and then the vessel comes on the top of this, and in the future, when I have to go back, I look for the right side, and I open it like a book, and I have all the vessels are on top of this shield, okay? Because some people, if you look in the literature, they're afraid of the redo surgery because they are not using this shield, okay?
Got it. That's really good. Rudy, you do all your own exposures, right?
Excuse me?
You do all your own exposures?
Yes.
How do you preserve the renal artery when you go to L1-2 or L2-3, which in our country is off-label?
What is?
How do you preserve or protect the renal arteries when you go to
the
L2-3,
renal artery?
L1-2 and L2-3? What do you do?
I put everything I block aside. I put the whole. So we take the implant out. Okay. Now we leave it like that, and now we close, and we are finished. So
thank you. That was beautiful. Thank you. So come and join us. Join us here for the final presentations. So I'll invite our 4 legends to come up to the hot seats. These are especially warmable seats. Dr. Samdani, you choose the seats. Dr. Theodore, Dr. Shaffrey, and Dr. Dr. Theodore will join us, and Dr. Bertagnoli will come shortly. So we'll arm you with microphones, and our fellows are going to show 4 cases.
Jens, can I make a comment?
You can just switch fingers also. And we'll start with Mohsen. And I'll ask Dr. Mohsen Karami to come up first. So we're going to see there are no curveballs here. One case is unresolved, but these are not uncommon cases. And we just ask for your wisdom and just putting together the insights that we gained here. So Mohsen, take it over.
Yeah, thank you. Good afternoon. So can I see the slides here? So this is a patient of us, came here years ago, 27-year-old male, had back pain for about 18 months. He's like avid canoer, and then there was only back pain, there was no numbness or like kind of sciatica on the legs, no weakness on the physical exam. So you see here the X-ray and the MRI.
So, I'll have to steal a microphone. So not an uncommon situation. You can readjust the chairs as you need to. not an uncommon situation. So high-performance athlete has left side disc herniation with radiculopathy, and he has a pars interticularis defect. Maybe you can proceed one. We can fast track this a little bit. So he has a pretty much non-displaced L5-S1 spondy, and maybe advance the slide one more. So, and over time, he's been treated 1.5 years non-surgically, and this little disc herniation has advanced quite a bit. He's from out of state. This is a highly competitive athlete, and he's sought multiple opinions. So he has a relatively stable grade 1, I'll say 0, spondylolysis, and he has a progressive disc herniation. Again, this is a person with means, and there's a higher performance expectation from him, and the thoughts are, what do we do? So I'll start with Dr. Samdani. Dave Skaggs online, this is the latest version of medical publications, presents a lot of robotically guided pars repairs very early on, even for unilateral pars repairs. Your thoughts on spondylolysis being more aggressive about treating that now that we have better technology?
You know, generally, I would say I'm still not very aggressive with pars repairs. Obviously, in this population, once a child gets past about age 18 or so, for us, it's a decision between repair versus fusion. And I've done both. I am much more lean towards fusion, especially as a patient gets a little bit older. Certainly you could do a repair, but now you're looking at utilizing BMP. And if you look at long-term results, there's a paper out of Sweden, I believe, that looked at long-term results with respect to motion and degeneration. Probably not much of a difference. So I generally, even with the advanced technology, as a patient gets older, move away from pars repair and more towards fusion.
Chris, decompression only, and then we'll go for Dr. Theodora.
Yeah, I guess the whole thing about it is the comparison of his back pain and his leg pain. As you know, I'm a kind of a big advocate for pars repairs. I do a fair number of them. But my pars repairs are people that have a nice looking disc at L5-S1 who are usually under 30. And so you're pushing all the different envelopes on the different options. So if he had almost all, if it was 70, 80, 90% radicular pain, I'd probably do a microdiscectomy. There's a lot of people walking around who have a pars defect who are very active physically. A lot of professional athletes and whatnot have a pars repair, have a pars defect that doesn't necessarily have to be repaired. Now, if he has equal back and leg pain, then I'm on the fence. You know, I would probably, if it was something, then and likely he's coming because he wants to have a pars repair. I don't have a problem with doing a unilateral pars repair, putting BMP into the defect, doing the discectomy, and seeing how that goes. But I would agree, if this was the average person, I would say you're going to get a result more predictable with a decompression and, decompression fusion of whatever choice that you want to have.
Chris, is it unilateral or bilateral?
I thought,
It's bilateral.
It's bilateral. Then again, you can do bilateral pars repairs, but I'm going to tell you, he's probably going to do just as well with an L5-S1 fusion. Now, again, if this was a 27-year-old female, I might be thinking about doing an ALIF on there and just taking that piece of disc out from the front, really doing a wide, take down the posterior longitudinal ligament, take that piece of disc out and do an ALIF. Usually if you do an ALIF in the front, the back's gonna be done. It's not the posterior back muscle disruption. But I would be reluctant to do that in a 27-year-old male.
A lot has been made about him having this L4-5 early disc degeneration. So Rudy would call this probably a Furman 2 or 3. So again, this young, highly competitive athlete, world-class canoeist, was told by everybody, if he starts getting a fusion at 5-1, that 4-5 is gonna blow apart. So we are waiting for Rudy still, but Nick, so computer-guided Pars screws,
Yeah, I mean,
atrophic pars defect. Any role for that?
I don't think so. I mean, there's corticated edges there, they're separated. I mean, in the younger population, we'll get SPECT scan or some way to look, just to see bone scan, to see whether that's actively, in a healing situation. The separation there alone speaks that they're not going to get from a direct pars repair. I don't think you're going to have a good outcome there. I just think those pieces are too far apart, and I think the edges are too corticated. So, and you see that, again, going back to what Chris says, less is more. If the leg pain really is the problem, I do a microdisc, and then just wait and see how he's going to do. You do a fusion, you're putting him out of competitive canoeing for a while, and the reality is that if you do fusion, you do have that adjacent disease, which is already going to be problematic. So I think less is more. Treat the symptoms, and again, this has been there for a long time. And by this age, he doesn't have a significant spondy. So I think that a microdiscectomy is going to be the way to go.
Mohsen, you've been trained in Tehran, in Paris, and in Montreal. What would you have been told, or what would you have seen in your previous sites in this situation?
Obviously, it's very difficult to decide because, for the direct pars repair, the indication is like very, clear. There shouldn't be any kind of, disc herniation above and below. So this case is very difficult. If you want to only microdiscectomy, you make it more unstable and cause more trouble. If you want to do fusion, there's L4-L5, disc degeneration, so going to cause issue in the future. So this is kind of very difficult to decide about this.
So in our orthopedic boards, we used to have a time period where doing a discectomy in a presence of a spondylolisthesis, now this is spondylolysis, was considered a failure point when we had standardized cases. Rudy, you just joined us. Can you take a microphone? So briefly, high-class athlete has a larger and larger disc herniation at L5S1, no obvious major motion, failed non-operative care. He's tired of it. This is a typical high-end athlete, super high performance. He does not want a fusion. He was told he has that 4-5 early disc degeneration. He's seen multiple surgeons who've all said, with one endoscopy exception, they wanted to do a fusion on him. He does not want a fusion. What are your thoughts on how to help this patient?
Yeah, we have done many cases like that. Definitely, this is, for me, an ideal situation for a hybrid, especially if a high sport athlete, because pars repair at this age, when he's doing this amount of sport activities, will not work well. So we have tried this a couple of times. It's not doing so well, these patients. Maybe it's a young patient, then it's a different story. And because he is already an onset of L4-5 with a big bulge, for me it's a clear fusion L5S1 and disc replacement 4-5.
Amr, what were your final thoughts? Now you've heard some colleagues talk about this. What's your thought?
I had not actually appreciated the 4-5 issue as much previously, so I was really just debating between a repair and a fusion. I still don't think that a repair is going to work so well. I would probably just do a minimal discectomy and then see how the patient does after that.
And Nick, final verdict?
I'd say go low, just discectomy.
Discectomy. All right, Mohsen, take us forward.
Okay. So that was discussion with the patient and our thought as well. So we decided to do microdiscectomy and direct repair. So this is, the defect was almost there. So there was a scar tissue there. So we, first we put the screw and the hook and the L5, and we removed that scar tissue as you see here on both sides.
Actually, first we did a microscopic discectomy.
And then we put the screws.
We left as much lamina intact as possible.
Yeah, this is, the pars defect. We removed the scar tissue all the way down. And then after this, we put the autograft bilaterally.
So bilateral tricortical autograft.
Yeah, so this is kind of a pars repair we done, and we put the rod bilaterally. And this is the results post-op. And this is out about 6 months. The pain was gone, no more pain.
We did use off-label BMP. as well. So we did an open pars repair. We did these upgoing hooks and screws. We did a same incision tricortical iliac crest graft, again augmented with BMP. We started this with a microscopic discectomy, so he is fully back to everything.
So this is the construct that I use as well for a pars repair, but there's others that are using a direct screw across as well.
Yeah, once again, I think.
You come at the right time, Chris. So we did a pars repair with a microscopic discectomy. What would you have done for a pars repair? We did, if you go back a little bit, we drilled out the pars defect, the same incision, tricortical iliac crest graft, fitted that in. We layered onto it BMP and a small amount of local bone graft. We put the screws. That's a beautiful, beautiful shots. Thank you, Mohsen, for taking those.
So I do the pars repair exactly the same way, and probably, I do the pars repair exactly the same way. I think you and I started doing them exactly the same way about whatever it was in 1999. It's a very predictable, very rigid. I think it's more rigid than a single screw put across the pars. To Nick's point, with the very well corticated bone there, essentially you're going to be doing, you're going to take that down, put BMP in that. And with this, to Nick's point, you're actually able to get a pretty substantial amount of compression across that area that you can't do even with a lag screw. So this is the way that I do it, and including some very high performance athletes, and it's worked very, very predictably. And the other thing that's so easy is if it doesn't work, or if they re-break, then you just put a screw into S1, take that rod out, put another screw in, and then you've got a setup to be able to fuse it. So I think this is a perfect solution, a perfect opportunity. And the only trouble is, what's going to happen? What's the long-term results of the L5-S1 disc? And guess what? If it doesn't work, you send them to Rudy, or you have Rudy tell you how to do your arthroplasty there, right? Exactly. There we go.
That was a beautiful dissection that you did, by the way. Thank you for that. Sorry that we did not have a fiber optic light. So that case went very well. How far would you stretch this? I'll start with Samer. Amir, how far would you stretch this? Let's say this is a true grade 1 isthmic spondylolisthesis. This is a spondylolysis. Would you be still comfortable to do a pars repair there?
Again, just looking at the MRI scan and the way the disc looks, I generally tend not to go for the pars repair, even prior to it slipping forward.
Okay. Nick?
I mean, and once you start slipping, the cat's out of the bag. I think it's not the right operation to repair. And like I said, the ones who benefit from the single screw repair are the young, well-opposed, where the bone is next to each other, but it just hasn't quite healed. They actually do very well, but in this age population, you did the right thing. It's a great picture.
Great. Thank you, Mohsen.
Thank you.
Let's switch to Dr. Oliver Mrozinski.
All right.
Again, a neurosurgical colleague who's graduated recently, and he's returned to his residency location. And thank you so much, Mohsen, in Pennsylvania. And he's in beginning successful practice there, and he did a terrific job as of all fellows this year, as we could reflect upon yesterday. So Oliver encountered another pleasant case.
Very pleasant. Let's see if it works.
Yes.
Perfect. Awesome. Great. Well, thank you guys again. Thank you for coming and being here. It's always great, and it's so fun having this in person like this, so thank you again. This case, actually, Dr. Shaffrey saw this case already because he was at my residency graduation. He was our featured speaker, but anyway, so.
This is a great case.
Yeah.
So I will not comment. I have to actually head to the airport in a minute, but this everybody was blown away about what things are done here under his tutelage, under Jens and all.
That's right. That's right. Yeah, so this lady, she's a 45-year-old female, history of fentanyl, cocaine, nicotine, all the things necessary for good healing. Presented for months of progressive low back pain, lower extremity radiculopathy, and inability to walk. When she came to the ED, she had urinary retention, a Foley ended up being placed, and she was really unable to even straighten out her back because she had terrible back pain and radiculopathy going down both of her legs. Her exam was a little bit limited because of pain, but she was weak distally with her dorsiflexion, plantar flexion, and EHL. And then she did have some decreased sensation in bilateral legs in the L5 and S1 distributions. So of course, we got pictures. This was her X-ray. It was almost hard to believe what we were seeing. We ended up getting a CAT scan, and this was her CAT scan. So amazed that she still had strength and any sort of ability to walk at all.
So Amr, the term of spondylolaptosis is frequently overused. Is this a grade 4 or grade 5? What does this qualify
just
as?
looking at that lumbosacral angle, I'm going to call that a 5. I guess technically you could say maybe there's a little bit of overlap, but this is a severe, I'd call it a spondyloptosis.
So briefly, not going through the old Meyerton grading, that's too boring, but we have arrived at a higher level of differentiation of spondylolisthesis. Do you mind just very briefly going through what you look for now as an experienced pediatric spine surgeon? So there's some newer thoughts as to what to look for.
Yeah, so, for me, the main things are, is it overall a balanced spine? So I want to see the entire spine. I want to see full-length imaging. And then in my mind, the two things that I'm looking for, number one is the neurological deterioration. So for me, that's a key factor in determining, timing and the type of surgery. And then secondly, what our goals eventually would be. Now, this patient's 45 years old. I can tell you in the adolescent population, I'm generally thinking of a 4-to-1 with a sacral domectomy, inner body, and trying to reduce this. Not over-reduce it, but just to get the lumbosacral kyphosis corrected and get enough coverage 5-on-1 that you're able to get an inner body and to be able to get a fusion.
Chris, stand behind me. I want to take a picture. Chris has to leave.
Oh, yeah. Let's get it.
For faculty. Rod, can you come in? So, Chris.
We should get you in here, too. Yeah. Come on in.
Yeah. Take the microphone as we're taking our picture. So, Chris, I'll come next to you.
Yeah.
Chris, so you know what happened there. Apparently, you've seen this case during graduation speaking. It's an honor. Thank you. Oh, yeah. Okay. Ken. So, Chris, as he's taking the photo. So before you saw the resolution, apparently, deal breaker, what would you have done? Is this where we can evoke the spirit of Dr. Bowman?
The nice thing about this is, because this isn't a dysplastic spondylolisthesis, usually the dysplastic ones, you have a lot of rounding of the S1 end plate, and usually have very small pedicles of L5. These pedicles are a bit bigger. For me, anybody that has more than a grade 3, I'm automatically going to put some type of iliac or spinopelvic fixation. And the one thing that I frequently do is I will do, in part just because the angle is so difficult to get into, I'll probably expose this up to L3. So I put temporary screws in L3, L4, screws in L5, screws in S1, and screws in the pelvis. And oftentimes, because with these high-grade things that happen over time, you have to do a shortening or else you put too much stress on the L5 nerve roots. So I'm usually going to do a dome osteotomy on this. Because this is probably, because it's infection related, I'm going to probably do something, I may not have to do that. And sometimes on some of the x-rays, you'll see that there's more of a reduction. But if it didn't just flop back into place, I'm going to resect some of the S1 superior end plate to allow a shortening and a loosening to be able to go. I want screws up to L3 because I'm going to gradually reduce this back. I don't want to share the load across there. And I want iliac fixation because I don't want to have some fracture through S1, S2 down the road with that. I've had enough problems on some cases with that before. So I'm doing an exposure, screws in L3, L4, L5, S1, and then iliac screws, and then I'm going to gradually reduce that. Now, if I can get it totally reduced, I'm going to put an inner body spacer in at L5, S1, And if I'm able to do that, I'll take do all that, put bilateral implants in, then I'll go back in, and if it's perfectly reduced, I may either at that sitting just take the 3 and 4 screws out if I'm really happy, or go back in 3 months and then take out, fuse L5S1, take the screws out, including the iliac screws, because I'm a very young, active person. I prefer to get the iliac or S2A or iliac screws taken out. That's how I would do it.
Can I say something?
Of course.
Yeah, so we have done the big problem here, what I see, if you do this, the pelvis is retroversed. So this is the problem. That means if you pull it back, you have the same problem. You have to pull the pelvis forward. What we have done, we call it puppet on the string technique. Because here is easy to access. Here you have the vascular structure. We take out the whole vertebra. We do the pedicles from the back. We put a screw here. And with the screws, we had titanium wires. We had a block over the OR, over the table. And then we pulled the whole spine upwards. And we tilted the pelvis back. We use this bone graft. We have a big bone graft to put it in between, but we are shortening the spine because if you elongate it, you have a high risk of L5 root damage. And this worked. We have done about 30 cases.
So it's like a Gaines procedure. Like a Gaines procedure.
A little bit like that.
It's probably wherever he is got his hand.
Yeah, the only thing I would say about the Gaines procedure is we've actually done one at our hospital, and there's one done at DuPont. There were bilateral L5 palsies after the Gaines procedure, at least in our hands. So obviously, in Rudy's hands, good results, but I know for us, and when we went back in after the patient had lost their L5, I mean, those nerve roots were like strings. I mean, they were like guitar strings, that's how tight they were. So I'm a little bit against the Gaines procedure. I do agree with the concept of taking the sacrum and actually levering that down rather than trying to bring 5 up. So the reduction maneuver I do agree with, but I'm not as big a fan of the Gaines procedure.
That's what the iliac fixation is for, is to
Tilt it down, exactly, exactly.
That's part, you're doing both things simultaneously, then shortening off of S1.
Yeah.
Oh, sorry, shortening, and I agree totally with shortening, but in general, and this is a little atypical of a case, but your typical dysplastic spondyloptosis case, you're taking off the entire dome of the
It
sacrum.
all comes off, absolutely. The only other thing that I would add is I like to use neuromonitoring in this direct nerve stimulation at the beginning, and often it's going to be stimulating at 15 milliamps. And then as you reduce it and the nerve comes into view, the simulation starts decreasing, so.
All right, Dr. Theodore, you've been very quiet there. You've been rolling your thoughts.
Yeah, I think I agree. I would probably do what Chris would do. And I think that it's not really a classic case where it's a dome, but shaving off that super aspect of S1 is going to allow you to bring that back into. Chris said infection. This guy had infection. Okay, good. All right. But every risk factor for infection.
We thought it was
no
going to be
infection.
correct. Yeah.
Yeah, I got it. Yeah. I think that's the, and I like the idea. I mean, I always use neuromonitoring, but I like the idea of consistent simulation and see what you're doing, because the risk of L5 palsy
How
is high.
far do you want to reduce now? We don't reduce fully anymore, 50%, or what's your verdict? And maybe Amir can also speak.
Yeah, whatever you can get without, it's just one of those things that you're not, I don't know that I have a set number in mind.
Without taking anything away from Dr. Morzynski, and over here, Amir's thoughts also.
Yeah, no, absolutely. I mean,
She did not want to reduce.
No, I mean, I think you just got to get it to a grade 2, so you've got enough surface area for a fusion. Much more important is getting that lumbosacral kyphosis corrected.
All right, Oliver, take it from here.
Yeah, so I mean, for us, a lot of those points that Dr. Schaffer said in the beginning were things that we talked about and discussed before we went into it. There were so many learning points for me in this case. I'd never done such a high-grade spondyloptosis, and so many learning points, but one of the big ones was just the initial positioning. So, instead of doing an open Jackson, we actually put her on a Wilson frame to try and push and get as much back with the Wilson frame, which was initially pretty interesting to me and did help a little bit. And then the exposure was extremely challenging just because of that angle and everything else. We ended up doing L4 to pelvis, and we did the intradiscal osteotomies at 4.5 and 5.1. and then, fuse all the way across. And I think the big thing, and this kind of shows some of the intra-op photos, you can see some of the reduction techniques that we use with what we call a squeeze spreader. It's an intralaminar spreader. But we basically we did the initial cages at 4-5 so that we then had 4 and 5 as a single unit. And then we placed the S1 and pelvic screws first, and then the 4-5 screws were deep, obviously. And so then we ended up using 4-5 as a unit, using towers, and then reducing back up. And because we had that strong fixation distally, we were able to use that and actually reduce it back to basically normal alignment. And this is the post-op CT here.
And Dr. Samdani, so we did use monitoring. I have stopped using the direct nerve leads because I've just been frustrated by them. But we did have very sophisticated motors and SCPs, and they did decline after we expanded the anterior cages. So the reduction was well done. The whole time we saw the L5 roots completely loose. They were never strung tight. And then the signals went down. And what did we do, Oliver?
And then we just basically followed the nerve roots out all the way.
We drilled out literally the L5 pedicle.
Everything out.
Around.
Everything.
And we coated it, so she actually woke up how?
In a lot of pain, but she did well. I mean, her strength was preserved and then improved the next day even, which was pretty impressive. So we were happy with that. Yeah, she did. She ended up doing well. She was a big pain ball in the beginning, obviously, but.
She went home.
Yeah, she ended up going up. Yeah, so she went home. I forgot. I mean, she was working with addiction medicine and a bunch of stuff, but she ended up going home post-update 10. But yeah, she went home, walking, ambulatory. So.
I saw her on the street last night. She'll be back to see you.
Yeah, I'm sure she'll be back.
Clinics next week, so I can't wait to get a complaint about some numbness on her little toe or something like that.
Yeah.
And we stopped using the gains procedure also there. I saw one in my residency, and that was not so good. And so we stopped doing that. I don't know why. The L5 roots are so fickle there. Great job, Oliver, and it's great working with you. Thank you so much. You're outstanding, and you'll be a beacon of spine wisdom in Pennsylvania.
Well, thank you very much. I appreciate the kind words. Thank you.
Let's hit Dr. Amster Khan, maybe. So Hagai has a pediatric case, so get the microphone warmed up. But I think they'll also go to actually all of you. Hagai's going to spend another year with us. He's been outstanding. Again, the whole year, I'm repeating myself, has been really, really good. And this is something different now. We've covered the spondy from minimal to maximal.
Yeah, and now for something completely different. This is actually a case we just recently saw at clinic this week. We kind of talked about it internally, and we don't have a lot of good answers for that, so we decided to consult all of you guys as well. So this is a 15-year-old. He came over to our clinic because he received a recent diagnosis of scoliosis by his PCP. He has no symptoms. His exam is completely normal, no hyperreflexia, no weakness, no nothing. He did have a complicated neonatal history. He was born prematurely. He had a salmonella infection with suspected meningitis, a lot of lumbar punctures, a long NICU stay. Currently, he's a healthy 15-year-old, 6'4", swims for his high school team. And these are his Scoli films. Again, not very severe scoliosis, about 10 to 12 degrees, left thoracic curve. I'm sorry, right thoracic. On pelvic X-ray, we can see his wrist is about 4. But on his MRI, there were some more interesting findings. You can see him better on the axial views. But from about here, which is T3, he has this big syrinx going down. And then below that, then starts his diastematomyelia that goes down to about T11. The rest of his scan is okay. If we look at this lumbar scan, no tethering.
No Theodore shortening there.
Yeah.
And brain was fine, C-spine was fine. Can you go
Yeah.
to the thoracic sagittal again, just to show the scope of that cystic deformation and the diastematomyelia one more time? So any initial thoughts? Who wants to take a first stab at it? Amir?
Can you go ahead? It's interesting. I'm very used to actually looking at x-rays. If you put the plain x-rays up from the left side being left, but here it looks like a right thoracic, a very typical curve, does have a proximal curvature that's driving that left shoulder up. I'm just trying to think what could be potential indicators that there's something underlying here. Were there any neurological issues? Like how did this present?
Not at all, not
Not at all, yeah. The only thing that's very subtle here is that there does not appear to be any thoracic lordosis, meaning does not appear to be hypokyphotic in the thoracic spine, which can be an indicator that perhaps there's something underlying, but it's not very severe at all. It's very difficult to even gauge that they would have an intraspinal anomaly based off of those x-rays. The only thing that gives me a little bit of a hint is that sagittal profile, because it's, as you know, it'll often be lordotic, but that's not very severe. What prompted the MRI scan?
That's a good question. I don't know. His PCP saw the scoliosis. He got him an MRI and a referral to the spine clinic.
Yeah, well, fortunately, they did end up getting that. And it sounds like the MRI scan is showing a diastematomyelia with a syringomyelia.
The upper part.
And does and we have a CAT scan as well yet, or not yet? I think it'd be wise to get a CT scan as well, and we got some of our neurosurgery colleagues that
What
love.
about CT myelo?
Would get, CT myelo.
Yeah, I think a myelo would certainly be helpful. I think a CT just to help us decide if it's a type 1 or a type 2. Type 1 would be a bony malformation versus a type 2 that would be fibrous. And, in the past when I had a patient like this with a more severe deformity, I remember this was probably 2010, I didn't know what to do. Like, do you take it out? Do you correct the scoliosis? There's a lot of literature from China over the last 5 to 8 years. Shen et al. Have published, which they've showed, certainly for type 2, if you're going to do a deformity correction, you do not need to take the diastat out. And now there's even more literature that even for a type 1, that you likely do not need to take it out as long as you don't try to overcorrect the spine. So here, depending on what kind of symptoms the patient is having, I think that I don't recommend anything that would be a direct treatment for the syringomyelia. That what I'm balancing in my mind is, do you treat the diastat, and what do you do with the scoliosis, which is not very severe? And I'll kind of ponder that while the others, if they want to make some comments.
So you showed us some cool cord pathology. What's going on here? Why is this syrinx going on? What's the cord deformity and cord dysplasia?
Yeah, I'd love to see, like I said, I think the MRI scan unfortunately just doesn't do it justice. I think this would be a case I get a CT myelogram. I'd like to see exactly where the cord is and what's happening and where the morphology is. He's completely normal neurologically, and that's a curve that you wouldn't do anything about. I would watch this kid. I wouldn't do anything. And I think that, he's already 15, and I think, it may be much to do about nothing, to be honest with you.
So what are you looking for in the CT myelogram? Are you getting a delayed CT to look for a delayed fill of the syrinx?
I'm not looking at the syrinx filling. I want to see what's causing compression and where that is in relationship to the syrinx.
Rudy, we could have said that also, wait and see, right?
Yeah.
Okay, your thoughts?
The same. I don't think anybody would take a healthy kid with 0 symptoms to the OR. We invited him.
But now we know.
But now we know, somebody got this MRI and now we have this on our hands. I would follow up on him. We invited him for follow-up in clinic with a CT for the next time. Again, I'd follow up maybe closely for the next 2 or 3 years just to see that he's not developing any symptoms. I'll be careful to check his reflexes and get a more meticulous exam. After he finishes his growth, if that's all he has, then I wouldn't take him to surgery. I'm sorry? The C-spine is clear. Yeah.
So, pan neural imaging and CT myelo. I personally get a delayed study. Amr, if there's an accumulation in that cyst on the delayed CT, that 1.5 to 3 hour delay CT, would that change your opinion? Hydraulically active syrinx.
It's a good point, but again, in my mind, I'm just trying to play out what the indication for the MRI scan was. If there truly was no symptomatology and the curve is small, the risk-benefit analysis is probably going to be in favor of just watching and seeing if any symptoms or if anything develops, in my mind.
The only other thing I'll throw out here is the problem is now you know, right? So the next question is going to be, can he play football? And what, I mean, so that unfortunately, we've opened up a bit of a Pandora's box by seeing this at this point now. He's swimming. I would say continue to swim and maybe canoe. But I think I don't know about, you know.
Otherwise, we have Alaska Airlines flying directly to Philadelphia. All right. Oh, yeah, ask a question. Microphone, one second. Can I have a microphone?
I don't know. Can you hear me from here?
Oh, yeah.
Okay.
Yeah.
Thanks. So with Chiari's and Syrinx, you know, the Park Reeves have published on the connection to scoliosis, and treating it early before the scoliosis has progressed may potentially slow the progression of the scoliosis if you treat that Syrinx, essentially. So why would this be any different? Why would you treat the Syrinx?
It's a good point. I think just looking at the skeletal maturity, being 15, already grown, and we can look at what the Risser sign is, and the risk-benefit of a diastat and a big Syrinx, to me, probably be a little more conservative because the curves are pretty mild.
And this is this Syrinx is different than, I would argue, than the Chiari Syrinx, because we've seen in children that Chiari Syrinx expand rapidly once you've got complete, you know, cessation of flow at the foramen magnum. And I'm sure Amar has as well. I've taken care of lots of kids where we've done a Chiari repair and the scoliosis is arrested. Not in all cases, but in many. But in that case, that's more of a dynamic phenomenon. This, I would argue, is, you know, a congenital sort of fixed problem. Could this get worse? Maybe, but we're going to watch it. We're going to follow it. But usually the pattern of degeneration is not like it is with the Chiari. It's a little bit different pathophysiology of obstruction.
Yeah. So for my I used to do scoliosis surgery. So for the kids with this scoliosis, I do umbilical reflex. If this is the reflex is like asymmetrical, probably there is something Syrinx or whatever. So it's very important to do like umbilical reflex when you see a patient with scoliosis.
Great. Okay, Mohammed, may I ask you to come up? Thank you, Hagai, for putting this together. And Casey arrived also, so we have two more cases. We'll go for Mohammed first. Again, he's going to spend another year with us, but he's going to switch over to the cranial side. The dark side.
Yeah, the dark.
So Mohammed El-Hoshimi, and he experienced this case out of the treasure trove of our weekly surprises.
Yeah. Okay. Thank you all for being here. Thank you for the nice cases, nice illustration. This is a case, as Dr. Chapman mentioned. We got it when we were on call. Next, 40-year-old female. She's a Romanian housekeeper. She came to Seattle originally from Texas. She had a lumbar epidural abscess there, for which she underwent a wide laminectomy, and medical treatment was started. As per the history, which was not fully clear, she took the complete course of antibiotics and she was on oral Augmentin. Past medical history, as I mentioned, laminectomy. She came with severe back pain and difficulty ambulating. So this is her MRI on presentation. So in the ER, severe pain, so they got this MRI. We have L2, L3 completely collapsed with severe canal stenosis. This is the
How long ago was the infection?
The infection was like around 6 months ago. She was treated there with the laminectomy and medical treatment, and she was maintained on Augmentin, as I mentioned. She came to the ER just to refill her Augmentin, but in severe pain, so they did this MRI, and we ordered this CT scan. This is her CT scan. Near complete collapse of the L2, L3 space, severe degeneration, and grade 2 to 3 retrolisthesis of L2 over L3. On exam, severe pain, 4/5 all over, no bowel bladder dysfunction. She has some dermatomal deficits on the right side, L2, L3. As per the site score, this is the scoring system that we, the group here, Dr. Chapman, the senior author on this paper, we try to grade these site score infection similar to what we use in tumors, the SIN score. We got this site score. On neurology, the patient, she had motor dysfunction, so she's 1. Location is a mobile spine, 2. She had canal stenosis with impingement on the central canal. She took 1. Severe pain, axial pain, and for the comorbidities, she had surprisingly no IV drug abuse, no diabetes, so she took 1. As per the site score, her total is 5. So severe canal infection with high probability of instability in neural impingement. So we recommended surgery. So this is what we have.
All right, so epidural abscess does not seem to be ostensibly a high-risk patient. Nick, you've taken the microphone already, so.
I mean, the very first thing, just in this delayed presentation, just to make sure is SED rate, C-reactive protein, making sure that she's not actively infected. I mean, that's always something to make out.
The markers were high. Yeah.
Everything was quiet?
No,
high.
were high.
Oh, they were high.
All the markers were high.
Okay.
She has a large epidural abscess. It looks like a recurrent abscess. I'm wondering what went wrong in the first place. I mean, epidural abscesses.
Yeah, probably wrong antibiotics or multi-organism, infection potentially. So
Augmentin was not enough?
What? Yeah,
Augmentin was not enough?
Well, yeah, I hope she's on IV antibiotics. I mean, before I did anything, I think I'd biopsy, have radiology do a needle aspiration, and just, if we can get an organism, just to see, so we can make sure that we're on. I don't mind operating in the face of infection, but it'd be nice to have an idea of what organism we're dealing with.
No idea, because she moved from Houston to Seattle like fresh, and we had no access to her previous
I get
medical
it, but
record.
I mean, now that she's in the emergency room, her inflammatory parameters are elevated. So I would say getting a needle, a biopsy to see if we can get an organism.
I mean, what's the scoop on kids and endoscitis? It's very common. It's in principle a benign disease. What happens between pediatricdom and adulthood?
Boy, I want to be honest with you, it's not something that I'm seeing very commonly in children, but likely just more of changes in blood flow parameters that make one more prone than the other.
Rudy, do you want to take a stab at this? We have a dislocated spine now. We have neurology. We have a likely recurrent infection. We have a larger accumulation of some soft tissues in the epidural space also.
Yeah.
Maybe not.
No, I would do, in these cases, we have done an anterior vertebrectomy so that you come to the healthy bone. You put a lot of solmecine foam around it, and also do, because there is obviously some pus in the back, go also from the back, put pedicle screws, rinse everything, and with solmecine you can work pretty well when you resect the whole, because this anterior part will never heal well because you have the disc debris, and this is a very common location that you have all the time a slow-grade infection in this disc material. So I definitely would take the disc out from the front. I do a lot of front work and
Nick, you
make it
elegantly
easy.
punted by deferring to aspiration, but now the patient has had it.
Okay.
And,
Do you have any organism? Do you have any organism?
Not really. It's
Okay.
it's just pending.
Yeah.
The patient's in more and more pain. She's laying on her side. This is the Chapman test. She's laying on her side, embryonic position.
Yeah.
Does not want to be rolled. Does not want to get up. Doesn't do anything. A brace lays discarded in a thrust of fury against the window.
Yeah, I mean, I think surgery, I mean, I like Rudy's approach. You could think about getting into the disc space laterally and just cleaning the disc space out, putting an interbody in and infusing her posteriorly. You can do that in a single position, which may, just collapse the operative time.
Want to show?
So
There's a
this is
smile
what-
on Mohammed's face.
Yeah.
Because there's a wrinkle coming.
Yeah, so this is what we did. So our
Can we switch?
famous spreaders, we took her down bilateral IDOs. We washed the disc space. We used here like 9 liters. We used the thoracoscopic irrigators. We cleaned her up. We did a quad-rod construct, short segment along 2-3 bilateral expandable cages, and a spanning rod from 1 to 4. This is our final construct. This is our CT scan.
So now I want to fuse her T10 to the pelvis, which is, and nowadays we try to not resect all of the vertebra anymore. We try to literally go back to stable, reasonably well-perfused appearing bone. It was very cool to have Dr. Raja Sekharan from the Coimbatore, India, Ganga Hospital here the other day, and he talked about TB in the spine, and without ever coordinating with him, he had the same opinion. We don't resect the whole vertebra anymore. We had trained at a time where we did full corpectomies. This is no longer necessary, so a limited debridement corpectomy and limited
Cultures,
fusion.
yeah.
And cultures came back.
With TB?
TB, tuberculosis.
There you go.
So she's a Roma from Romania. And that's apparently, our epidemiologists had all the data endemic in the Romanian Roma population. So
And apparently augmentin doesn't work for that.
I have not heard that. When we had Raja on in his brilliant lecture, which I highly recommend everybody to watch. I mean, the guy is brilliant, not just surgically, but microbiologically and mechanics. He basically put biomechanics, microbiology, nutrition, genetics, all into one lecture. It's truly, right, Rod? This is amazing to watch. Raja, he's going to come here for our spine trauma meeting. Yeah. But yeah, so TB, so now we all get tortured by our infectious disease people because we were all exposed, like 100 healthcare workers.
Yeah.
Any thoughts from your end, Mohammed?
Yeah, the thing that I would agree with Dr. Theodore, we would have biopsy, in Lebanon, we would have biopsied and gave her like a trial of treatment. She was in severe pain, but she's still moving. So we maybe like gave her like a few days of antibiotics before taking her down.
I mean, again, it just gives you another piece of information. The good news is it was not an emergency. And, it may tailor the way you do things. And then you can actually start treatment before you, but it's not always possible. So, but this, you can't argue with the outcome, so.
She actually had pretty good bone purchase. So
Yeah.
the reduction through a short segment fixation I love these quad rods, so they do give us a far better mechanical stability. And yes, we used off-label BMP. Thank you, and
Thank you
such a pleasure to work with again.
Appreciate it. Thank you so much for this
Mohammed.
nice course.
And Ruth could not last. I still want to be adopted by your parents, so I get your last name. Okay. They're wonderful to meet them last night. Casey Spinelli from Corwell Health, formerly known as Beaumont, neurosurgeon, colleague. He'll be brilliant. He says to finish his residency, but he'll be much sought after, and has also published a nice article about paraplegic patients and return to sports. And he has a deformity case, and Dr. Shafri has left, so we'll have to torture our 3 colleagues here.
Okay.
Casey, take it.
Dr. Chapman, thank you for the introduction. Bear with me just a second here while I'm getting this case pulled up.
When in this institution have you last seen a tuberculosis patient?
Actually, about a year earlier, that's very reassuring to hear, by the way, a senior cabin steward of a larger cruise company had a destructive discitis osteomyelitis that was TB. I'm a TB magnet. In my Harborview, it always amazes me how institutions handle this differently. In my Harborview days, we had it very regularly, a large Pacific Islander population and Far East Asianers. At Harborview, it was just like another infection. At UWMC, when I dared to take care of 2 TB patients, one was a physician, by the way, a surgeon who had been infected in there. They literally locked off, this is not a joke, a section of the hospital, put a hermetic air seal on. Troy, were you a fellow then? They locked off 3 ORs and a separate hallway. They brought this patient down in an air vac bed, she was in a separate section of one of the floors where they had like this is a precursor of COVID, high maintenance thing. We asked Raja that, and he basically said, if there's no active open pulmonary TB, so get a chest CT, you don't have to do anything.
When the Iron Curtain was opening in the 20 years ago, we had in the week we had 2 or 3 tuberculosis cases coming from Romania, from Bulgaria, from Russia.
Wow.
All right, Casey.
Wow. All right.
On that note,
I realize this is the last case between us and the conclusion of our day, so this will be kind of quick here. But this was a 75-year-old female who we saw in Dr. Chapman's clinic with progressive neck pain, difficulty ambulating, some falls, and kind of like we mentioned earlier today, she couldn't look straight ahead, right? She had this humpback with difficulty lifting her head and chin on her chest. Medical history for osteoporosis on anabolics, and a surgical history of a C2 to T2 for this chin on chest deformity 2 years ago at an outside hospital. Said she didn't smoke, occasional alcohol use. Kind of notable from her exam here, some weakness in her hands, as well as some dermatomal deficits in the C8 and T1 distributions. And so at some point we had the pictures of her original x-rays before this operation, but didn't have them now. But this is the imaging. Hey.
What went wrong? Who wants to take that on? We don't have Chris anymore, so there's no hiding. Amr, do you want to take a shot at that?
I'll take a step. Obviously, I'd love to see the full spine x-rays to see what the overall alignment, but there's pull-out, it looks like, of those distal screws on the bottom, to at least what I'm seeing from that x-ray.
You also developed a fracture on the
Yeah, there's a compression. It's like a flexion extraction injury.
And so this is a CT scan of her preoperatively before our case, as well as some full body x-rays here.
So nobody can send the patient to Duke now, so that flight's leaving. We could put him on a video chat, but here we have a full-length film. So thoughts? I know it's an adult patient, but I'm not going to let you have to impersonate Chris now.
Of course. The nice thing is in adult deformity, there's really never a right answer, so I can pretty much say anything, and people will at least consider it. Anytime I look at a deformity, the first thing that I think about is the rigidity, and I'm looking at that position right below where things have pulled out. And can I see that CAT scan one more time?
Yes, sir.
Yeah. So, and that surgery was done how long ago?
I believe it was about 2 years prior for that
2 years prior, yeah. So in my mind, I'm just trying to assess if there's any flexibility in that deformity. I'm assuming that there's not going to be any. Is that fair?
I like to do a test called the recumbent test.
Yep.
When I see a patient in a forward bent posture, I lay them flat on the exam table, very simple, and make sure the hips, knees, ankles all straighten out, and then I put my hand behind their head and basically ask them to do self-meditation and see whether they're flexible or not.
Exactly, and I'm assuming that this patient will not be.
Was not.
Yeah.
All right, so what do we do? Ready?
Any injections? Do you want to talk about? No, not even go there. Okay.
Nah. So this patient, we ended up taking back for removal of hardware from C2 to T2, decompressed from C3 to T4, intradiscal osteotomies from T1-2 and T2-3, and then Ponte osteotomies kind of the rest of the way down. Here, I'll put up the images while I talk about it. As well as some cement augmentation at these T10 and T11 levels. So this is what the final films looked like here.
So that cement distally, that's something you never have to do, right, Amar?
Except in our OI, we don't use it, but in our OI osteogenesis imperfecta patients, some people would consider.
Now, Rudy, I saw your amazing pictures in your deformity cases in that second lecture of yours. Did I see some cement in some of those vertebrae?
Yeah.
Tell us about that.
This is what we call EMP, augmented motion preservation, because this is allowing us also to include patients with a T-score. We already did -3.8. That was our lowest core, because it's what we call as a local bone density booster, and we used a glass ceramic cement, so a bioactive cement, high viscosity, and that allows us to use a disc prosthesis also in osteopenic and closely osteoporotic patients. And we have very good results with that.
Great. You put that into the screw tract?
Yeah.
Okay.
And because we are going from anterior, we do an antegrade vertebroplasty.
Oh, wow. You got to have a whole course on that. You come from a major center there. I've been honored to be a guest professor there. I was amazed how busy and large that center is. What would you have done? And one of the specific questions that's unresolved in my textbook is how low do we go? We've had a whole session about distally, and I'll ask you in a second, Nick. How low do we go to not have this immediately fall apart?
Yeah, I agree with that. I think, back home it would be a mixed bag as opposed to how low to go for this. We don't do as much of this big deformity on our neurosurgery spine service as the orthopedic spine service back home. But I do think that if they did do it, probably would have been more of a T2, like corpectomy, vertebrectomy situation, as opposed to this 2 separate level intradiscal osteotomy that we did here, which worked well.
I think, what do you think? Because I think in this case because you stopped at the apex, it's pretty dangerous. Because normally you should go here, the neutral vertebra.
I did not want to go down to the lumbar scoliosis.
Otherwise, this will.
We need Chris Shaffrey here for this one, but somehow, call me a chicken, call me lazy. I did not want to do a C2. And by the way, you can see there's some vertebral artery asymmetry, so we had to do a translaminar screw on one side. So just to add its complexity, I did not want to do a scoliosis correction down to the pelvis on my first go, but we had a whole session with Sig Bervin, and I don't know who all was there, about how low to go for distal junction failure avoidance, and nobody had the right answer. A lot of people wanted to go to the pelvis, and sorry. This was long enough, 8 hours or so.
Yeah, long day. Cool.
Nick, any thoughts?
Yeah, no, I mean, I agree. We just don't know enough. I mean, it's interesting, because it's not just the sagittal plane, but the coronal plane. So you're right. If you're you either go big or you don't. And if you didn't, you'll have to wait and see how she does. But and her bone health was optimized or is optimized?
This is the usual battle. I think we gave her stuff. At this point in time, I forgot what we did there exactly, but we have an ongoing struggle. This for me is frustrating because there should be a systems answer. Yeah. And we had an actually nationally recognized bone health physician who, right, Rod, was so overbooked. We literally had to call him personally and beg him to try to take an extra patient. And the fights with insurance companies here in the Pacific Northwest are very, very significant. This is, again, this should be talking about machine learning.
Yeah.
We should have incidental bone readings from CT scans, like from chest CTs, that basically put a red alert out, and these patients should be sent to PCPs.
That also then tell you what to order. I mean, that's all cooked.
Algorithmic.
It should be that way, right? Everybody gets afraid of ordering these medications. I don't think that's, so we're looking at that now too, because we have the same problem in Phoenix. It's difficult to find somebody to see them. So we're actually training a nurse practitioner to be able to do that, because it's not rocket science.
How's it in Michigan? Is that easy, bone health?
I would say on our inpatient service, we don't really encounter that much, right? I don't know, managed more in the outpatient setting than that, but.
But she actually did pretty well, right?
Yeah, this patient did well. I mean, she left on post-op day 5 from the hospital. For an older patient with this kind of surgery, is pretty decent.
Good.
How long was she in the hospital?
5 days.
5 days.
That's it.
Yeah.
And what was her view of what was her view of the outcome? She can now look, what?
And she was very happy with that I remember, yes, she was able to swallow again. These people usually can't swallow anymore and aspirate and are in misery. And we have a whole non-operative program for these people, but again, the optimization at some point in time hits a apex of futility.
And you did laminectomies also in the cervical spine?
Yeah.
Because it didn't look like there was much compression. I was just curious.
I want the core to fall back.
I see.
This is I think, I don't know how high we went, C5 or so, C5 to T, whatever, I forgot. But we did a several level laminectomy. So when I do these, I try to have 1 or 2 levels runway for the core to fall back. So, yeah.
Cool.
It's beautiful.
So far, so good, yeah. We had pulled that up for Chris, but then I didn't know that he was leaving. Otherwise, I would have pulled you up first. But thanks for coming back, Casey.
Yeah, cool.
And that's it. We'll put up our laptop. A round of applause, please, for our fellows. Thank you. Thank you, Casey. So, Rod, can you join us up here? And can our distinguished faculty come up here also? And we'll flash up the going away sentiment. Amir, Nick, come on up, please. And Rudy, yes. So here we are at the conclusion of this. This was a reincarnation of Rod's initial Masters of Spine Surgery course, Legends in Spine. And again, this was the master, our master Jean Dubussy, who right next to Patrick Johnson said, what you give to others belongs to you forever. What you do to yourself is lost forever. So keep to yourself is probably what he meant there. But Jean was kind of the inspiration. He was the first big master. Switching to this 4 Legends thing was personally so enriching for me. We had stiff competition with Norway versus England. What's going on right now, UV? Do you have an update?
2-1. England won.
England won. But this was a picture by somebody watching in Austin, Texas, that showed Chris Shaffrey and the game going on. So we had stiff competition, despite we're very blessed with such a great presence here. I was, and Rod, we were so blessed, and I think I speak for all of you, to have these Fab 4 here. I'm not going to reiterate all of them. You've seen how well they presented what they're passionate about, what they're so knowledgeable about, which is such a rich gift for all of us. The simplest program planning ever. Talk about 2 things you really like and show us something in the lab. And that's it, end of story. And what is not resolved yet, and Mr. Viscogliosi was so eloquent about that, is what's best for each patient. Is it the fusion that occiput the pelvis, or is the principle of life is motion, motion is life there? For all of those who've not seen the triple presentation of an evening with a spine surgeon, we had, for the first time ever, 3 non-spine surgeons there. And it was so cool to hear how their passion for quality research changed our practices by actually enabling us in this country to put motion-preserving technologies in there. So a grateful spine is what we all look for, and some fuse, some rubber band, some use robots, some don't. And this is the beginning sentence. That's the greatest room in the world is a room to improve, and the Fab 4. Round of applause, plus Chris. Led that magnificently. So I'll turn the microphone over to others, but this was so inspirational. All of you have been so fantastic. Can you put the slides up again? I have a grand finale slide. So, Rod, say something.
I mean, honestly, Jens, it's a great summary that you did. And you know, we got Jean Dubussy to come the very first time we did it. And Jens actually did his residency in Texas, so they had a long relationship. And you know, it's been great, and it's awesome having these guys here, and we learn so much every year. So thanks again, and thanks to all the sponsors. I don't know if Amir and Rudy and Nick want to say something.
guess I'll kick it off, and I'm sure the others will follow as well. Truly tremendous course, and I mean, two people who are so dedicated to education. I mean, so passionate, so much time that they're taking out of their personal lives. So I think we should really give these two a big round of applause. And just to say, I mean, every single course, I feel like the ones that I value the most are the ones where I feel I take some pearls back home and incorporate into my own practice. And I can certainly feel that I'll be doing that from what I've learned from everybody in here. So thank you.
Thank you. Thank you for coming.
Yeah, I can also finalize that I'm also pleased to travel half the globe, and it was worth it, even if I'm a little bit tired now because I feel the jet lag now. But I learned a lot, and I thank the great organizers, and thank you, Jens, for inviting me live here in this beautiful facility and great workshop, and I hope that I will come back soon.
Yeah, I think it's been said, but there's so many avenues for learning around. There's so many meetings. I think Chris Shaffrey left actually to go to another meeting because he's at every single meeting in the world. But what I applaud these two gentlemen for is really bringing to the masses having these things on YouTube, having these things on ViewMedi. I can't tell you how many residents, fellows, has always saw this talk, I saw that talk, and it really has changed our field. Without leaving Seattle, you really have made such an impact nationally, internationally in spine. So for that, I think we were very thankful, and it's fun to come every once in a while. I noticed I didn't have my name on the stars on the floor, and you told me it's because I didn't come enough. I think the last talk I gave for you guys was virtual, but I have to applaud you because the format's amazing. The banter is amazing, and as Amr said, and Rudy said, I'm leaving here better. So
You
thank
pick
you.
your spot on the floor. We'll put a star there for all of you. You certainly deserve.
You just want to be able to walk on me.
We applaud all of you for pioneering, perfection, and passion. Triple P.
What about the three bones?
That's okay. Let's rehash that. Okay, so there are three bones that we all have to have. As spine surgeons, the first bone is the
You have to have a backbone.
backbone. It has to be flexible, not always rigid, okay? Flexible. There are two flexibility proponents here, but strong also and straight. That's the first one. What's the second one?
It would help to have a funny bone.
No, you gave away. It was supposed to be the wishbone, the optimism, the looking forward to the future, the wishbone. Rod, I'm not going to do a stand-up. Okay, the wishbone is the second one. And the third one is to have a funny bone. And this is, again, you got to see everything with a sense of humor, or as the Austrians would say, a schmäh, right? Yeah. So you got to have a little bit of a schmäh component to it in terms of don't take it all too seriously. And all of you have also really provide an entertaining and highly humanistic approach towards what you've talked about. So thank you, and thank you on behalf of SSF for contributing so frequently. Amen.
Thanks, brother.